Good morning, everyone. Welcome back to day 2 of ADO 2023. I am Dr. Saima, postgraduate at Daikon Hospital. We'll begin the scientific program with Insulin and Incretin Symposium. To chair the session, I would like to invite Dr. Divyata Arun, consultant diabetologist at Manipal Hospital, Yeshwanthpur, Bangalore, and Dr. Kiran Nidagundi, consultant diabetologist at Shubham Diabetes Center, Bangalore. Welcome you, sir. Welcome you, ma'am.
Good morning, everyone. We will now begin the symposia with the topic, insulin co-formulations, clinical attributes beyond efficacy. To enlighten us on this, I would like to invite Dr. Ganapati Bantwal, Professor and Head of Endocrinology, St. John's Medical College, Bangalore. Over to you, sir.
After sir. Yes. Right. Yeah, right. Okay. Good morning, all. I would like to thank the ADOR team led by Dr. S.R. Arvind, Dr. Krishna, and Dr. Sanjay Reddy. So in the next 15 to 20 minutes, I'll speak on insulin co-formulations. What are the clinical attributes beyond efficacy? So this is my financial disclosure. So now there are some key challenges for diabetes management. This is in general. One is poor glycemic control. You find that at least more than 75% of the people with type 2 diabetes fail to achieve an A1C less than 7%. Indians, we predominantly have postprandial hyperglycemia, so that's suboptimal. And there's a therapeutic inertia also. 10% of adults with type 2 diabetes receive an injectable treatment after 10 years of insulin, of diabetic duration. Non-adherence to therapy is another problem. You have polypharmacy with diabetes, and that's why more than 50% of the participants were non-adherent to anti-diabetic medications. And another major concern is hypoglycemia. So adults with type 2 diabetes have an estimated 3.4 severe and 14.6 non-severe hypoglycemic events per year. And the moment you find that hypoglycemia happens, they start taking the medication less frequently, the A1C increases. I always tell in my slides, insulin is the definitive treatment for all types of diabetes, whether it's type 1, type 2, type 3, or the gestational diabetes. For all of them, you can use insulin. So need of an insulin therapy that offers lower hypoglycemia, mealtime flexibility, simple regimen, convenience of device, better quality of life, and cost effectiveness. So is Idursulfase a prudent choice? So let us see, because we have to see that it should control fasting, postprandial, and A1C also. Now, what is this co-formulation? So you have an Idursulfase. So you have two mixed composition. Here you have ultra long-acting degludec, which composites of around 70%. It's in the form of a dihexamer. And then you have the rapid-acting aspart. The people always ask this question now, how are you sure that this is 70% and this is 30%? They have done SEC, the size exclusion chromatography, after you have shaked it properly, and you always find that it is always in the ratio of 70-30. Unlike sometimes in the NPH or, for example, in the pre-mixed, say, insulins, sometimes if you don't shake it properly, you find that sometimes you find the short-acting component being more, and sometimes you find that the long-acting component is coming less, but that is not so with this. So the two components do not interact in the solution and in the subcutaneous tissue, thereby retaining their individual properties. So this is what they have found. So once you give a dose of that, you find there is a peak, and that's the aspart component. And then you have a flat stable component, and that's a degludec component. So this is when you give 0.6 units per kg body weight. Does recommendation by the RSSDI, ESI say, can we use this? Yes, it can be used as recommended as a choice for insulin initiation, but then avoid using insulin as a threat, elevate patients' anxiety about insulins, and insulin therapy should be considered in all patients failing to achieve glycemic targets on 3 oral agents. So you could begin with once daily, and then for intensification, twice daily with a single device. What are the evidences with that? A lot of phase 3A and phase 3B study. So you have for type 1 diabetes, the basal bolus, the intensify premix, start one, Japanese one, and then phase 3B, twice daily versus basal bolus. A lot of trials, you can see many of them being there. And so it's not only RCTs, you also have real world evidence, which have backed the efficacy and safety of Idursulfase. A lot of them even from India, from Kalra, then I think you have from Gangopadhyay, Rajiv Kovil, etc. Now coming to the efficacy with Idursulfase. So this was one study where they compared Idursulfase versus basal insulin, 147 patients, Idursulfase once daily with OADs and with glargine plus OADs. So what they found here was a superior 1.4% HbA1c reduction, similar fasting plasma glucose, 70% basal component, and more significant postprandial control. That's because you are having the short-acting component also. So the Idursulfase provides superior long-term glycemic control compared to glargine U100 with similar FPG reduction. Insulin initiation with the insulin degludec, insulin aspart versus glargine in oral anti-diabetic drugs failure in a real-world study from India. So here they took participants who received, who were uncontrolled on OADs. One group received Idursulfase, the other group received glargine. So what you can find here, it provides significantly greater glycemic reductions in A1C. Numerically, you can see here, fasting was better with Idursulfase, postprandial naturally better, 20 versus 41, and A1C reduction was better with this. Efficacy by prior treatment subgroups. This is the SAI study. A subgroup analysis was done from the Indian cohort. So 185 patients were there. And here also you can see that up to a decrease of 2.1% A1C was seen. This is when you started with a baseline of around 10.1. So if the patients are already on basal and then you switched over them to Idursulfase, you got this much benefit. Only on OADs and you started them 1.9%. If they're on GLP-1 and put them on this 1.7, basal bolus and you added this 1%, premix, and then you got 0.9%. So the mean at end of study, 141 from 190 at baseline. So that's how it has come down. And the change in fasting was around 52 milligram. What about hypoglycemia? Yes, so what you have learned is it is efficacious. A1C reduction is quite significant up to 2.1 when Previously, they were on basal, and then you switch to this. What about hypoglycemia? So, a little bit about hypoglycemia. Fear of future hypoglycemic episodes is common in people with type 2 diabetes. The moment I start them on insulin, the first question, will I get low sugars? The sugars may be around 14% HbA1c, but they are concerned that will they get low sugars. So what happens after a severe episode? 85% experience fear of future episode. It's very devastating. That's the reason. After a mild moderate episode, 30% experience fear of future episodes. After an 16% skip anti-diabetic medications. Due to fear of future events, 37% report decreasing their insulin dose and 11% report missing insulin injections. What about in the ARISE global cohort? So 4 weeks prior, you had 364 episodes, and within 4 weeks prior to end of study, you found it has decreased by more than 50%. What about severe hypoglycemic episodes? I think more than 20-fold decrease. So treatment with idagasp resulted in lower number of non-severe and severe hypoglycemic episodes. Reduction in hypoglycemic episodes in the SMART study confirmed hypoglycemia. You can see 176 number of episodes came down to 11 at the end of the 4th visit. This is in the SMART study. What about severe hypoglycemia? From 24 episodes to almost none. So you can see one of the very good drugs. If you use it appropriately, the risk of hypoglycemia is low. It doesn't mean that it does not produce hypoglycemia. It will produce, if you give excess dose, it will produce hypoglycemia. People have an impact that, okay, this does not produce hypoglycemia. No, insulin is insulin. It will produce hypoglycemia. Simplicity in dosing regimens. See, normally what happens, we start with OADs, basal insulin, OADs, basal with, basal plus, basal, you add 2 more times boluses, basal bolus therapy. This is how it is. Whereas if you're using this idagasp, you are on OADs, start with once, second time, 2 times, and that's it. You have intensified the regimen. So the next question comes, if you use twice daily versus basal bolus, which is superior? So a study involving 532 patients uncontrolled on basal insulin. One group received idagasp OD plus OADs, glargine OAD with idagasp plus OAD. The initial 26 weeks was that. And then they gave idagasp twice daily. And the other group received glargine plus aspart once, twice, or thrice daily. So 26 to 38 weeks. So what here they found was idagasp achieved similar improvement in fasting and A1C compared to basal bolus therapy. 9% significantly lower dose with idagasp versus glargine with aspart at end of study. Fewer mean number of daily injections with idagasp 1.6 versus U100 glargine, which was 2.9. So how do you switch from idagasp to idagasp from other insulin regimens? Suppose somebody is on a basal or a premix once daily. You use idagasp once or twice daily. You could begin with once and then make it even twice. If the patient is already on basal or premix more than twice, you use this either once or twice. And if the patient is on basal bolus, you make it twice daily, idagasp. So switching needs to be individualized based on careful consideration of basal bolus doses. Choose blood glucose monitoring as required. What about quality of life? So we found the efficacy, hypoglycemia events are lesser. It's simple regimen. What about quality of life? So switching to idagasp is associated with a lower total and basal insulin dose requirement and significant improvement in quality of life. So you can see here, 75% preferred idagasp compared to the previous regimen. So here you can see significant reductions in basal and total insulin dose with idagasp after 26 weeks. And there was improvement in total quality of life score with idagasp in patients with A1C more than 7%. Impact of quality of life and treatment preferences. This was a single center survey. Adult patients treated with idagasp, 26 questions involving 245 patients. So what they told, 95% told they manage their day-to-day activities better with idagasp initiation. 90% told improved quality of life with reduction in the number of pricks. And around 87% found it comfortable to inject idagasp in different social situations. So there was a reduction in number of injection pricks. Flexibility and simplicity of dosing with ida-gasp translates into better quality of life. So this is from Indian study only by Rajiv Goel. What about reduction in pill burden? So the same study, once again, subgroup analysis. So there was a reduction in pill burden with ida-gasp initiation. 70% of patients on 3 OADs could be shifted to 1 or 2 OADs. 50% on 2 OADs a day were shifted to 1 OAD per day. So reduced pill burden improves quality of life and adherence to treatment in individuals with diabetes. What about dosing flexibility and convenience? Start with 10 units of ida-gasp OD, administer with any major meal. That's very important. So with the most carb-rich meal of the day, that's the best time to initiate. If you're using it twice daily, administer it 2 times with the 2 most carb-heavy meal of the day. So meal size and postprandial glucose response should dictate the ratio of the 2 doses. It doesn't have to be 1:1. So suppose somebody is on 20, you want to make it 10-10. It's not necessary, it should be 10-10. It could be 14-6. So depending on how much is the carb meals, you can actually decide. And the dosing, actually, suppose you want to increase, and that is decided by the fasting. Rarely, sometimes if the patient is on an SUs also, then you may get a pre-meal hypoglycemia. That's the time when we actually reduce the dose of ida-gasp without consideration to fasting glucose. How do you titrate? If above fasting, add +2. If at target, maintain the same dose. If below target, -2. So this is what I told you how to adjust. Now the device, how do you find it? So you have what is known as the flex test, a disposable insulin pen, no push button extension, unique injection mechanism, very low dose force, end of dose click, accurate and consistent dosing. So here there is a catch here. So once you turn it, you press it, you'll get another click telling that you are given the exact dose. So that's important. Unlike the Novo pen, what happens, you press it, it should come to 0. There's not, the second click is not there. Here you have another one. Novo pen 4, yes, accurate dose delivery for more than 5 years, low dose force to inject, every dose adjustment, easy to read, dose scale, quick and simple to use. What about cost effectiveness? This is a study done in India itself. So overall, they found that yearly total cost of medication and healthcare resources based on Indian cohort. So yearly total cost, including that of medication, healthcare resource, was lower with ida-gasp as compared to all treatment by around 3,000 rupees, 2,955.83. The number needed to treat to bring one patient to target of A1C less than 7 and less than predefined individual treatment target was lower with ida-gasp than contribution of all baseline treatment options. So it is cost effective also for people with type 2 diabetes not achieving glycemic targets on other therapies in your routine practice. Yeah, the advantage versus the premix is you could go up on the doses without fear of that hypoglycemia because that peak effect is not there. You go up titrated, reach the fasting normal, automatically postprandial becomes normal. So is it a prudent choice for Indian scenario? Yes, lower risk of hypoglycemia, mealtime flexibility, simple regimen. In the mealtime flexibility, it is not necessary that it should be morning and in the night. You could even give morning and before breakfast, or before breakfast and before lunch also, or before lunch and before dinner. That's also fine. It's a simple regimen, convenience of device, better quality of life, cost effective, and plus it's an effective glycemic control. Controls fasting, PP, and A1C. Thank you for patient hearing.
Thank you, Doctor. Sir, any questions from the delegates? Thank you, sir. If there are no questions, we'll move on to second talk. So the second talk will be on once a week GLP in practice. To talk on this, I would like to invite Dr. Arpande Bhattacharya, sir, who doesn't require any introduction. He is a consultant endocrinologist in Manipal Hospitals, Bangalore. Over to you, sir.
Thank you very much. Thanks, Adore team for inviting to talk this. incretin insulin symposiums. After insulin, we listen a bit of incretin. This molecule, which is once in a week GLP-1 receptor analog, is there with us for a long time, nearly 10 years, I believe, maybe a little less than 10 years. So it's not that how it works, what are the molecular structure I'm going to tell you, it's just our idea that where you can put in our clinical practice to improve the quality of care, obviously by improving the glycemic control. Other than the glycemic control, a very important point in treating people with the type 2 diabetes is that taking consideration of the benefit of the cardio-renal metabolic benefit. And that's what we are going to do, which we do not get with insulin, good for glycemic control, but not for any extra cardiac protection. And that makes actually a big debate that once your people with the type 2 diabetes, once you have decided that tablets are no more working, which should be the first, get the first injection? Is it a basal or co-formulation or premix insulin, or is once in a week GLP-1 receptor analog? So this is what actually I wanted to be very, very straightforward, but certainly I would not try to like to this. Look at this one. For those who don't want difference between a crocodile and alligator, the crocodile is the one next to the alligator. This is wonderful English language to confuse you what it is. So I don't want to be doing like this. Okay, so our cardiovascular disease, atherosclerotic cardiovascular disease, the mode of exit, 2/3 of the people with the type 2 diabetes is atherosclerotic cardiovascular disease. Whatever we do in treatment of the people with diabetes, we need to look into that. The important point to notice is that from the diagnosis of diabetes, as the time goes, your problem goes up. But this actually starts with the pre-diabetes. This is very, very important. This is very unlike to the microvascular complication like retinopathy, nephropathy, or neuropathy. The cardiovascular disease problem starts from the pre-diabetes. We need to start very early, people with the risk factor even. And also, different studies have shown very clearly, even if you try to control very strictly the glycemic area, you do not really prevent much of the cardiovascular. Although UKPD's continuation of the study showed some benefit, but that's an extension trial we need to remember. Now, this particular one, if we control conventionally, HbA1c less than 7.5 versus intensive 6.5, I agree that it comes down from problem to this, but still there is something. So what essentially we try to tell that, irrespective of your tight glycemic control, you don't get everything. You need a molecule which will also look after the cardio-renal metabolic aspect. A lot of advancement has done with the new insulin analog, glucose monitoring, pump, chronic care model, multidisciplinary, but we need to move from the glucocentric approach. That's very, very important. And we need to do this a multiple risk strategy. And this has been shown very clearly on the Steno trial. I think it's very small digit, you can see, but everything essentially we are trying to improve the people with the type 2 diabetes, hypertension, dyslipidemia, obesity, risk reduction. On top of that, that's not everything. We need to do something else so that we can do the cardio-renal protection. The choosing the treatment for the people with the type 2 diabetes will come this point very clearly. Unless we are doing this, we are not doing proper justice to our people. So these are the usual molecules: metformin, SGLT inhibitor, GLP-1 receptor analog, gliptin, thiazolidine, sulfonylurea. The main difference, as you see here, with the gliflozin and GLP-1 receptor analog, everything is actually favorable. Only place where GLP-1 receptor analog didn't get chance is the heart failure, which is an extra benefit for the gliflozin. All other things for the atherosclerotic cardiovascular disease, it is beneficial. And we know that on the left side, the glycemic benefit, different mechanism of action, I'm not going to do that. And the right side, the GLP-1 receptor analog, how we are getting the benefit for the atherosclerotic cardiovascular disease. And no wonder in the guideline, you will find most of the places there will be GLP-1 receptor analog. Dulaglutide, which we are talking at this point, once in a week GLP-1 receptor analog, because once in a week semaglutide injection is not yet available to us. It is a good glycemic potential efficacy, comparing with liraglutide 1.8 milligram once a day injection. You need to remember that most of our people in India actually on 1.2 milligram liraglutide, not 1.8 milligram, but 1.8 milligram, the comparable glycemic efficacy, fasting reduction, and PP reduction. Interestingly, I tried to tell about the fast injectable space. You see the middle one, I think this is not okay, doesn't matter. If you see the middle one here, if you compare the basal insulin glargine, your HbA1c reduction actually better with once in a week injection. So we are getting a better HbA1c control with once in a week injection as compared to daily one basal insulin. That is very, very important point. And the similar trend is seen when you are adding about other short-acting insulin. Additional benefit, weight loss, different ones on. We all know that GLP-1 receptor analog group of medicine causes significant weight loss. Now comes the cardiovascular point, as I was mentioning again and again. So all these trials with the GLP-1 receptor analog, leader with liraglutide, sustain 6 with injectable semaglutide, harmony with albiglutide, rewind with dulaglutide, and pioneer 6 with oral GLP-1 receptor analog, oral semaglutide. Main benefit is seen with the liraglutide in the leader trial and injectable semaglutide, sustain 6, and rewind with the dulaglutide. Albiglutide has shown the benefit, but it is not going to be launched. That's because of some injection site reaction and so on. And this is what we have seen in the rewind trial, 3-point MES, which is a standard of cardiovascular disease, in comparison to the placebo. As you see, the blue color is the placebo and the red color is dulaglutide, a significant reduction in the 3-point MES over the long period of time. But what is interesting to see is that, which not been seen in other trial, is that whether you have cardiovascular disease or you do not have cardiovascular disease, the benefit is there, both of them. And this is the one reason why this trial was continued for so long time. 5.5 years is the longest trial with the gliptin, GLP-1 receptor analog trial. And whether you have just risk factor without disease or you have disease, you get the benefit for both of them. And that makes the point what I was telling you the first time, that the action we should start probably in the pre-diabetes time so that we can prevent the atherosclerotic cardiovascular event. Obviously, any of the anti-hyperglycemic agent, we call about hypoglycemic incidence should be less. The Ganapati has already showed about this with your co-formulation insulin, and here has almost comparable hypoglycemia with the placebo group. So there's no extra risk of hypoglycemia. Other benefit, reduction of the LDL cholesterol or BP or heart rate, as you have seen plenty of this slide, composite benefit is very, very clear. Now, the renal outcome, these are a bit subgroup analysis, but it's very, very interesting to see that in comparison to placebo, the dulaglutide, the red curve is showing some risk reduction of composite renal point and also new onset macroalbuminuria. So along with atherosclerotic cardiovascular disease, we are getting some renal benefit. And again, this side is compared with insulin glargine and dulaglutide, as you see clearly in the blue curve, that renal benefit of reduction of the microalbuminuria and is significantly more into the placebo. So this is doing something good for the kidney as well. Important point, when we start, we need to counsel the patient. Nausea and fullness at the beginning, almost everybody get it, but within a span of 3 to 4 weeks, it goes up. Some simple tips like eating slowly, consuming smaller meals, and taking the medicine a bit an empty stomach, not immediately after food, because the chance of throwing up will be there. And also not to take a lot of fatty meals. Initially, for a week or two, we can give a symptomatic treatment with the anti-emetic agent like domperidone. Not surprisingly, in a direct comparison, when you compare once in a day liraglutide with once in a week dulaglutide, people favor dulaglutide. Obviously, once a day injection or once in a week injection. There's nothing surprising about that. But interesting to see the delivery technique. The needle is not seen, and this most of the people like. And that this pen is really unique and very nice to use. I was surprised to see this poster, which was presented in EASD this year means 2022, about the adherence with dulaglutide and oral semaglutide. Now we know that Ribelsus oral semaglutide is available to us, which is to be given every day. Actually, in this study, taking more than 12,000 people, post-marketing study, the adherence and persistence was better with the once in a week injection in comparison to oral semaglutide. And this makes me making a small comparative table. So on the top, we see dulaglutide, 0.75 to start, then 1.5 milligram. And the bottom, oral semaglutide, 3 milligram, 7 milligram, 14 milligram. If I compare the different parameter, efficacy, both are clear. Weight loss, both are clear. Cardiovascular benefit, we still don't have the data with oral sema. Hopefully it will come soon. Frequency, clearly it's better than dulaglutide because it's once in a week. No need for dose titration, little in favor of dula, because oral sema we need to give 1 month 3 milligram, 1 month 7 milligram, then 40 milligram. Now here it is a negative point. Obviously injection is a barrier which goes in favor of oral semaglutide, but no need to take in fasting. The flexibility is very much in favor of dulaglutide injection because you can take any time of the day. Not even every 7 days you need to take. You can take 6 days, or we can take 9 days also. Within 3 days, you should not be taking 2 injections. So suppose if somebody is taking every Saturday injection and they have some program on Saturday, they can take Sunday next week. So it is in 7 days, it become 8 days, nothing happens. That flexibility certainly will not be there with oral semaglutide. So beyond glucocentricity, we need to look somebody who has failed on multiple oral therapy, struggling to get a blood sugar control. Weight gain is a clinical concern. Cardiovascular risk is a clinical concern. A simple therapy to put it, just once in a week injection any time of the day, and who is motivated to the long-term benefit of the patient, it is certainly a big option. And that makes us a big point that about the fast injectable space in the people with the type 2 diabetes, probably it goes above basal insulin or any insulin, as long as there is no acute catabolic situation. For example, somebody is losing very weight rapidly, somebody is septic, obviously insulin will be the choice. Otherwise, for our general people, that can occupy the first place for the injectable thing. So that's all in the summary. Then it's important to the beyond glucose, we need to act early. I emphasize this point again and again. So reduction, the 4 pillars we have made it here. One is the glycemic management. One is the blood pressure management, lipid management, and some extra thing we need to think of about the cardiovascular and kidney protection. So moving beyond glycemic control to manage type 2 diabetes, we need to remember type 2 diabetes is a complex disease with micro and macro complication. We need to address the vascular risk. We need to control early intensive treatment, hit early, hit hard. That is the campaign. And the GLP-1 receptor analog is the preferred drug therapy in these people. Also, this multifactorial approach, you need to remember, they cause a very clear cardiovascular protection data, effective glucose lowering agent, less hypoglycemia, and important benefit of weight loss. It is safe in patients with the type 2 diabetes, CKD, up to the GFR of 15 ml. That is the current license. And adherence and persistence has been shown in the post-marketing study with a once in a week GLP-1 receptor analog is quite a bit good. Thank you very much for your attention.
Are there any questions?
I'll take that as a comment.
Arpan, it's a great talk, and one simple question with GLP-1 once a week injectables doing so much better than the oral semaglutide, where do you see the market for oral semaglutide over a period of time? Because I know there are still some people who prefer that, but when you compare these two, I mean, it's so much better once a week, better compliance. Even if you miss a dose, you can take it on another day, less of side effects compared to the oral semaglutide. Where do you really see oral semaglutide going for a period of time?
Okay, it has not shown any better efficacy wise. The only thing, the cardiovascular data we have with injectable dula, but we don't have yet with oral sema. Injectable sema, we have a cardiovascular data sustained. That's clear. Now, the main point with the benefit is that flexibility. morning, evening, 5 days, 8 days we can do. Now, where do I see oral sema? A lot of people have injection is a big barrier, 100% agreeable. Although the technique of this pen with a Trulicity pen is wonderful, I mean, needle not seen, but injectable barrier is there. So whenever we are discussing and giving an option, once in a week injection versus you start with the oral sema, a lot of people choose oral sema, no doubt about that.
Yeah, because my experience is quite contrary to that, because if it's oral sema, then every day it has to be in the morning, 120 ml of water, don't take anything for half an hour. Anybody who can afford this kind of a tablet, who can spend about 300 odd rupees per day, always says that this kind of a flexibility, I don't really get with oral sema, that, take the tablet any time. So I prefer once a week injection versus every day going through this,
Agreed.
problem of that.
Totally, our experience is like that. Only thing, some people that coining of injection word is the problem. But once they get the first injection, they realize that this is nothing. A lot of people, we make a point that we give the injection ourselves the first time. And that's it, it is done, because they have not seen the needle, it has gone in and came out.
Yeah, because today, if you look at the 2023 guidelines of ADA also, I mean, it's so much cardiorenal, vascular, adiposity centric kind of a thing. I think GLP-1 far outscores the oral sema in all these respects. But this is just my personal view. I can ask Krishna to pitch in on your experience. Anantram is here, others are here. So, I mean, if you are given an option, whether you prefer once a week GLP-1 injectable or
probably yes, once in a week will be much better.
What's your
what you're going to see happen is this greater and greater push towards obesity as the primary target in diabetes. So, and this is where, doula is going to lose out if the higher dose doesn't hit the market soon. That, again, hopefully doula is coming out with a higher dose. Once it comes out with a higher dose, then it will be equally balanced. In my view, I find the doula to be sort of equivalent to 7 milligrams of sema. But you need anything more than that in terms of weight loss. I actually push to 14 milligrams of sema, switching from 7 milligrams of doula. Somebody's on 7 milligrams, I mean, a doula, it works to around 7 milligrams of sema. I think roughly for most of us, I think that's how it's working, right? But if obesity is a main reason that you want it in, then you want to up titrate it. And that's where, 1.5 milligrams of doula is not going to make the cut. You will need either the double dose or the triple dose that's coming in, or a much higher dose of sema that's probably also coming in. The next few years, you're going to see this greater and greater push towards obesity as a primary target in diabetes. And you see that the narrative is already being built in the Western perspectives and reviews. And they will keep pushing this.
Yeah, the higher dose of injectable sema and also tirzepatide, whenever it is going to come to the market, will take over definitely.
Sir, Dr. Arpan, how many don't respond to GLP-1 analogs in your practice?
Very nice question. Now, this I need to be data to tell that, but certainly a percentage of the people, they don't respond. No doubt about that.
How long would you try? 6 months, 3 months?
Whenever we ask, this is a very important question. Anybody can this? So how long I need to continue? So we tell to take at least for 4 to 6 months to see the complete benefit. If we see the 4 to 6 months, whatever expected improvement we have not seen with spending this much money, probably we need to think of other injectable option.
Thank you.
Sir, one more question, sir. Yeah. So do you have any patients with low BMI on
Well, initially our idea was like that, but incretin therapy, GLP-1 receptor therapy, only people with the obese type 2, but that concept is gone. Now, it is correct that if somebody's weight is 95 kg, they probably will come to 91 or 92 kg, but somebody's weight is 65 kg, they will probably lose by 1 kg or 1.5 kg. That's right. But we are not taking that as an indication for choosing the treatment.
Sir, when we look at the response, there are two responses that we are looking at. One is the glycemic improvement and second is the weight loss. What would you consider as a response at the end of 4 or 6 months that tells you that, okay, let me continue in terms of A1C reduction or weight loss, like 3%, 5%, or HbA1c reduction of 0.5 or 1%, would you consider significant enough to continue at the end of 6 months?
Yeah, that's actually a very nice question. So weight loss wise, I'll divide in two ways. One is a metabolic weight loss, one is cosmetic weight loss. We expect a metabolic weight loss, which will be around 3, 4, maximum 5%, not kg. So from say 95 you start, it will come to 94, 90. And the way HbA1c reduction, 1% I'll take as a good response, definitely.
Thank you, sir.
So if there are no further questions,
Thank you.
we'll move on to the next session. I would like to invite Dr. Krishna Seshadri to give us a talk on interchangeable biosimilar glargine. He's consultant endocrinologist, Chennai Diabetes and Endocrine Clinic, clinical and research lead, Apollo Sugar Hospitals, Chennai. Over to you, sir.
Does anyone have a piece of cloth that I can use? A handkerchief or a cloth? I want to show something as we go. As long as you've not used your nose on it. Can you see my slides?
Yes, sir.
Wait, I have to mirror this, just give me a minute. I'm putting slides, but most of them I won't be using because I thought I'll make it much more simpler for people to understand the biosimilars. Thank you. So, what is it about glargine and this thing? First thing is to understand, we have this question all the time, right? When dapagliflozin or sitagliptin or vildagliptin are small molecules, they're chemicals. They can be easily made into generics. So at the end of 4 years, the original owners of the patent suddenly find that they have a lot of competitors that are making the same product at a much lower price. And the original makers either try to reduce the price and stick along, or, you know what, we can't work on this market and escape. That's what happens in India. Correct? It's an easy target, and that has been there for years and years and years. But that doesn't happen with insulin. I'll give you an example of a drug that has a monopoly for now the past 30 years or 40 years. That's growth hormone. People may try as much, but the price of growth hormone has never come down. But how many of you remember that in 2019-20, in the US, there was a shortage of insulin, to the point that people were talking about access from other countries. The second thing was that led to finally today, now many states in the US saying that the total cost of insulin in any month cannot be more than $100. Right? Why? Because in the US, there are probably only 2 major players that bring insulin. So this is the big question. The question is, as long as somebody has a monopoly, they have a monopoly over the cost. Now, there's another part called cartelization that occurs everywhere, including pharma, where irrespective of how much they compete, they would have gotten back in one small room and said, let us make sure it doesn't reduce below this price. That's cartelization. But there is an important reason why people throughout the world are talking about having competition and not allowing monopoly after a certain period of time, whether it is insulin, whether it is biologicals. But the problem has been about biologicals is that they are very large molecules. They are proteins and they're not easy to copy. Every molecule, remember, it is very interesting for us to remember that that the molecules are all made by E. coli or fungi, right? And each protein is slightly different. And in a chemical, you can easily recreate it. But recreating a biological molecule is very, very, very different. I'll give you an example. I launched the biosimilars in Bangalore now 10 years ago, probably. And that day also I used this handkerchief. I'll use it today also. Not the same one. This is the amino acid structure. It's a monostructure. Insulin is 59 amino acids. It folds once, right? That's a dual structure, the secondary structure. It folds a second time, that gives you a three-dimensional thing called a tertiary structure. Then to this, at different parts, other carbohydrates and other glycosylated products, other fats add, gives it a quaternary structure. In addition to this, so the same amino acid that is exposed here may not be exposed when it becomes this way. When it gets attached to a receptor, it undergoes a change that exposes certain amino acids to the receptor that makes it work. So now you understand, it's not just a chemical, it is a protein that has a quaternary structure. But if you just copy it and place it, it may be present, but it may not act. So this is the issue with biologicals. In fact, this became a problem 10 years ago when first erythropoietin was produced. And in fact, the human insulin Marvel was produced. That is why biologicals have very, very stringent requirements and very, very stringent norms to follow before they get agreed. So you might find in 3 years, every company is able to bring in a patented molecule that is a small molecule like an oral drug. But it's so difficult to make insulin or growth hormone. There's only one Indian company that has created growth hormone, right? Reliance. And all the others, biosimilars. But biosimilars are very important. Why? One, they create competition. If you didn't have biosimilars, India would have had the same problem that Africa has and the rest of the world had as an access to insulin. For those of you who don't know, because of the Ukraine war, growth hormone is not easy to get in India today. In fact, I was told on Saturday that the first batch of growth hormone from Denmark has finally arrived. We switched a lot of our patients to Reliance, which had a biosimilar. So what does a biosimilar do? A biosimilar insulin is an insulin that has been reverse engineered. Just like in the olden days, when IBM made all the computers, the first day somebody said, let's make it cheaper in Malaysia. They took it to Malaysia, and then Malaysia said, this is how it is done. They created the computer. Then they said, why don't we assemble it and box it here? Then, why are you making it in America? We'll make it here itself. That's exactly what happened 30 years ago. That's what's happened to insulin by biosimilars. India, in many ways, is the biosimilar capital of the world. I myself have helped launch biosimilar insulin in places like Colombia and Malaysia and Sri Lanka. That in these markets where money is an issue, where access is an issue, where you are under the control of multinationals, having an Indian company that does that or a local company does that just removes the barriers of access to patients. We in India are very lucky. We don't understand the value of access simply because we are flush with options. We are in many ways the manufacturing hub of the world. We may complain about cost, but the cost of our medications are much lower. And one of the reasons is because of competition. So that's really all this is. This is what is a biosimilar does. A biosimilar is an insulin that is similar to an existing insulin, but not an exact copy. Because, for example, it could be made by fungi, but may not be an exact copy, but does the exact same thing. How do you know that a biosimilar does the exact same thing? First, Don't ask people for RCTs or phase 3 studies. For a new molecule, you need a phase 3 study to show that it is superior or non-inferior to the existing molecule. What you need from a biosimilar is, does it act like the existing molecule? Meaning, if somebody tells you, sir, our insulin is superior to the existing molecule, send them out of your room and say, you're not a biosimilar, you're a different product. If it is superior, it cannot be the same molecule. So how do you know it is like the same molecule? The only slide you should ask people is, show me your PK/PD slide, your pharmacokinetics, pharmacodynamics slide. If they show that, and they show that both the PK/PDs are exactly the same, and in the studies that even if they have few hundred patients, that's enough, that they have the same A1C reduction, that is all that you need. So these are made from living cells. They are not identical. Just no two insulin molecules are the same, just like snowflakes are, right? I don't want to spend time on all of this. We know all of this. I've already explained this. So just to understand that this is the insulin burden, and in most places, access to diabetes care is very poor, and having cheap insulins that can compete. So today, a biosimilar insulin is around 30% the cost of, anywhere between 30 to 60% the cost of the original molecule. But what we need to understand is, when you have a biosimilar insulin in the market, the original maker is forced to bring down the price after some years. Otherwise, it'll be like growth hormone, it'll be the same. So what biosimilars have achieved is, one, they made insulin accessible, they have made insulin cheaper, and they have forced the originators to bring down the price. The only thing I just want to add is the evidence is fairly good. Now, Biocon was probably the pioneer in the insulin bit, because 10 years ago, Biocon launched its basal insulin. That is an interchange. I'm sorry, that is a biosimilar. Now, how good are these is a question. One, in PK/PD studies done in independent countries, including Japan, they're exactly the same. So clearly, remember the DCGI approvals for all of these came before the new EMA guidelines. But based on the EMA guidelines, the Biocon insulin that we know has the same PK/PD. One second. The InStride studies, and I'll show this to you towards the end of my talk, which looks at RCTs, that looks at how similar are they in terms of A1C reduction. They're bang on. Same risk of hypoglycemia, the same antibody formation. All insulin cause antibody formations, both the original and the copies, but the same risk of antibody formation. Now, from a marketing point of view, Biocon is going into town with this particular word, interchangeability. What is interchangeability? Now, when you write a prescription, you write things say may switch or may not switch. That is, for a given generic, a doctor can decide, right, whether the pharmacy, if available or not available, can help you choose with two brands. For example, you're writing sitagliptin and Januvia is there, and let us say Siaglide is there. If you say may switch, then the pharmacy can give either Siaglide or Januvia based on what is available. In many corporate hospitals, they usually have two drugs on the formulary, and one of the two they can give. If you say do not switch, they cannot do. Now, in the US, patients don't pay from their own pocket. Many of them pay from insurance or third party. In lesser countries like the UK and Europe, where people depend on NICE and others, and they don't pay out of pocket, but the government pays for them, what happens there? The pharmacy decides what is going to be stocked and what is dispersed. Now, in these third payer economies, this new thing called interchangeability has been introduced. So even if I'm a doctor and I work for one insurance company and I bill, and that is billed, For example, Kaiser Permanente is the insurance for which I'm working, or the hospital uses Kaiser Permanente. If I write Lantus, the pharmacy, even if you have written do not switch or do not substitute, the pharmacy has the right to give a lower cost insulin because the FDA has approved this as interchangeable, meaning they don't see a difference between the two. And therefore, they've taken the power of the doctor to interchange, to prescribe a particular insulin. This is mostly in insurance and payer markets. Thankfully for all of us, it is not going to affect us because most of our patients pay from their own pocket. So if you say do not change, they don't change. But what it does for a company like Biocon, which has been struggling and with the US-based companies to say that we are as good, the FDA says, look, you are good. You are so good that we really don't care if, even if the doctor has given Glargine, Lantus, can you substitute with Glargine Biocon? That is what interchangeable means. Is it going to affect Indians? Probably. I see a time when ESI, CGHS, ECHS, or those that have domiciliary insurance opting for interchangeability. But the way that we need to look at it is, look, it doesn't affect us right now. What it tells us is the product is very good. Is it important to look at the product name in biosimilars? The answer is yes. Ask for the PKPD. Many companies that now have biosimilars have come into the market before the rules changed. So ask them for the PKPD and then choose which biosimilar, right? Otherwise, you can have issues. So I'm not going to spend time. So this is what you have. And these are the InStride studies that show that, remember, these are all biosimilar studies have to be done on type 1 because there the other parts of insulin resistance don't come. Type 1 studies show they exactly mirror, just bang on top of each other. This is the InStride 2 that is on type 2 diabetes. Again, small numbers, don't expect big numbers in these. Can't say the difference at all. And the PKPD slide is not here, the PKPD is also the same. Immunogenicity, exactly the same. Hypoglycemia, exactly the same. Antibody percent over time, exactly the time. And this is one Indian study showing again the same as the same. Again, you really don't need to look at, what is it called, biosimilar versus Glargine. You will see that they're exactly the same. If they're not the same, then you shouldn't trust the study. So quickly, so what are biosimilars? One, they are copies, not exact copies, but they work the same. Second, what do? They help you get cheaper insulins or cheaper biologicals. Third, if well done and approved by various agencies, they can reduce costs and improve access. India has been able to withstand the pressure of multinational pharmaceuticals because of a very, very strong Indian pharmaceutical industry. We actually don't appreciate it because only when you go to another country, you realize how much hampered they are because of a lack of competition. And Indian companies coming out with biosimilars is a very, very important step towards that Atmanirbharta we talk about. Not just the Atmanirbharta, we are able to help other countries just as we did in COVID-19. And that's a role that we need to continue to play. With that, I will stop and I hope I have enough time for questions if necessary.
One question that I always have is, does the plant in which the insulin is made, I mean, the interchangeable Glargine, is it the same Glargine that is marketed in the United States, or it's a different?
No, it's the same.
It's the same thing.
The same.
Okay.
Yeah.
And so, what's your take on Glargine being available through the Jan Aushadhi? And we have so many different Glargines actually, and there is no literature available on comparing all these different Glargines.
So I followed with a lot of interest the Janaushadhi discussion in Friendos. So I think the first thing is that it's not Janaushadhi's mandate to see the difference between drugs. It is a DCGI. And just want you to know that many of our friends sit on that DCGI committee that approves these drugs. Second, in terms of two difference between generics and biosimilars. Generics, the bioequivalence is important. But there is clear data that for some drugs like thyroxine, brandeds are better than generics. There is no question about it. There have been repeated studies that have shown that for things like thyroxine, brandeds are better. In fact, there are some studies that looked at even clopidogrel, that branded may be better than generics. This is one. Second, with biosimilars, it's a different story altogether. With biosimilars, if the most important thing is actually to ask, there are differences. For example, Vocard versus Biocon versus Lilly's Basaglar, Lilly and now Cipla's Basaglar. The one slide that the drug rep doesn't bring to you is a one slide you want to keep asking. Show me your PKPD versus Glargine.
But then the thing is,
sometimes they would do a U100 versus U300, U100 versus U100. Yes.
No, it's the PKPD is not available in the DCGI's website, isn't it? I mean, I've tried.
So they should have looked. So the DCGI's dossier will have. That's exactly what I warned you about.
Should we file a RTI request for that? Or
you don't need
how
to.
Do we get it?
Just ask the company. So what it is that that is why I said when the biosimilars originally got their approval, the top three, not Cipla, but the other two, because Basaglar came a little later, Lilly's Basaglar came later. The others, they came before the 2013 guidelines. They were approved before then, right? But the simple thing is to ask the company to say, look, show me your PKPD. Otherwise, I'm not going to prescribe. Immediately, it'll come in front of you. Should you file an RTI? I don't know about the RTI, but you can try. But as part of the original filing, you will not see that. But the EMA guidelines came a little later, and now every country has somewhat, adopted the EMA guidelines for biosimilars.
Yeah, I think I'll just add to your question, Anantha. What is sold in Janaushadhi for Glargine, you don't see who the manufacturer is today. Initially, when Janaushadhi came, it used to be the Biocon. Biocon actually supplied on the request of the government. And initially they were good. Okay. And we had asked the same questions to Biocon at that particular point of time, that why is there a price difference between your stockist? The stockist price was much higher than what was available in Janaushadhi. So this question was asked because some of us run the pharmacies. So I know the story. And then Biocon stopped giving it to Janaushadhi. And today the Glargine that is sold in Janaushadhi, we don't know who makes it. Okay. Now, Lupin's Basogen is nothing but Biocon's, Basilog. Right? Now, it's clearly mentioned in the Basogen that it is co-marketed with Biocon, even though it's not co-marketing, but they sell it with a different name. Vocard's insulin always had the problem, even when we were doing post-marketing trials and things like that. The watery insulin would turn cloudy, and the cloudy 3070 of Vocard would turn watery. I mean, this was actually shown to them, and they do have a PKPD data, and there
which is not.
Yeah.
The one that I saw did not match. I didn't want to name them, but I didn't.
This PKPD was done in some lab in India, and repeatedly, I think all the diabetologists, endocrinologists have asked the same question to Vocard, that there's something wrong with the insulin, because the rest of the products are very good. There's something wrong with the insulin, the stability part of it. And that story has continued. But now even Lilly's Basaglar is interchangeable. So it
is absolutely. Yeah,
so Lilly's is interchangeable. Now Biocon's is interchangeable, and And what Lupin
So-
now sells is nothing but
Is
Biocon's,
Biocon's insulin.
Biocon's large
And the
insulin.
interesting thing is that, the other thing I always look for is there a Japanese submission?
I think that's supposed to be the
If the
toughest.
Japanese submission is there and things are fine, then it's fine anywhere in the world, right? And since I did a lot of initial thing with Biocon's Glargine, I know that they had a German and a Japanese PKPD done, which are bang dot. And what is interesting is that that Biocon uses a fungus, and the original molecule is E. coli. So, but they were able to do this very, very well.
So any comment on the immunogenicity of the molecule?
Absolutely the same. The antibody levels are absolutely the same. It's very interesting, that it is actually we think about it in terms of generics, but creating biosimilars is not easy. We have some very bad experiences with erythropoietin and even insulin, human insulin Marvel.
So another comment is batch to batch variability. And if they could make, I think that's
That will be there with every insulin.
every insulin.
Every insulin will have batch to batch variability. Remember, it's like, you're asking some other organism to make it for you. It's like milk. Unless you're someone who's powdering milk and reconstituting it. I don't know how many of you get cow's milk. We get cow's milk at home. The taste is different and the consistency is different each day. So it is, unless you have, find it and done some homogenization, which all of them do, there will be batch to batch variability. That's part of any biologic. But there is a percentage to which that variability needs to be, and that's all it is. Less than 5%, or many of them will talk about less than 2% batch to batch variability.
It's no more questions.
Thank you.
We can move on to next session. Thank you, Krishna sir, for a wonderful talk. So next, I would like to invite our dynamic speaker, Dr. Mahesh DM, who is a consultant endocrinologist at Est Hospital, who is going to talk on insulin in hospitalized patients and different case scenarios. Over to you, Dr. Mahesh.
Thank you, sir, and thank you, organizers, for this opportunity to talk about insulin in hospitalized patients. I'm sure all of us, have gone through the COVID phase where we saw a lot of patients who were newly detected to have diabetes and who already had existing diabetes and came to the hospital. And the most important, sometimes we may think that, the patients who had uncontrolled diabetes for a very long time are the ones that are likely to have worse consequences. But the data shows that those who have newly diagnosed hyperglycemia with an HbA1c that is high are more likely to suffer adverse consequences than somebody who is on treatment not well controlled. So that is something that is, incidentally found out. And also we have seen that many of our hospital data in the last 2 years have shown that newly discovered patients with high glucose levels are much worse than pre-existing diabetes. So this is a chart. I'm sure some of us would have seen this. This is how it used to be when I was doing MBBS. During the rounds, they will see the glucose levels being plotted, the urine sugar being tested. We did not have glucometers available everywhere. So the testing used to be done with urine sugar, and we used to mark something. And then when the glucometers came, we used to get this sliding scale was commonly followed. This is a chart from 1921, 1922, when the initial insulin was discovered, and there were huge fluctuations which resulted in severe hypoglycemia that caused even death in the hospitalized patients. So, Banting had said that when a single injection of insulin is given, there is a rapid fall in blood glucose below the normal level, which is accompanied by many symptoms that we all are well aware of. And it cannot be predicted with any great accuracy in an individual patient. It is felt that hypoglycemia constitutes a real source of danger. So the most important word here is cannot be predicted. So this cannot be predicted is one of the most important word that we all want to remove from our clinical practice, and we want to predict what is likely to happen in our patient. That is why the pharmacokinetic dynamic studies looking at the what is the onset of action, what is the peak level, how long does it act. So analogs have helped us improve that, becoming more similar to what happens in the body. Therefore, we have a large number of insulins available today, from the initial isolation of insulin to animal insulins to newer molecules that are having more consistency in terms of their half-life, less variability, and moving on towards more stability in terms of predictability in our clinical practice. So today in hospitalized patients, it is recommended that any patient, if you see with a blood glucose level of more than 140, should have an HbA1c done. If it is not done in the past 3 months, insulin should be administered using validated written or computerized protocols that allow for predefined adjustments in the insulin dosage based on glycemic fluctuations. Why is it important is that in this word cannot be predicted is one that we are trying to tackle. So we are trying to give a computerized or a pre-written formula with a particular amount of glucose, because based on what is the knowledge we have, we know that the likelihood of hypoglycemia is less when we follow a particular pattern. For example, in the hospitals, same nurse may call 3 doctors and say the glucose level is 300. One doctor may say give 10 units, the second doctor may say give 15, the third doctor may say 20 units. All 3 may be right for different patients, but they cannot be right for the same patient. So we cannot have, giving for the same glucose value without looking at the type of patient, give insulin that will result in a severe or hypoglycemia that may cause, harm to the patient. So today we have glycemic targets that have been fixed, that in patients who are having, who are sick, admitted in the ICU, the target range is between 140 to 180, and if possible between 110 to 140. Anything below 100, maintaining it has caused adverse outcomes. Anything above 180 has also caused adverse outcomes. And high glucose range may be acceptable only in terminally ill, severe comorbidities where nursing supervision is not possible, or we are not able to monitor more frequently. So what do we do in the hospitals? The common practice is to use insulin. OADs are generally not recommended. We usually use it for daycare patients or somebody who has come for maximum 48-hour admission, where we don't try to give insulin. Patient may be discharged. We know all the predictables. So when we can predict everything, then when a patient is admitted electively, we may or may not use insulin in such patients. But in most of the patients who are admitted for acute illnesses, insulin should be the only choice that we should use. And then if required, add on medicines towards the end at the time of discharge, once we are clear about the variables and predictable parameters. So IV insulin is the first choice for any patient who is critically ill and admitted in the ICU. How do we use the IV insulin? We'll discuss briefly, and how do we use insulin subcutaneous in non-critically ill patients is what I'll cover in few cases. So we have various protocols published. There are Portland, Mayo, Medanta, Yale protocol that are talking about safe and effective ways in which you can give insulin with lower rates of hypoglycemia, or at least nil severe hypoglycemia. So if we are monitoring regularly, the chance of having a severe hypoglycemia is less than 1% or even less than 0.1%. You may have an hypoglycemia, but it should not come down below 50 whenever we use any protocol. So the exact protocol is less important. What is important is its presence in an institution and adaptation to the individualized hospital needs. So what is an ideal glycemic target in critical care setting? Just we discussed, it is definitely between 140 to 180. If possible, you can go for 110 to 140. That is what is acceptable to keep it between 110 to 140. Recommended is 140 to 180, and not recommended is anything above 180 or below 110. I'm sure above 180 is also common and below 110 is also common, but we would like at least 70 to 80% of the values to be between 110 to 180. So this is a first patient, 59-year-old lady with diabetes for 8 years, with having heart failure and also hypertension, admitted with COVID pneumonia in the hospital care. I'm sure the word COVID pneumonia will make us know that the patient is likely to be on a drug that will definitely further increase the glucose levels. and patient is already on home insulin and sugar level is on 30 units in the morning and 24 units in the night. So usually what happens is that when the patient is started medicine in the hospital, commonly we see that when they check the glucose level in the morning, it will be 110, and they will call either the whoever is the staff, and they will usually tell that, okay, sugar is fine, don't give anything. That is the common thing that will be said, because we don't know, patient may eat, may not eat. But what is not known in the background is that the patient is admitted with COVID and pneumonia, and we know that if he doesn't take his morning dose of insulin, what will happen? So the RBS came down, have 402 after when the consultant came on rounds, RBS is 402, creatinine is 1.46. So what we should always have with us is the previous, what is the medicine that the patient is taking, either he is on OHA or insulin, whatever he is taking, and what is the minimum basal requirement for that patient. So if we don't know that, the minimum basal requirement, like we all know, is somewhere between 0.4 to 0.5 units per kg is what is the basal requirement of insulin. So if the patient is already on insulin, it's important that we cover that. Even if the patient is nil orally, we give some insulin unless he's having severe renal failure or severe heart failure with liver failure, or unless multi-organ failure is there, we need to give a basal insulin so that this excursion is not too high. So patient blood glucose level is 402. X-ray shows basal atelectasis with small effusion. Treatment plan, he's already on dexamethasone 6 milligram per day, not tolerating oral feeds, and is on oxygen. So next thing will be that what do we do in such patients who is on steroids? So what do you do to gain the glycemic control? So we have three choices. Go for sliding scale, which is what is usually done in the first day. And then when the sugars don't come down, that is when the next day the reaction is. And if there is a fixed protocol that you already discussed with the ICU, I mean, I've seen that happen in the last 10 years. When there is a fixed printout in the hospital, it happens smoothly. When there is no fixed print material available, then usually it is the discretion of whoever is there at that moment, depending on how they feel the reaction will happen. And we usually first day, we always miss in terms of getting in control of the glucose level. So ideally, we would like to be patient on IV insulin. He is on steroids and glucose level is more than 400. And in an ICU setting, subcutaneous insulin, the patient is on inotropes, will not be very effective in terms of bringing the glucose under control. So it's always better to be using IV insulin in patients who are critically ill and especially on inotropes. So the infusion indications are any stress infection. I'm sure all of us know this. Important is to look at steroids and what is the type of steroids, how frequently it is given. If it is methylprednisolone, if it is given once daily or twice daily. If it is dexamethasone, what is the dose that they are giving? Or if it is hydrocortisone, how much they are giving? Because the half-life of these drugs vary, and therefore you have to tailor your insulin needs to these patients depending on how much they are receiving and how much they are taking already. And also look at patient who is already on insulin more than 0.6 units per kg. Definitely, if he is admitted in the hospital in an acute setting, first day or 24 to 48 hours, they may require insulin infusion. So what will be the bolus dose and the infusion rate in this patient? So thumb rule is divide by 100, whatever is the glucose value. You get 400 divided by 100, that is 4. Start with 4 units per kg, give a bolus dose, and then again start with 4 units per hour. And you can use 2 or 3 algorithms depending on the type of patient. So I usually keep 3 algorithms in my hospital. One for patients who are having no inotropes, not on steroids is the first protocol. Patient who are on steroids is the second one, or who are having acute illness with obesity, BMI more than 30. And the third is for patients who are on steroids plus inotropes admitted in the ICU, because they, especially the post cardiothoracic surgery, who are on very high dose inotropes, require sometimes 10-15 units per hour insulin for the first 24 hours. And then the insulin requirement starts coming down. So you can, there are different algorithms, but having an algorithm is more important than not having an algorithm. You don't have to stick to what somebody has written. You may make your modifications according to the hospital needs, but start with that. reassess, reevaluate within 2 to 4 weeks whether whatever you are giving is working or not, and change the protocol. Within 3 months, I'm sure you will get a protocol that will work in 80% of the patients, and you will be happy with the response that you will receive in the first 24 to 48 hours of patient, because that is where you either get the patient to start improving or you will see the patient deteriorating. So the first 48 hours in the hospital is where you make a difference in terms of improving the outcomes, because whatever the illness, the medicines that you give them to improve the illness will be able to do its best work when the glucose levels are also coming down. So in this patient, the insulin course, IV insulin was given, and the target was between 140 to 180. The insulin ranged somewhere between 3 to 17 units per hour, and the blood glucose levels were between 78 to 300. And day 2, the insulin, IV insulin rates reduced, and glucose level range also came down. Is the patient ready for transition? The next question is, when do we stop IV insulin and move the patient to subcutaneous insulin? For that, we need certain criteria that the patient should satisfy. So what would you say? Is the patient ready or not? We have to ask the first question: is the steroid dose continuing at the same level? And is the patient receiving any other drug? How is his oral intake? What are his bicarbonate levels? What is his GI status? Has he passed platus or has he passed stool? So those things will have to be kept in mind before transitioning, and look at whether if he had diabetic ketoacidosis and it has resolved. So I always ask, is the patient able to take orally, or have you fixed a Ryle's tube and feeding has been determined? So if those two criteria are met, either the patient should be able to take orally so that you can predict what is his intake and how much you can give, or the patient should be on a fixed meal of NG feeds so that you can decide how much insulin to give and you can vary. If it is variable, patient is getting IV or TPN, and then you want to fix, you will always be doing a glorified sliding scale, but that is not what we want. We want to be more predictable in terms of what we want to do for our patients. So hemodynamic stability without the use of vasopressors, stable glucose levels for at least 4 to 6 hours with stable IV drip rates, that is low variability, is what we want before transition, because we want to calculate the dose, which is possible only if we have a 4 to 6 hours of stable insulin infusion rates. So in this patient, the patient was shifted to basal bolus regimen with 30 units of basal insulin. After an hour later, the IV insulin was stopped. So is this problematic transition? The answer we'll see. Dexamethasone was continued at the same dose, and the IV insulin rate was 8.3 units per hour. So look at the 8.3 units per hour. If you take and you multiply into 24 hours, how much insulin you will have to give for this patient as a basal insulin or additional insulin. So at this rate, I'm sure all of us will be finding it difficult to actually see the glucose levels come down. So the result, blood glucose level resulted in more than 300 within 4 hours, and IV had to be restarted the next day. So it is important that we don't do this mistake of seeing 1 or 2 values that are 180 and not look at the entire 4 to 6 hours before making a decision of transition. So more time was needed for this patient to stabilize because of multiple issues, steroids, DKA, enteral nutrition, sepsis, etc. should be kept in mind before we decide about transition. Let the patient continue on infusion for more than 2 days or 3 days also. It is still worth it, because you will get good outcomes as compared to trying to just moving out. And it's not a quick fix. We have to take time, and the patient, you'll find that will improve only if you do that in the right way. This is a second patient who is admitted with acute myocardial infarction, has a past history of 2 amputation, diabetes for 20 years. Current treatment is OADs at maximum dosage, sulfonylureas 6 milligram metformin 2 grams, and thiazolidine 30 milligram per day. So his body weight was 110, RBS was 589. Immediately started on infusion around 6 units per hour. That is the thumb rule we usually follow, is divide by 100 whatever is the glucose value and move it to the nearest whole value, either 5.5 or 6 units in terms of starting. You can give a bolus dose of 6 units also in such patients. So blood glucose stabilized on day 2 at the infusion rate of 8 units per hour. What would we do? Patient is already on 8 units per hour. So continue infusion because the infusion rate is very high. So what will be considered acceptable? That may vary from people to people, place to place. I usually consider that it has to be less than 2 units per kg for that patient, or in terms of reduction of insulin dosage required per day, and then it has to come down to at least 1 unit per kg approximately, or around that, to be convinced that this is an okay infusion to shift to subcutaneous insulin. So these are the same things we need to keep in mind before transitioning the patient. So indications that are not safe for transition are high variability, drip rates are too high, or fewer than 6 hours of IV drip administration will not result in significant outcome. So please wait for at least 12 to 24 hours before deciding that you want to stop the insulin infusion. Other predictors are poor admission. Patient HbA1c comes 13. It's a complex surgery procedure with likely sepsis and ICU status, receiving corticosteroids, advanced age. Keep in mind these factors before transitioning the patient. Next day, drip rate was reduced to 3 units per hour and it was stabilized. So in this patient, 30 units was given. So this, how do we calculate the total dose? Look at the infusion rate per hour into 20 hours. We usually I take 12 hours and then divide 50% basal and 50% bolus. And then you can again move it up and down in terms of giving the different divided boluses for this patient. So last case, in non-critical ill setting, patient had fever with a blood glucose level of 150 at the time of admission. He was started on blood glucose monitoring, and also glucose was managed with insulin, and the blood glucose levels with glucometer were ranging between 200 to 160. What do we do in this patient? Start basal bolus insulin regimen. How do we do that? There are 3 components in that. We start the basal, the bolus, and the correctional dose. How do we do that? I will go to a specific way in which we do that. So this is how we calculate. So depending on the type of patient, patient is normal body weight, obese or lean, you divide the total daily dose as 0.3 to 0.4 or 0.5 to 0.6 or 0.4 to 0.5 units per kg, depending on the type of patient. That will be the total daily dose, divided into basal and boluses. And then equally you can divide for the 3 meals, the total insulin dose. So for example, patient may require a total of say 40 units, 20 can be basal, and rest 20 you can divide as 6 units for 3 times a day. Then comes the sort of modified sliding scale that we now call the correctional insulin dose. So in a patient who is insulin sensitive, depending on the blood glucose level, you can add or even subtract the dose that you are likely to give to the patient. For example, if the patient glucose level comes down below 70 or below 80, you can reduce by 2 to 4 units and give the insulin. 6 instead of 6, you can give 4. In the same way, instead of 6, you can give 8 units. So these additionals that you want to do has to be kept in mind. And if the fasting is high, you add the dose that you have adjusted to the basal component the next day, so that the fasting comes down. And in the end, at the end of 3 to 4 days, you will see that you will have the glucose levels that are looking like this. You can make a reduction of insulin dose or increase the dose. You can see the correctional insulin dose in the last block here. And at the end of day 3, you can see the patient's glucose levels have improved, and the insulin requirement morning is 8, afternoon is 4, and night is 6, and 18 units of degludec, 2 units was added to the basal component. So we should not, we should always understand that the variability is a part and parcel of clinical practice, and we should try to reduce the variability as we see the patient. And by day 3, you should be having a fair idea about what is the basal dose and what is the boluses dose, and then bring it down to acceptable ranges at the end of at least 3 days. You should be able to be more predictable in terms of the patient's outcome or outputs, unless and until there are variabilities which include these parameters like altered nutritional intake, decreased physical activity, exacerbation of hyperglycemia due to some new medicine, or administration of enteral or parenteral nutrition, change in clinical status. If there is any change in glucose level, you should see that is there any change in the intake. So for example, in the hospital, I've seen the patients receiving Instead of ensure diabetes that was written, patient got ensure, and sister thought ensure both are same, and they used to give ensure, and sugar level suddenly shooted up from being 140 to 180 to 250, 300 sometimes. So always look at the nutrition first, then look at the medications, and then look at whether there is any change in the parameters, whether there is tachycardia, fever, all those parameters. Look at them that are likely to alter the glucose values and readjust your insulin. And at the same time, be aware that once those parameters change, again, the glucose levels will come down. So unless and until you are in touch with the values that are surrounding the patient, that are looking at the health parameters, then only you will be reducing the hypoglycemia risk in the hospital. Otherwise, we'll be in a roller coaster ride like this. And this is not what we want to see in our clinical practice. We don't want a roller coaster ride. We want a predictable outcome. See, both of the sliding scale and basal bolus will start at the same place, but the ending will be smooth and flat in a basal bolus regimen, but the ending will always be a roller coaster in patients who are on sliding scale. So today we have moved from early experiences of unpredictability to improving predictability, and today we have more not only predictable but also physiological insulin secretion, which will result in flat and stable glucose lowering effect over 24 hours. And the latest degludec molecule, that is the basal insulin, has shown to be lower 40% variability within the intraday in comparison to glargine U300 for patients in the hospital setting. In this way, we will be able to give better outcomes for our patients by using a method that is your own. You need not follow what I say, but have a method, follow it, modify it in your clinical practice. At the end of 1 or 3 months, you will see that what you have done has given you very good outcomes because of your effort, rather than not doing anything and just following the sliding scale module that many of us are probably still practicing in clinical practice. Thank you.
Sir, would a CGM sensor be reliable in monitoring sugar levels in such patients?
In the critical setting, right now, there is the variability is too much to be relying on that. In a stable patient who is admitted for a long period, more than a week in the hospital, CGM are found to be useful. I have in my own practice seen that those who are off inotropes and on stable glucose levels, where you don't want to keep pricking 4 to 6 times a day, they're on rails to feeding, there everything is fixed, parameters are stable. In them, the CGM will help. But in other patients who are critically in, where there is variation, because there is a lag time between the subcutaneous, the capillary glucose level and the interstitial glucose level. So you will not be able to overcome that lag time, and sometimes it may reach up to half an hour or 1 hour. So you will not be able to give an appropriate dose, and you will end up with more hypoglycemias in the hospital. So that can be used, but only in a stable patient who is long-term care like that, not for acute setting. For 3 to 5 days admission, we won't recommend CG.
Thank you.
If there are no further questions.
Thank you.
Thank you, sir, for that very interesting talk. We now move on to the next topic. Insulin dose adjustments to be done during any sports activity, while eating out, and in case you miss any meals. For this, I invite Dr. Usha Ayagiri, Senior Consultant Endocrinologist and Diabetes Specialist. She practices at Apollo Sugar Clinics, Chennai, Apollo Specialty Hospitals, Chennai, and Apollo Proton Cancer Center, Chennai. Over to you, ma'am.
Thank you so much. First of all, I would really like to thank the organizers and Dr. Arvind especially for inviting me. I hope you can hear me back there. Now, what I'm talking about is insulin adjustments. I'm not going into a great extent on how to do anything else, and certainly not how to start or adjust OADs or anything else, because time is limited and the brief is very specific. The brief is sports, eating out, missing meals, dose adjustments, insulin dose adjustments. No conflicts of interest to declare. I'm going to go straight into sports. I'm going to cover a bit of physiology here, because it's really important when you think in terms of adjusting insulin in sports to understand the background physiology of what it works like in normal. So we know blood glucose Okay, can you see the pointer? No. Oh, yes, faintly. Blood glucose from the liver, from the kidney, from the intestine, postprandially. These are our, okay, I think I'll have to work between, okay. These are our main sources for your blood glucose, and the muscle burns it and the fat stores it. So the income is from the three sources. The outflow is either to muscle or to fat. That's number one. Number two, if you look at insulin, yes, it has a, we all of us recognize the hepatic gluconeogenesis and suppression of glycogenolysis and the stimulation of glucose uptake in the muscle and fat. We all understand this. But there's also an important role in protein synthesis and inhibition of proteolysis, but also an important role in lipogenesis, storage, leading to adiposity, and inhibition of breakdown of triglycerides and lipolysis. So insulin is potentially something that helps us build muscle, lay down fat, but at times of exercise, the actions are slightly different. A single session of exercise can improve both your insulin mediated and non-insulin mediated glucose uptake in your muscle. And the non-insulin mediated is important. And insulin sensitivity can be enhanced for up to 48 hours after your exercise ends. This is important because when you talk in terms of, for example, hypoglycemia, somebody who has exercised in the morning and is complaining of hypos at night, we may not immediately associate that hypo with the exercise earlier in the day, but we need to remember that intense exercise can alter your insulin sensitivity for 24 to 48 hours after the exercise. Now, once you start exercising, there is an immediate increase in glucose uptake into the muscle, several fold, and this is independent of insulin. Number one, there is improved blood flow to the muscle and improved glucose delivery to the muscle. As soon as the myocyte senses this glucose, there is a translocation of your GLUT4 to the membrane surface and an improvement of or increase of glucose translocation from the circulation into the myocyte for utilization. This is supported by also breakdown of glycogen in the muscle and glucose oxidation. So there are several channels that happen at the same time. All of this means that acutely there is a blood glucose lowering effect as soon as you start exercising. So, but most of these mechanisms, remember, are insulin independent in the first instance. Then, as soon as you stop exercising in the recovery phase, right, there is a gradual decay of muscle contraction promoted glucose uptake. This is insulin independent, remember. And what that means is there's a potential for hyperglycemia immediately after exercise, depending on your glucose status. The other thing to remember is that, as I said, the insulin sensitivity remains enhanced for 1 to 2 days post-exercise, depending on the duration of intensity of exercise. And also, the muscles then start taking up glucose from the circulation to replenish their glycogen stores, both of which then have a potential for hypoglycemia the further you go out from exercise. So immediate post-exercise period, you may have hyperglycemia. Prolongation of that can take you down to hypoglycemia. Then there is the insulin to glucagon ratio. You start exercising, your blood glucose comes down, which then physiologically, your insulin comes down, your glucagon increases. So there is a change in your glucagon insulin ratio in the portal circulation, not peripherally, but in the portal circulation where it matters to the liver. And immediately there is an increase in hepatic glucose production, combination of breakdown of glycogen and gluconeogenesis. Apart from this glucagon driven pathway, okay, all these are practically, they need new batteries, please. Apart from the glucagon driven pathway, there is a adrenaline, noradrenaline, epinephrine driven pathway where you have an exercise mediated increase in your sympathetic drive, and that downstream increases your gluconeogenesis. More about that in a minute. But remember, in type 1 and type 2 diabetes treated with insulin, the insulin levels don't fall. That blood glucose goes down, insulin goes down, glucagon increases, doesn't automatically happen. That's number one. Number two, depending on the site of injection, supposing you've injected into a thigh before a run or cycling, even if it's a basal insulin, thank you very much, even if it's a basal insulin, you may have an increase in your exogenous rate of insulin absorption, and that can put you at risk of a hypoglycemia. Then the physiological response to exercise also depends on what are your serum insulin concentrations. Is this post-dose? Is it perhaps pre the next dose? What is the site of injection? If you go for a run after injecting in your legs, that's going to increase your insulin absorption rate, and that's going to put you at risk of a hypoglycemia. When was your last meal? What are your current blood glucose levels? And what was the time of your last bolus dose and basal dose? And I'll illustrate these with a couple of cases. So all of these make a difference to how your body is going to respond. So while I've laid out the basic insulin and glucagon physiology along with glucose in normal health, once you come to diabetes with an exogenous pool of insulin, this changes. So the other thing is to consider the counter-regulatory hormones. Now, you start exercising by about an hour or more after exercise, your counter-regulatory hormone response is at its peak. That includes your epinephrine, norepinephrine, your growth hormone, your cortisol. Now, the epinephrine, norepinephrine response, whilst it's very important for gluconeogenesis, it's much, much more important because it drives your metabolism towards lipid oxidation. And this is its main role. So your epinephrine literally shifts your gluconeogenesis from towards lipids. Okay. Right. I'm going to keep going on. Okay, can somebody give me a point? Okay, thank you. Right. Now, I do really need a pointer for this because, okay. Right, I'm just going to go here. Now, it's worth it. I'm going to spend a minute on this slide while they do the background stuff, okay? Look, we all know glycogen, liver, and muscle, ultimately through your citric acid cycle, through your Krebs cycle, gives you energy for exercise. But that's not the only pathway. You also have your fat metabolism. Remember, I said especially your counter-regulatory hormones drive your metabolism towards fat. So your triglycerides break down into, remember, that is triacylglycerol. You get one moiety of glycerol that goes back into your gluconeogenesis or energy regeneration pathway, depending on which way your metabolism is going. And your fatty acids go into your citric acid cycle. But remember that ketones are a byproduct of your fatty acid metabolism. So this is very important when you think in terms of exercise with diabetes. Right? Because okay, please don't restart now. This is going to be a fun talk. So, okay, this is fine. We can do this without slides. Can I just have my iPad from that bag, please, Bhavna? It'll just give me a memory. Don't worry, we can do this without the slides. We may lack some images, but I have, thank you. I have a, don't worry, look, no panic, we can do this. Life needs to be a little challenging. Otherwise, where is the fun in this, right? Okay. So when we think in terms of the fatty acid metabolism, please remember that the main byproduct of your fatty acid metabolism is ketones. Now, if you exercise in a state of relative insulin deficiency, what can happen is that the metabolism is mainly driven towards the fatty acid cycle. And that means that you're more prone to ketoacidosis, especially in type 1 diabetes. Now, the other thing is when you start exercising, there is a shift in substrate utilization. I had a beautiful picture. We'll come to that if we get lucky. But initially, your muscle glycogen starts breaking down, starts getting converted to glucose. You see a spike in glycogen metabolism. But as time goes on, this glucose that's generated initially peaks, but at some point, the blood glucose comes down and that starts coming down. At this point, when the blood glucose comes down, your fatty acid metabolism is the predominant driver of your energy requirements. Initially, the fatty acids start mobilizing, but at some point when your blood glucose comes down, your insulin levels come down, your glucagon levels go up, your epinephrine, norepinephrine response kicks in, and you go on to Lovely. Thank you. Let's go back one. No. Okay. Okay. Next slide, please. Lovely. Okay. So this is what I'm talking about. Your glycogen spikes and then that's gone because it's a short-lived fuel in your muscle, especially. I'm not talking about hepatic glycogen. That keeps putting out blood glucose, and the blood glucose in the red, combination of what you've eaten, what's coming out of your muscle, out of your liver, goes up. But at some point, the liver also, supposing you're running a marathon, the liver also starts getting exhausted, which is when your fatty acid metabolism primarily kicks in. Now, at that point of time, if you don't have enough insulin, this is where your ketone bodies start getting generated. So all prolonged exercise does lead to hypoglycemia and a shift to fatty acids as your main fuel. And that's where you start seeing your risk for DKs in patients who are not adequately insulinized. Now, these are the problems. Exogenous insulin, if there is too little, at that point, you're going to get a DKA. If there is too much, you really can't shut it off. You have a prolonged period of hepatic glucose output. This is what you're relying on initially, right? That's going to be suppressed with your exogenous insulin. And potentially your glucose disposal rates are increased. So when your glucose disposal rates go up in your muscle, your hepatic glucose output is suppressed and your insulin cannot be shut off physiologically, you're in trouble, right? Now, this also depends on the type of exercise. Short bursts of exercise have a different effect from sustained exercise. Supposing you're doing aerobics, it really burns a lot of glucose initially and can put you at a risk of hypoglycemia. Supposing you're doing resistance training, the muscle physiology is slightly different and that may actually balance your sugars out better. Supposing you're doing HIIT, there is a mix. And supposing you're running your marathons, you're steadily going through your glucose reserves and moving on to your fatty acid metabolism. So each type of exercise makes a difference. So when you're talking about advising insulin around sport, this is the complexity of the physiology that we have to deal with. And that's why I thought it's important to set a little bit of background. So if you're starting with aerobic exercise, in somebody who's well-trained, whose muscles have gone through that fitness adaptation, if you will, you may not see much of a hypo, but in early trainers, you will see hypoglycemia. In somebody who's doing mixed training, playing tennis with rest between sets, do we say playing football, things that involve sprints and spurts with rest periods in between, you have spikes and you have balance, or HIIT, but you have the risk of hypoglycemia during exercise is less. This, where you have anaerobic exercise, either sprinting, the 100 meter, 200 meter sprints, or where you have, for example, weight training, anaerobic exercise spikes up your blood glucose. And this is why sometimes when people do aerobic exercise, it's a good idea for them to do a little sprint at the end of exercise or halfway through the exercise, because that spike means that the risk of hypoglycemia is lower until they have a chance to replenish their blood glucose through oral intake. So coming to a couple of case illustrations. 32-year-old male, type 1, occasional, reasonably controlled, mid-7s, with occasional hypos as you'd expect and very hypo-aware. Twice daily basal insulin, this is important, and mealtime insulin. Wakes up with a fasting glucose of 278, decides he's going to go for a run. I'm going to burn it off. I'm going to exercise, my sugars are going to come off. How many of you agree with this? Let's burn it off routine. Quick show of hands, please. I know it wouldn't be that easy, would it? Yes. So post-run, his sugar goes to 355. Why do we think that is? And what are his options in this kind of a situation? Number one, okay, here we go again. Remember, he's on a twice daily basal, which means that the basal by the morning is coming down. So actually, with a high sugar, there is very little insulin left. He goes for a run. One of two things will happen. If it's a longer run, he's going to go hypo, insulin or no insulin, because he's burning through the insulin. But with a short run, with his counter-regulatory hormone response and his hepatic glucose output, he's going to go up. And there's no insulin to suppress his hepatic glucose output. And he's going to shift to fatty acid metabolism if he does it for about an hour, which is going to generate ketone bodies. So in this perfect storm of the tail end of the insulin, high blood sugars, he's at risk of hyperglycemia and shift to fatty acid metabolism and a hypoglycemia. So what are his choices? Number A, correct that high. correct the high, and the high then comes down, and then they can do moderate intensity exercise for a longer period of time and keep going through their fuel, or that intermittent sort of football, tennis, HIIT kind of exercise that keeps us going. Okay, don't worry, we'll get through this. Now, the second case is a young lady who's extremely active. She knows she's a type 2. She's gone on to insulin. She's doing everything she can with her lifestyle to try and get her sugars and her weight and everything under control. She's cycling, she plays tennis, she swims, and she's utterly frustrated because she's still not well controlled. She has frequent hypos, and she's learned to eat to prevent hypoglycemia, and she's forever gaining weight. Not an uncommon situation. Why is this happening? You need to dig a little deeper. What's her insulin regime? She's on mixed insulin 2 or 3 times a day. She's injecting pre-meal, but we need to know the timing of her exercise versus her meal and insulin dosage. So her cycling is on a weekend when she's part of a local cycling group, and they get up in the morning and go for a 50-kilometer cycle, and then they get to breakfast. Now, 2 dangers. She's cycling on an empty stomach. She's going to go hypo. And then at breakfast, if she overeats, she's going to go hyper. Or if she under-insulinizes, there is a risk of the fatty acid metabolism putting her type 2 not into a DK, but certainly it's going to be poor glycemic control. Her tennis is in the evenings. And what she finds is that she's okay during the play, but she's waking up at 2, 4 o'clock with hypos. Typical. She's burning through her fuel. She's probably not replenished either her hepatic or muscle glycogen. And then, because remember, she's trying to lose weight at the same time. And then she's getting hypos. And the swimming is at various times of the day. So to be able to fix it for her, number one, I think with the mixed insulin regime is really difficult. Number two, I'd probably put her onto a basal and prandial, but I'd be very careful about where she's injecting the basal, especially if she's on twice daily basal. Into her thighs before cycling is dangerous. It's going to accelerate the rate of absorption. And then the timing and type of exercise makes a difference. She can maybe have a snack before her cycling. She can maybe change her night insulin dose after her tennis to prevent hypos. And the site of injection, as I said, don't inject into your thighs before you go play your tennis, or don't inject into your thighs before you go cycling. These kind of things are very complex and need some time to elucidate. Another young lady just got a dog, is walking twice a day on twice daily mixed insulin, hypos all over the place. This is her early morning hypo remnant of last night's insulin. She's compensating at breakfast, but she's still got the glucose consumption from her exercise. She has post-exercise hypos, compensating throughout the day. Evening walk, not enough carbohydrate, too much insulin at evening hypos and early morning hypos. So knowing the pattern of exercise and knowing the pattern of injections is very important to be able to fix these. So that is a summary of your insulin and exercise. You do aerobic activity, consumes more glucose, you're more prone to hypoglycemia until you are trained. Mixed aerobic and anaerobic is likely to keep your blood glucose level stable. And if you're going to advise people, try and guide them down this path. If they're going to do anaerobic activity, they are going to see a spike immediately after training, but it will drift down later on in the day. These are the 3 things. Missing meals. Physiologically, prolonged fasting, starvation, leads to decreased blood glucose in you and me. You don't have to be diabetic. We compensate by decreasing our insulin levels and increasing our glucagon, and still covering about 75% of your glucose requirements. But remember, we've just gone through the glucagon and epinephrine response in people who are on exogenous insulin. This is already compromised. And so these people with missed meals are going to be more prone to hypos. Why are they missing meals? Is it just erratic lifestyle? Counsel them. Is it planned? Do they plan to fast on specific days for certain reasons? Then we can build that into their regime. Is it predictable? Are you at an office and dinner is always going to be 6 hours late? Well, we can work around that. We can design a regime that suits you. The duration of the fast, is it going to be an all-day fast, or is it just a meal that's really delayed by a couple of hours? The type of insulin, if they're on a fixed premix, then it may be difficult, less flexibility. But if you can change them onto a basal and prandial, or maybe a shorter acting basal, depending on the situation, or a basal that is a second generation analog that has less risk of hypoglycemia, That might help you. Tech for monitoring, put them on a CGMS, get them doing SMBG. Dr. Bhavna talked to us yesterday about the IPCD. So you can use things like that to get them out of trouble. And insulin pumps are always a solution for people with very erratic lifestyles. So well-controlled type 1, this is one of my patients, has been reasonably well controlled on a basal and bolus, decided they want to fast every Ekadashi. Doable. We just reduced the basal 2 by a third initially. Eventually, we discovered we need to reduce it by 50%, shifted him onto second generation once daily basal, and then he just missed his prandial insulin but stayed out of DKA. When he broke his fast was when he took his prandial insulin. This worked very well for him eventually until he decided that he liked the convenience of a pump. Remember, not pump, not because of control or trouble, but he just liked the convenience and he shifted to a pump. But he wore a CGMS for the first couple of fasts. We figured out his pattern and we were able to advise him accordingly. Second case, slightly more challenging. He's an IT exec. He goes into a meeting. He doesn't know when he'll come out. The scheduling of the meetings is not in his hands. Somebody else announces the meeting time. He's got to be there. At 1 o'clock, he might get dragged into a meeting when he was planning a 1:30 lunch, and then lunch gets to be 4 o'clock. So very erratic lifestyle, frequent missed and delayed meals. Currently, at that point of time, was on a combination of OAD and premix insulin. We had to move him away from that onto a basal and prandial with a basal that reduces the hypoglycemia, and then he was able to manage a bit better. Again, tech, a CGMS, self-monitoring, or pumps can be your friend here. Remember also that travel and most importantly, us in hospital, when we admit patients, are the worst cause for missed meals. Suddenly somebody will phone and say, I've given their morning insulin from 10 o'clock nil by mouth till 6 because they're going for some procedure. So when you're going to plan procedures for your patients, please think of their OADs and insulin well ahead of that preceding dose, morning dose or evening dose, so that we can prep them accordingly. You can do it. If you want to do it early in the morning before there is any mist, that's the best scenario. But if it's going to be slightly later in the morning, I can decrease the basal at night by 30%, 50%, whatever it takes to tide them safely over till maybe 10 o'clock or lunchtime. But the earlier you plan these and the fewer meals that are missed that involve disruption to their regime, the safer it is for them. So we are one of the most guilty partners in this. Always tell them about how to manage hypoglycemia, but the simple things I told you, you're preparing for something tomorrow, reduce your basal tonight, reduce your sulfonylureas tonight, take care of your, don't take your prandial till you eat. Simple tricks, rescue measures, teach your patients about them. Eating out. Remember, a lot of patients, if we ask them, how often are you eating out, might feel it is a judgment and we might not get the accurate information. There's a lot of anxiety for people who are on insulin associated with eating out. The timing of eating out, I might have dinner every day at 7 o'clock at home, but I was here yesterday, I had dinner at 9 o'clock. If I were on insulin, that's a major disruptor for me. The meal pattern, at home, I might eat something different. I'm going to be going to a wedding reception. I might actually be grazing for 2 hours with a heavy meal at the end. Starters, a few drinks, and then meal at the end. The meal composition, what I eat at home, maybe 2 rotis and a vegetable, may not be the same as the spread laid out for me when I go out. And which meal, is it going to be a lunch or a dinner or a breakfast that they're having out, makes a difference to how you're going to advise them. Simple things like telling them the plate method, keep it proportionate, work to some degree. Type 1s, teach them to carb count. That gives them a huge amount of independence and autonomy for adjusting their meals. Otherwise, teach them to substitute. Okay, at home, you're having a katori of rice or a fulka or 2 idlis. You go out, this is the equivalent. If you try to stick to that or multiples of that, we can try and work out your insulin requirements. Teach them about apps that can help them plan and proportion out their meals. Teach them about apps that will help them adjust their insulin doses. They exist. And teach them about alarms. I go out, I'm at a party, I may not remember my insulin. Set an alarm on your phone. Teach them about timing of their insulin vis-a-vis their meal, even when they're out, right? At home, they may stick to whatever time you tell them, 2 minutes, 20 minutes, 5 minutes, but out, they may forget. So maybe you can teach them about alarms and timings. So all these things need to be covered. The stigma, the anxiety, oh my God, is that what you're going to eat? Are you not diabetic? Teach them to cope with that, and for heaven's sake, teach everybody else not to do that. They may not want other people to know that they're diabetic, so they may not want to take their insulin in public. and they may have reservations about injecting in a public space. These are all things that if we talk to them about, we can educate them and modulate. So none of this is impossible. With adequate dialogue and conversation, we can get them to the place where they're safe and we're happy. Remember, eating out is not always eating out. Since the pandemic, we eat out at home. So ask them how many times a week they're actually getting takeaways to eat at home and counsel them accordingly. So if I were to summarize, we really need to dig a lot into the individual circumstances if we're going to keep our patients safe. We can play with technology, we can play with insulin, we can play with regimen, we can play with anything, but ultimately, until you talk to the patient, you will not be able to individualize it to your patient. Educate, educate, educate yourself and your patient. Thank you very much. I think we got through despite all the technology that we were helped by today.
Thank you, Dr. Usha, madam. Excellent talk on diet and management of diabetes. So any questions?
I think one comment from me, today's talk, if anything, proves to us that reliance on tech can help and disrupt.
Usha, after a very long time, I think we have had a lecture designed for you. I think this is a very important topic because day in and day out, we all find this problem. One of the big problems that I face in practice, or me, Bhavna, and others, is the age group between 11 and 15, especially the boys who want to go out and play in the evenings. One day they play cricket, another day football, another day kabaddi. You can't really tell them that, okay, you only burn this much of calories. He may be batting, he may be bowling, fielding. This is where the big problem comes, and I haven't really found an answer. Otherwise, they come back after the game with 400, 500, and then the mother gives extra insulin. They have early morning hypo, and this is what is being happening. And there are no easy ways, but how do you cope with this kind of a problem? That age group where every day their energy expenditure changes, and you can't restrict them to a particular level of activity.
I mean, I think one of the advantages, if I may use that word, is that this age group is a type 1 age group. And therefore, we don't have to worry too much about the vagaries of insulin and glucose metabolism of type 2, because it's much tougher to predict the fat, lipid versus insulin versus the glucose metabolism in a type 2 than in a type 1. For me, technology has been helpful here because you're right. These, they want to cycle one day, they go out to play cricket one day, they want to play football one day they're on their whatever latest fad is and they don't move. However, what I found is that for any given child, there's only 5 or 6 different kinds of activities mostly that they do. So if you put them on a CGMS for a reasonable amount of time, looking at their pre, post, and what they've done and the timing of the exercise, for that, and this is why I'm saying individualize, for that child with their parents, you can come to some kind of a compromise. So this is a child that's going to go cycle, give them a banana before they cycle, measure their sugar after they cycle, be conservative with the correction doses, or maybe you get them to play and then it's dinner time. So be a little conservative with your basal and go undercorrect a little for the meal. Don't overcorrect on the immediate post-exercise hypers. That is something that's very difficult to teach parents because their knee-jerk reaction is, oh my God, they need insulin. But then if you show them with CGMS 2 hours down the line, they've drifted down and then they continue going down. It's a very visual aid to tell both the patient and the parents that this is the drift and this is why I don't want you to correct here. So in those circumstances, 1, thank God it's type 1. 2, thank God for technology. And 3, a lot of education. Because at the end of the day, like I tell people, nobody does 100 different things on a regular basis. It's a core 3-4 things. If you can crack those 3-4, then the rest, well, that's life. What do you do?
No, I mean, I fully agree with you. You got the practical solution, but then basically when we are seeing children with type 1 diabetes who are poor, who are coming to the free clinics and things like that, where you can't use a CGM, where money is a problem. And if we are seeing a paid patients, yes, technology definitely helps, but what about a regular practitioner who comes across this kind of a challenge in smaller places where it's not affordable and you don't have CGMs, all CGMs, you can't pick up a value immediately. You need to have a real-time CGM. is there any other easy way in which one can teach them? And 5 days in a week is different again, 2 days in a week again totally changes. And these are the kind of the problems.
So number one, I think limited monitoring if resources allow. So limited monitoring, maybe immediately post exercise followed by 3 to 4 hours later, can give us a picture. You can do that once or twice a week, and over a period of a month, you'll pick up the patterns. That's number one. And I'm then assuming that at least we have that limited monitoring. But if you have nothing else, then err on the side of caution, because over a period of time, you can figure out their patterns and fix their highs, but a hypo is going to be the most dangerous thing in that situation. So if I had access to limited monitoring, I would use it in the best possible way of maybe looking at what it looks like immediately post 1 day and maybe 3 to 4 hours post 1 day, and then conserve the resources. But if I had nothing, I would err on the side of caution, snack before exercise, do your usual insulin regime, go with your A1C, and then try the best you can to monitor it. But if you have very limited resources, be cautious. That would be my only suggestion. So certainly post exercise, okay, let me put it this way. If they're a marathon runner, for example, modification in the carbs won't be of much use because you want quick acting carbs periodically throughout the exercise. You might want a snack before they start, and maybe depending on their pattern, starting maybe half an hour to 45 minutes into exercise, you might want to start giving them snacks to stave off. So they're playing a 90-minute football game, or they're running for a longer period of time, or they're going on a 50-kilometer cycle. Yes. Post exercise, you definitely need access to quick acting carbs, but the meal post exercise would need to have a combination of both to then, and protein to then help muscle recovery, but also stabilize their glycemia over the next several hours. Yeah. Yes, please.
Good afternoon, ma'am. I do spend some time in gym, so I have seen these bodybuilding chaps. I've seen worst abuse of several hormonal medications like growth hormone, nandrolone, and even non-diabetic the bodybuilding chaps use insulin. So I do stop them, but what should I know before I confidently stop them?
Oh dear Lord, this is a complete different can of worms, not even kettle of fish, is it? So, look, we know that, okay, if you're speaking from a pure glycemia point of view, yes, you'll see some dysglycemia when they start doing growth hormone and nandrolone and all the other steroids. But I do know that they use insulin as a muscle building kind of drug. You can't prevent hypos if a healthy person is going to be using insulin, and they've got to be counseled that one of these hypos can be quite life-threatening or serious. That's number one. But completely apart from that, men especially abusing androgenic or steroidogenic, we also need to counsel them about their potential effects on testicular function and fertility for the future. So that's, apart from the content of this talk, that's something else that we need to be aware of and counsel them about. Yeah.
Thank you for the wonderful talk. I'm in the tech field also. We have seen like you explained, one patient with meeting. They also have these shifts or duties that keep fluctuating, which they will hamper their exercise regime also. So is there something that you have discovered as to, if the patient has a daytime schedule and when will he exercise, and if he has a nighttime schedule, when should he exercise? Like he gets up at one day 6 o'clock, next week he gets up at 3 o'clock.
Indeed.
So how do we decide as to what should be the sort of timing of exercise?
I'll give you two answers. If resources permit, if resources are limited. Look, if they're on insulin, we know that if they're on a pre-mix fixed dose regime, it's a lot more difficult to control this kind of things. But if that is all that resources permit, we've got to get them to snack appropriately and maybe monitor as much as resources permit to try and work around it. But the best thing is, if you have the resources, get them onto a analog insulin that is, one, truly peakless, two, that has the flexibility of potentially a 36-hour or so dosing, because that helps shift workers. They can inject one day in the morning, one day in the evening, one day at 12 o'clock, whatever it is. And we have these available now. And then the prandial becomes when they eat, because you've got the background basal sorted out. Then the next generation, if you can put them onto a pump, great for them, great for you. If you can put them onto CGM, happiness all around. But at the very least, if all you can do is a pre-mixed insulin, it's going to be difficult, but maybe a snack before exercising protects them about the most against the most important hypos. If you can get them onto a basal that is truly third gen, and you can have the flexibility of dosing and minimal hypoglycemia, no peak, good. If you can progress beyond that, much more flexibility. And I'm in that space where I go from the basal to, I'm lucky enough to be working in a space where resources are not an issue for me. And I go from the basal to tech kind of space. But we must know that 99% of India is in this space, and we've got to find solutions, small snack before exercise. And the amount of snack, whether before exercise, maybe midway through exercise or immediately after exercise, depends on the type of exercise, the duration of exercise, the baseline control, the relation to the last meal and the last dose of insulin. Trial and error is your only bet if you don't have tech to help you. Right?
Last, have you seen any difference between daytime exercise versus nighttime exercise in terms of the physiological impact?
Number one, exercise. Full stop. Timing is less important than doing it. Number two, there are some studies to show, and I've shown you why, that if you're exercising for weight loss, early morning is better because you shift your fat. You go automatically into your fatty acid metabolism because your baseline blood glucose depends, as I said, on your liver, your kidney, and your intake. The intake is knocked out, then your liver and kidney contribute, and then you shift to your free fatty acid metabolism, like I showed you. Your glycogen gets your blood glucose down, you shift to fatty acid synthesis, you lose weight. So if you're exercising to lose weight, there is some data to suggest that early morning helps best, but I'm not dogmatic. I tell my patients, please exercise 5 minutes. If you get time after lunch to climb stairs, do it. Doing it is more important than timing it. Yeah.
Okay.
Yes. I'm sorry to the organizers, I'm taking up more time than I've been allowed. Is that okay? Okay, right. Thank you.
He's on a CGM also.
Okay.
He's on a CGM also. So he used to do gyms in the night, and the father and son, they are very well trained, everything this. My fastings are, say, 4 o'clock onwards, it's shooting up 4 a.m. onwards.
Yes.
I try to increase my basal, and I'll get hypos sometime else.
Yep.
So they told, then I told, okay, after gymming, maybe you do some aerobics or cut down. That's the reason this is happening. That's one. The other solution I gave was maybe you add a NPH, because that has a peak effect and that will take care of. Was I right or was I wrong?
So it depends on the timing of the NPH, because if
So that will be at bedtime, because that's at 4 p.m. for this one. And the peak of the gym also was happening at that time. Counter-regulatory hormones are also increasing at the same time. So the solution I gave was, one, you change the gym because that will increase catecholamines 16 folds versus 3-4 folds with the sprint, or you do a sprint or some, aerobics, that will be better. So these some solutions. The other things what I do.
So number one, you exactly hit it on the head. Individualize it to the patient, individualize the timing of the exercise, the kind of insulin, and the monitoring to what you see in front of you. Number two, your choice of insulin does make a difference. Number three, finishing, for example, if they're having hypos, finishing with that sprint or finishing with an anaerobic set may be enough to get it up, but they mustn't correct that high there. Because if they correct that high, they're going to go low. So maybe enough to coast them down gradually to a morning reasonable reading, avoiding that night hypo. So if they're going to do a long period of aerobic, finishing with a burst of anaerobic will take their sugars up and then coast them down. But nothing is a permanent fix. We need to individualize it to the patient. The second thing I want to remember, everyone, is when I'm talking CGMS and tech, at times of flux, at times of rapid flux, post-meal, post-exercise, during hypos, remember that there's a lag time that can be anything from 20 minutes to 40-45 minutes. This is reliable to within 8 to 10 minute window at times of stability, but at times of flux, your capillary is always going to be much more reliable than any tech that you might wear that measures interstitial fluid. Please remember that.
And again, they test and they find that it's high. Yes. So
It's
this
up
is
to-
always a concern. So why should I go for the walk? It's not even helping me out.
Remember the first case I showed you when I talked about exercise, if they're on a basal insulin in the evening, and say, for example, not to name brand names, but the NPHs or the first gen analogs, let's call them, they have a half-life of 12 to 16 hours. They're injecting at 9, whatever, 10 o'clock at night. By the time they go for their walk in the morning, number one, it's the tail end of the insulin. So they're inadequately insulinized. Two, their counter-regulatory hormone response is at its peak. Their growth hormone, their cortisol is at its peak, even without the exercise. And they may be experiencing a dawn phenomenon with or without the exercise. Number three, once they start exercising, depending on the type of exercise, they have started shifting their hepatic glucose even more. And remember, there's inadequate insulin to suppress it. And they've shifted with the early morning exercise to fatty acid metabolism. The sum total of this will be high, the dog walker, right? Immediately. They overcorrect at breakfast, and with the breakfast bolus insulin, the subsequent action will be a low after breakfast. So this is an entirely predictable set of events. The thing to do is to, one, either change them to a basal that is actually covering that period, so a longer acting basal, and number two, teach them not to overcorrect at that time, because over the next 2 hours it will drift down. Or number three, take a small correction dose at that point of time. If they're going for a walk with a 250, for example, take a 2-unit correction dose and then exercise, but not vigorous exercise, because unless they're insulinized, that's again going to tip them over into the ketogenic pathway for fuel consumption. So then moderate exercise, and then by after breakfast, their sugars will be much more manageable. So a mix of the type of bedtime insulin that you're giving, the type of exercise they're doing, if necessary, a pre-exercise correction bolus, and adequate but not over-insulinization with enough carbs at breakfast will then land you softly by post-breakfast. Yeah.
Okay. Thank you, madam, for your
Thank you.
discussion. So we'll move on to next session. So I would like to invite another dynamic speaker, Dr. Anant Raman. He's a consultant endocrinologist in Magna Diabetes and Endocrinology Center. He's going to talk on game changer in management with GLP-1 injectables and oral preparations. Over to you, Dr. Anant Raman.
Thanks to Dr. S.R. Arvind and Adore for having me over here. So today I'll be speaking about the oral and injectable GLP-1 analogs. In general about GLP-1 analogs, and going on to talk about the oral GLP-1 analog that we have in particular. This is the financial disclosure. I've been supported by Novo Nordisk for this meeting. So let's look at the burden of weight in diabetes. So how weight and diabetes are linked, and then we'll go on to what are all the measures that we need to do early on in the diagnosis of diabetes, or even before that also. And then what is the role of GLP-1 receptor agonists in the management of weight in type 2 diabetes. And then we'll also do a small case study of a single patient. So most of us deal with single patients. So how to carry this home into our practice is an important aspect of what we'll do today. So 67% of patients with type 2 diabetes in India have obesity. This figure is higher in the West actually. So many patients in India have a normal, so-called normal BMI less than 25 or 23. But they may have visceral obesity, or they may have a thin fat phenotype. So 4 in 10 adults are obese, and increased risk of all-cause mortality is there in the 50 to 61 years age group if you have diabetes plus obesity. So there is why does this happen? I mean, why is there a synergy between obesity and diabetes? So the physical environment that causes obesity also tends to cause diabetes, and you are all aware of that actually. So I think we have discussed several of these aspects: sleep disorder, shift work, and income inequality. Many of these things are there in the environment. Apart from that, the 2 core defects, which are the genetic defects, are basically the insulin resistance and the beta cell decompensation. Together, all these things lead on to diabetes. So complications due to increased body weight can be classified into two, like you can have a cardiovascular and a non-cardiovascular complication. So cardiovascular complications will include stroke, heart attack, and peripheral vascular disease. Non-cardiovascular complications include obstructive sleep apnea, depression, GERD, urinary stress incontinence, NASH, NAFLD, osteoarthritis. There is a litany of almost 54 to 60 conditions which are closely related to obesity, or obesity worsens them significantly. So the upstream problem is actually the obesity, and then the obesity leads on to multiple conditions, which also includes diabetes. So it's not surprising for us to have a patient with diabetes who also has a significant amount of, significant number of people have a NASH, obstructive sleep apnea, and in severe obesity, it's possible to have a single person having all these problems. So the problem, when we just give medication to just reduce the blood glucose, take care of the HbA1c, it's not solving the patient's problem wholesomely, because they also have other problems. So if you address the obesity issue, so we are going to address all the problems that the individual has. And of course, macrovascular and microvascular complications are also a consequence of diabetes. Of course, that can be controlled with non-GLP-1 agents also. So we all have been controlling glucose with various drugs that we have, but by using drugs which address the upstream pathway, so we also take care of multiple things in one go. And it improves the quality of life of the patient also. Such a weight-centric intervention will disrupt the underlying pathophysiology of diabetes. So let's look at how important is weight loss for type 2 diabetes itself. So when you look at the diabetes prevention program, so a 5 kilogram weight loss from baseline reduces the incidence rate from say 15% at when there is no weight loss to 5%. So almost a more than 60-70% relative risk reduction occurs. But you can see that the curve is hyperbolic. So even a small amount of weight loss will give you a very rapid reduction in the prevalence of diabetes in the next 1 year or 2 years. So even if the patient loses say 2 or 3 kgs weight, it is going to be very significant and important for that individual. So encourage your patients to achieve weight loss through whatever means possible. It's not that only GLP-1 analogs have to be given for weight loss. Even a diet and exercise advice will make a lot of difference for that particular individual. So, but if you lose somewhere near 10 kgs or 15 kgs, so the incidence rate per person with 100% years of follow-up, so that comes down to almost zero actually. So you almost are able to very effectively almost reverse diabetes. I think all of you must be seeing reverse diabetes things in your social media. There's a lot of advertising happening. So this again is data from the Look Ahead trial, which looked at cardiovascular prevention with diet and exercise intervention. So if you look at HbA1c and weight loss, a change in HbA1c. So if you lose about level 2 weight loss, that is more than 15% weight loss, so you get a HbA1c reduction of 1% independent of the medication that the patient is taking. So this is in addition to the patients are all getting the same. In one group, you have intensive lifestyle modification. The other group, you have the usual medication. So the medication requirement goes down, as well as there is an improvement in HbA1c. There is a definite improvement in HbA1c. The change in fasting glucose again happens dramatically with more the weight loss. So when you look at the direct study is basically a trial of a very low calorie diet in the US, in the UK general practice setting. So if you lose about 10 kg body weight, so around 57% or almost 60% of people are in remission from the type 2 diabetes at year 1. But when you follow it up for a further year, so that actually, stays the same or it comes down. So when you have patients lose more than 15 kg, you have almost 86% remission rate. So the higher the remission rate, higher the higher the weight loss, the higher the remission rate. So there is a direct sort of correlation between the amount of weight lost and the amount of improvement in diabetes. So you can have lifestyle, diet, and pharmacotherapy and weight loss surgery. So these are the 3 basic treatments that we have. So we have spoken a lot about diet and physical activity. So I'll be speaking about GLP-1 based therapy. So for weight loss, we have Orlistat. We have for weight loss approved drug liraglutide 3 milligrams, semaglutide 2.4 milligram injectable is approved for weight loss. We have naltrexone, bupropion, and phentermine, topiramate. These are approved for weight loss. The oral GLP-1 analog is actually approved only for diabetes, type 2 diabetes. It's not approved for the weight loss indication, though many people use it off-label. So for weight loss, we have, you can have a gastric band, or you can have a Roux-en-Y gastric bypass. So this is a weight loss surgery. So the main problem is that sustainability of weight loss, the quality of weight loss, addressing adiposity and fat distribution. So many methods of weight loss probably may not reduce the visceral fat and the subcutaneous fat. So we want disproportionate reduction in visceral fat, and we want preservation of lean mass. So these are all characteristics that are desirable when somebody is losing weight. So when you use various agents like they were used in the past, like sibutramine, recently we had lorcaserin. So the amount of visceral fat loss that you got with those agents are not at all comparable to GLP-1 based therapy. With GLP-1 based therapy, you get a much higher reduction in visceral fat mass. You get a much higher reduction, much higher preservation of lean body mass. It's a more physiological and more pathology friendly weight loss agents. So a molecule that can address the gap is basically the GLP-1 receptor agonist. They have a side effect profile of nausea in about 10% of individuals, but those individuals who actually are able to tolerate the drug, they will do well. I mean, if they are able to take it for about a month, 2 months, and they continue taking the drug, they will definitely have a benefit. There is definitely a cardiovascular benefit. I think many people have spoken about the CV benefits for injectable liraglutide several times over. I'll also cover some of that. So these are the GLP-1 receptor agonists. So the human GLP-1 based therapies and the exendin based therapies. So there are two groups basically. The Eli Lilly initially introduced exendin, basically extracted from the saliva of Gila monster. It's not the native GLP-1. It's an analog called exendin 4, but it works longer on the GLP-1 receptor because it does not get degraded by the DPP-4 enzyme. So you can have a once weekly exenatide, and one of the variations of that was the lixisenatide. Lixisenatide mainly addresses the post-meal glucose, not the fasting glucose. And in the human GLP-1 based therapies, we have lira and dulaglutide. Dulaglutide is a weekly once injection. Liraglutide is a daily injection. Semaglutide is available both as oral and injectable. So this is the future of incretins. So basically the human GLP-1 based therapy is the future of incretins. Many people, we almost stopped using the exendin based therapies. So the potential mechanism of GLP-1 receptor agonist on HbA1c. So the combination of these effects may partly explain the positive CVOT results. So not only does the GLP-1 reduce HbA1c, it reduces body weight and also the systolic blood pressure. So across all agents, so you can see the different color graphs represent different GLP-1 agonist. So irrespective of what GLP-1 agonist you do, there is a secular trend of reduction in HbA1c along with the reduction in body weight and along with the reduction in SBP. So when you do all this, so you know from the steno diabetes trial that when you reduce HbA1c, blood pressure and body weight together, so there is going to be a cardiovascular benefit. So you get the cardiovascular benefit comes through these mechanisms basically. So GLP-1 receptor agonist classification according to molecular size. So you can have a large molecule or a small molecule. The advantage of small molecule is that it crosses the blood-brain barrier easily, and then the effects on the brain are more. The weight loss may be more. So we have dula and albiglutide in the large group. As albiglutide is not being used anymore, dula we do use, but the effect on weight loss is little lesser than sema. So the lesson from the leader trial is the only, liraglutide is the only agent that we have which has got proof of cardiovascular protection. So this the leader trial is very important for us. So there is a 13% MACE reduction. There is a 22% CV death reduction. Non-fatal MI and fatal stroke were also reduced, though this did not reach significant, but the primary endpoint was positive in this study, and it was superior to placebo in terms of reducing CV risk. So the reduction in HbA1c reduces severe hypoglycemia. There's significant weight loss even. So I'm going to talk a little bit about the oral GLP, the sustain group. This is the injectable semaglutide trials. The sustain group of studies basically. So this is the development program with so many different patients, more than 20,000 patients. Those who achieved a pre-specified triple composite endpoints actually was much higher with semaglutide, injectable semaglutide when compared to other agents. So even when compared to dulaglutide 0.75 milligram, and even when compared to liraglutide 1.2 milligram, so it was found to be more efficacious, better performing. So you look at the the data with the oral semaglutide. So this is the number of studies that have been done. So it has been compared versus SGLT2 inhibitor versus DPP4 inhibitor versus other GLP-1 receptor agonist. So you can see that the bouquet of data that we have is quite comprehensive, and we have dedicated trials in the Japanese population as well. So oral sema had shown significant A1C reductions of up to 1.5% versus a range of comparators in the Pioneer program. So it has been compared in direct comparison with liraglutide. There has been a superiority versus liraglutide. You can see that it's on a 1.2% reduction versus a 0.9% reduction with liraglutide in the same trial. So it's superior to lira basically, and definitely superior to sita, empa, and in comparison to with insulin also, the oral sema 14 is better than oral sema 7 milligram. So there are a lot of studies done on so many patients in the development program. Both lira and sema have shown extremely good efficacy. And also there is a fantastic weight loss of up to 5 kg versus active comparators. So look at the comparison versus liraglutide. You can see the liraglutide comparison over here. There is a 3 kg reduction with lira 1.8. With oral sema it is 5 kg, and this is superior to placebo basically. So it's a 5 kg in the same trial. There is a better lowering when compared to lira 1.8. So, and the oral sema does provide a good right balance of efficacy and safety. So when you look at GLP-1 receptor agonist in general, so it is not about sema particularly, but about oral GLP-1 receptor agonist based therapy in general. So there is high efficacy, there is a low hypoglycemia risk, there is a cardiovascular benefit with most agents, though we are not documented it with the oral sema. We have documented it with injectable sema, but not with oral sema. But then the trials are ongoing. Most likely, even those will be positive. So this is a dedicated weight loss study comparing semaglutide 1 milligram, semaglutide 2.4 milligram with placebo. The trial objective was to show the superiority of semaglutide 2.4 versus placebo versus semaglutide 1 milligram for weight loss. So the primary endpoint was the percentage weight loss achievement and number of people who achieved more than 5% weight loss. So you can look at the observed in trial data basically. So observed on treatment data. This is both per protocol and intention to treat analysis. By both analysis, you find that there is a reduction in weight. There is a massive reduction in weight. So body weight percentage change from baseline with the 2.4 milligram dose is actually 10%. So this is one of the agents, is the only agent to actually demonstrate such a strong weight loss. No molecule before this has actually demonstrated such a large reduction in weight of 10%. So you get this kind of weight loss probably with tirzepatide, and the weight loss with both these agents, tirzepatide as well as injectable semaglutide, is on par with bariatric surgery. So it is such a strong weight loss therapy actually. So when you look at the on treatment data, that is those people who tolerated it and took it continuously, you can see that it's more than 10%. So the 2.54 milligram semaglutide, it's a massive weight loss. So, and there are news reports that people are not able to get in the US this molecule semaglutide, because semaglutide is being used by patients with obesity. Obesity has a large prevalence of say around 5% to 10% in the US. The demand is very high, and since it's licensed for use in obesity, so many patients with type 2 diabetes aren't able to get the medication for diabetes control, because people with obesity and without diabetes use the drug with a prescription. So these are the selected confirmatory secondary endpoints. So this is the ADA 2022 standard of care. So it's right up there, GLP-1 analog. So I'll come to our patient profile. He's Pawan. He has a HbA1c right now of 8.1%. So he has a strong family history of type 2 diabetes, and also he has a family history of CVD. So he has a sedentary job and often eats sugary snacks like all of us. So HbA1c is 8.4% with a BMI of 30, the blood pressure of 142/85. So this is the LDL cholesterol. So looking ahead to Pawan's care, so initiated on metformin and diet and exercise. So with multifactorial treatment, we would like to prevent his complications. So symptoms of atherosclerosis over the past 6 months, hypoglycemic episodes and weight gain. So this is therapy with glimepiride and metformin. So 49-year-old, this is what was given to him. So initially when he presented at the age of 46, he was given glimepiride and metformin. And what has happened is he's actually gained weight. His blood pressure has remained the same. His cholesterol, LDL cholesterols have remained the same. There's no improvement in these risk factors. So this is what has happened. Then the treatment decision was taken to give oral GLP-1 analog. You can see that over a period of time, there is a sustained reduction in HbA1c. And he has also lost weight actually. So from 91 kilogram body weight, the weight has come down to 78.4. So this can be a life-changing therapy for several patients with type 2 diabetes. So when he is 49 to 52 years old, he has actually successfully reduced his LDL cholesterol, his blood pressure, as well as his weight. So there's a multifactorial intervention using a single agent. So this is the sort of thing that we want for our patients. This was the missing piece in the puzzle, the GLP-1 analog therapy in management of type 2 diabetes. So we have actually, we have used drugs with efficacy only for glycemic control. So if you look at his HbA1c, so you have successfully made sure that his HbA1c does not rise actually over the previous 2 years. But once you add a GLP-1 analog therapy, so it's very powerful. So you can see the efficacy in terms of HbA1c control is actually superior to even liraglutide 1.8 milligram. So you get a very good superior glycemic control, and you get a very good weight loss. So both of these things put together help them to avoid cardiovascular complications, encourage compliance and frequent surveillance. So we're able to manage the CV risk and prevent further complications. So now the thought happens, should we start this patient early on in the course of the disease? Should we offer GLP-1 agonist therapy upfront to such a patient? So patient with obesity and hypertension and multiple risk factor at the age of 48 definitely is at a high cardiovascular risk. That is something that we need to consider in our clinical practice. So in summary, the national burden of type 2 diabetes is increasing, complicated by inadequate glycemic control. Diabetes with a high body weight is an emerging syndrome leading to adverse patient outcome. Adopt upstream approaches. Use an agent which can reduce weight, which can reduce blood pressure, and which can reduce the cardiovascular risk. Strategies in weight reduction in their current scope have multiple challenges, especially in patients with type 2 diabetes, because the medications which are used to treat type 2 diabetes themselves actually increase weight. So GLP-1 receptor agonist based therapy holds out a huge promise for our patients, basically, with type 2 diabetes. Thank you.
Thank you, Dr. Anantraman. If any questions from the delegates? If there are no questions, we'll close the session. Thank you.
Thank you, chairpersons and the speakers, for a very informative session. Now move on to the next session on oral medications in type 2 diabetes. To chair the session, I would like to call Dr. Shashikala, MD, Assistant Professor, Ramaya Medical College, Diabetologist, Diaz Life Clinic, and Dr. Raju, AT, Director and Chief Diabetologist, Sri Sakubai Specialty Clinic and Daycare Center. Welcome to you, sir. Over to you, madam.
Good afternoon, everybody. So we'll go into the next part of the sessions, which will be mainly on the oral medications in type 2 diabetes. I don't think there is any need for formal introduction of Dr. S.R. Arvind. He's the person of organizing and coordinating the present conference, and he's also Chief and Director of Daikon Hospital, Bangalore. And he's the man for diabetes, and he has blessed us many doctors to fight diabetes in corners where the reach of endocrinologists is meager. So I welcome humbly Dr. Arvind sir to please speak out on sulfonylureas in diabetes.
Because okay, so this is going to be the topic, sulfonylureas. I think this should be interesting because I've been told to make the life of Dr. Ganapathy miserable because he's going to be speaking about DPP4s next. And I really don't know. I don't want to be in his shoes because there's nothing left for DPP4 to be used in the clinical practice at all. Okay, so I'll just make my case very clear. It's not a debate. Diabetes is becoming extremely comprehensive and patient-centric. And you don't have to go into the details of this slide, but this is from the ADA guidelines 2023. No more just glycemic control plus weight management plus cardiorenal protection. Very aggressive weight management. And they have stressing on the point of the diabetes care team, which basically has to address the social determinants of individual healthcare. So we need to build a team. So clinic-based practice is becoming more and more difficult. And more aggressive strategies to reduce the cardiovascular disease through blood pressure control and LDL cholesterol goals. I mean, this is what the guidelines say. Fair enough, we all accept this. And this is the chart which takes you through how you start managing patients. So it's cardiorenal risk reduction plus comprehensive CV risk management. Now, ASCVD, indicators of high risk, heart failure, CKD, whatever it is, well, SGLT2 has taken the seat. Okay, we'll have to accept it because the evidence is very clear. So metformin and SGLT2 have already sealed their place in the management of type 2 diabetes. Now, the big question that comes is what after metformin, or in case you're not using metformin, or what happens after metformin and SGLT2? ADA 2023 guidelines also give us the answer. They straight away tell you if you want higher reduction of HbA1c, move to insulin because insulin will always give you the best HbA1c reduction. For any reason, if insulin is refused by the patient, they clearly tell you in the guidelines, choose the third drug which can reduce HbA1c by a much, much higher margin. So use and move to drugs with higher efficacy approach to target HbA1c. Very clear in the guidelines. I'm not saying this because Ganapathy can tell you so many other things later on after this my talk, but this is what the ADA 2023 guidelines, very crisp, still very hot, just 1 week old. What do you mean by drugs with higher efficacy of HbA1c reduction? Okay, so you can actually see this red square here very clearly. GLP-1, metformin, SGLT2, yes. Sulfonylureas and TZDs. And I don't even see DPP4 in that particular box. Nowhere near. Intermediate acting drug is what is a DPP4 today is. Now we have enough evidence to say that sulfonylureas can reduce HbA1c by 1 to 2%. Your DPP4 is only 0.5 to 0.8. So among the add-on OADs after metformin and SGLT2, I think an automatic choice is going to be your sulfonylurea. I did mention HbA1c reduction with sulfonylureas or next best only to insulin. Now, people have been talking about weight gain, don't use sulfonylureas. It's become adipose-centric along with cardiorenal. Sulfonylureas may add weight and things like that. Close the door, please. Okay. Now, let's actually check the facts. Is this statement true or is it just a myth? Do sulfonylurea really increase the weight? Showing you the data from Carolina. After 256 weeks in the Carolina trial, the weight gain was only 1.5 kgs. After dinner at Adore yesterday night, I'm sure many of you would have put on 2.5 kgs. After lunch, which is going to be good today, probably you will put on another 1 kg more. And here, 256 weeks, 1.5 kg, advanced trial, absolutely no weight gain. And this was for 192 weeks. So weight gain is not a problem. You just need to readjust your diet. Hypoglycemia, yes, can be a problem. So the ADA guidelines clearly says, consider avoiding hypo, especially in high-risk patients. Absolutely agreed. Sulfonylureas can cause hypo, but what is the extent of the problem? But before that, let's ask ourselves a question. When insulin is used, there is no talk of hypoglycemia at all. Even the company slides show hypo as the last slide or something. So we have to use insulin at some time or the other in all our patients. So hypoglycemia is something that you have to learn, you have to educate. So it's not a side effect of sulfonylurea, but it is the result of good efficacy of this particular drug. Even if you have to look at or compare hypoglycemia between DPP-4 and sulfonylurea, 9.1 versus 11.2, very small thing, a very small absolute difference. Even in Carolina trial, the important thing was, even though it was told that severe hypo was about 3 times more in the glimepiride group, admission to hospital with heart failure was much less in the sulfonylurea group compared to the linagliptin group. This is something. Coming to advanced, hypoglycemia was almost negligible, 0.7%. So what are the tips to avoid hypo? Yes, let's accept the fact that sulfonylureas do cause hypo. Prefer glimepiride or glycoside. The older sulfonylureas are being avoided. Start with a small dosage. You don't want to start with a higher dosage just because the FDC is available as 3 milligrams of glimepiride and 850 milligrams of metformin. You don't have to start that. Start with a small dose. Start with 0.5 glimepiride. Up titrate over a period of time based on SMBG. And most importantly, educate all your patients on symptoms of hypo and what needs to be done. And teach your patients to reduce the dose of sulfonylureas in case of hypo, just the way we teach them to reduce insulin. So reduce the dosage of sulfonylurea to half maximum in case if the insulin is being used along with this. Of course, we all know you must avoid sulfonylureas in elderly and high-risk patients, and then you look for alternatives, and then probably Dr. Ganapathy can win his case that DPP-4s are better. Is it cardiac safe? Yes, Carolina has answered. Advance has also clearly told us that it is safe. So both glimepiride and glycoside are cardiac safe, so you don't have to worry about it. So what will be my approach? Very simple. Somebody on metformin, SGLT2, use it if there is no contraindication. And still, after all your efforts, best of diet, exercise, medication, if the HbA1c is more than 8.5, which drug to add? I would straight away go for a sulfonylurea because it can reduce HbA1c to a much higher level than a DPP-4 and can probably bring it close to the target that we are looking at, which is 7. And if you want to use glimepiride, start with a small dose, up titrate over a period of time,
Same thing with glycoside also. And in case if they are contraindicated, of course, do not use. Definitely avoid use in elderly and high-risk patients, and then you can look for other alternatives. Now, why prefer sulfonylurea over DPP-4? I think it's one of my last slides. Remember, DPP-4 is a very, very weak molecule when it comes to HbA1c reduction. Some of the earlier trials, it was only 0.4. Then some trials, it was 0.6, 0.8 maximum. Their weight neutral, do not do anything to the weight. There is no weight reduction. Cardiac safe, but has no benefits. Not at all renal safe when it comes to majority of the DPP-4, except for 1 or 2. And when it comes to hypo, it is known to cause hypo when used with metformin. And when you use it without metformin, it's absolutely useless. So when you use it with metformin, it is known to cause hypo. And this is the slide which I didn't want to show, but I thought I will just show this because this is from our own study in Ramzan. And I know the Sardia people use this slide a lot, that hypoglycemia with sitagliptin was much higher than that of glycoside. And we also have some work with glimepiride and sitagliptin. So somebody saying DPP-4 does not cause hypo is a wrong statement, and that should be removed from the books. Durability, I don't want to go into this, much better with sulfonylureas compared to gliptins. So we all are clinicians, so we have to provide a patient-centric approach, and this is what we have been doing. A good physician, of course, treats the disease, but a great physician like all of you here in the auditorium, except for Dr. Ganapati, definitely will be treating the patient. So sulfonylurea in 2022 and probably 2023 as well, still standing extremely tall. I would still continue to use sulfonylureas for long, long periods of time. Thank you so very much for your patient here.
Any questions? Any questions, please?
Or you want to take the questions later on also? Yes, I asked the same question to Dr. Krishna Sheshadri today, that how long will you be giving GLP-1 based on the fact that your beta cell reserves may not be there. He said lifelong, because the beta cells never die. So you can continue to use sulfonylureas for as long as you want, as long as the patient is type 2 diabetic. So beta cells dying, beta cells apoptosis is a myth. In fact, Dr. Rohit Kulkarni has repeatedly shown in type 1 patients after death, when they have done the biopsies of the pancreas, still the beta cells are viable and active in type 1 patients after death. So that means beta cells remain there. They may not produce insulin. So sulfonylureas can be given for a much, much longer period of time than any other drugs. In fact, that's the question with DPP-4 also, because it has multiple hurdles. If there are no beta cells, then DPP-4s don't work. Yesterday, invited speaker, Dr. Lori Leffel, spoke of the Dynamo trial, when below the age of 18, classical type 2, the linagliptin did not work at all. Where SGLT2 worked, EMPA worked, linagliptin did not work in classical type 2 patients in the Dynamo trial, and they don't know why. I think Ganapati can come and finish, then we both can come back. Yeah, you have one more question. I think Ganapati can be here.
No, but this,
because he has some cases where he's going to show that.
The non-responders to GLP, did not respond to the, did you see anyone not responding to a sulfonylurea?
I mean, it's very rare, but in the textbooks, you do see that maybe 1 to 2% may not respond to sulfonylureas, and GLP-1, it's said to be 20%.
Yes.
Non-responders to GLP-1. So in clinical practice, sulfonylurea, what I have seen is about 1 to 2%, but you can't disprove this. It's very difficult. We try to blame the diet, no exercise for non-responding. So that's the thing. But still, in medicine, there are always non-responders.
Yes, thank you.
And there are also patients who don't pay. So,
Not working?
so you can come here.
Okay.
Yeah.
Dr. Vijay Kumar, thank you, sir. Dr. Arvind, we very precisely clarified the present role of sulfonylureas. This question has been lurking for the last few years in my mind because of the recent DPP-4 and even this SGLT, which has almost taken over the practice of diabetes. But my question is, by the time the patient comes to endocrinologist or a senior physicians, people already they have used sulfonylureas. They have failed there. The sugar is not controlled. They're taking maybe the maximum dose of metformin and sulfonylurea. By the time they come to us, it is about 300, 400 blood sugars. So the first thing we do is we add SGLT insulin, SGLT, depending upon the patient's preference, of course, insulin or SGLT inhibitors. And now DPP-4 also is coming up. But you have very clearly said, you start with the DPP or, start with SGLT inhibitors and metformin. If the SBA1C is not getting controlled, then add on glimepiride. But the practice, what we have, people already are on sulfonylureas. Maybe Dynel also nowadays, there people are taking glibenclamide. So how should we, program our management?
So the best thing would be when the sugars are extremely high, if they are not on an SGLT2, don't start with an SGLT2 till you kind of reduce the blood sugars, because especially the genital infections are much higher when the sugars are very high. Please give them the option of starting insulin for a brief period of time, bring down the glucose load, and then try to see whether you can add an SGLT2. I think this is what we do in practice. Very high, 400 and above, they are symptomatic, then start them on insulin, bring down the symptoms, bring down the glycemic load, and then probably you see whether you can add an SGLT2 and avoid using insulin for long periods. And if they're already taken sulfonylureas, it's okay. You can still continue sulfonylureas. And all of us have done it in practice. Sulfonylurea, metformin, SGLT2, DPP-4, acarbose, everything we have given, still not under control, then the patients have agreed for insulin. So there's nothing wrong if you're using all of them also, including pioglitazone. And only then they get convinced that, okay, I'm going to use insulin now. That has also happened. It may not look very conventional, but in practice, sometimes it happens.
Failure. Because by the time they come to us, already they have 4 milligrams of glimepiride.
I understood the question. This theory of a sulfonylurea failure or a beta cell exhaustion. Sulfonylurea failure, we don't have an answer. Beta cell exhaustion, it does not exist anymore in the books. I mean, that was a myth which has now been removed. It was just that the beta cells are still there. They're so exhausted, they may not be producing insulin. Reduce the glycemic load, reduce the glucotoxicity, and they start responding all over again.
Thank you, sir. I now invite Dr. Ganapathy Vanwal to deliver a talk on positioning DPP-4 in practice today.
Yeah,
Over to you, sir.
Thank you, chairpersons. First, let me make it clear. I'm not having a debate on SUs versus DPP-4. So that's the first disclaimer. I am telling facts where you can use DPP-4 inhibitors. 3, I think Dr. SRL forgot to tell that there was a study known as a guide trial, which came in the New England Journal, in fact. So what after metformin? We all know, okay, metformin, now it's all changed. You can use ASC, with ASCVD, even SGLT2 first, even before metformin, that's there. But then when they did a trial, SGLT2 was not there. Then the question was, what will it start after metformin? So they gave SUs, DPP-4 inhibitors, GLP-1 and insulin. And they found that the durability was the same for both SU as well as for DPP-4 inhibitor. It was the same. But then the weight gain was more with SU. So now what will it choose now? Which is better? Durability is same. DPP-4 naturally better. Agreed? Now these studies are all done in the Caucasians. Now in India, what happens is we have more DPP-4 activity, and the DPP-4 response is actually better. And there are, I won't say many studies, some studies telling at least the A1C reduction is more than 1.2. Caucasians less, agreed. I agree with him, but not for that. Okay, now coming to the topic proper. Worldwide, diabetes prevalence increasing. And in India, I will not go to this. Diabetes is a progressive disease. We all know that. UKPDS, that's what we learned. I told in the previous study also, talk also. Initially, we were thinking we just had two pathophysiological defects, insulin deficiency and insulin resistance. At the time, we were wondering which came first. The question was, which came first? Was it insulin deficiency or insulin resistance? And that was put to rest. The moment you get insulin deficiency, type 2 diabetes sets in. There are exceptions, of course, syndromes of extreme insulin resistance where insulin is completely normal, but still you get hyperglycemia. So except for that exceptions, the moment beta cell starts failing. And then we learned that there are other defects also, pathophysiological defects in diabetes. And that's what we learned from the famous DeFonso study, where you have increased glucagon, you have CNS neurotransmitter dysfunction. That's why we had a sustained release, quick release bromocriptins, SGLT2s came then. So all these things, so the more the merrier, because if you know the pathophysiology, you add another drug acting in a different pathophysiological pathway. And that's how this also came. You have the incretin. Till 2015, it was all glucocentric effect. Our target was bring the A1C to less than 7%. But then now, this has changed now. Now it is cardio-reno-metabolic benefit. It is not only glucose. You should also see that you have benefits in the other things also. So with all these things, rightly showed, sir told that it's an intermediate risk, but still, does it have a place? How many of them are using DPP-4 inhibitors? Please raise their hands. I think all will use because it's a progressive disease. We can't use only with one or two drugs. We will keep on increasing it. So yes, so this is the slide which he also put in. Yeah, DPP-4 almost is very difficult to see. We'll have to put a microscope and enlarge it. I do agree, but still we use it. So, okay, where will I use DPP-4? This is a mechanism of action. I think you all know I will not go into that. Okay, so 40-year-old newly diagnosed to have diabetes, fasting 190, PP 300, A1C 8.9, no other comorbidities, family history of diabetes, no osmotic symptoms, BMI 26.5. Now what will you use? Metformin, DPP-4, SU, SGLT2, combination of these things. Which one you want to use? Yeah, you can use metformin alone. You can use DPP-4. No, I will choose the metformin along with that. So you can use anything of them. But then since the HbA1c is more than 8.5, I would like to use a combination therapy. Now, why do I want to use a combination therapy? You know, the A1c reduction with only metformin is around 1 to 1.5. It's around 8.9. So this is a time where I would like to use a combination therapy. So what did I choose? I chose metformin with DPP-4. Can I use an SGLT2 with the DPP-4 inhibitor? SGLT2 with the metformin? Yes, you could use, but I don't have the time to tell him, okay, when you use this, you'll pass more urine, you will have a genital mycotic infection. Please take Candid cream, you apply that, and then use fluconazole. Please don't disturb me. So these things will start happening when you use this. Only 15% of the patient or 20% of the common garden variety of type 2 diabetes have an ASCVD risk factor at the time of presentation. The common garden, what you see, me see, is 80% do not have that. They just have hyperglycemia with some little bit minor risk factors, you can say. So why do you want to use an SGLT2, spend time, busy OPD? I don't have time in SGLT2. The moment the patient comes, we are writing prescriptions. So in these type of scenarios, I think we don't have time for all these things. So I chose this. Why did I choose? Because the traditional approach, if you see only giving metformin, you see that the glycemic dyslegacy is actually increased because you are waiting. You give 500 milligram twice daily, doubling the dose, only 0.3% increase in HbA1c of metformin when you give 2 grams. Instead of that, we know the Verify trial. What did we learn from that? You start combination from the beginning. The dysglycemic memory actually comes down. You have more durability in this type of patients, the Verify trial. The time to primary failure was you brought down by 50%. Secondary failure going into the insulin brought down by another 25%. So what do you want to use? You want to give metformin, then go up? No, I think the ADA also now endorses this. Start combination therapy from the beginning. And this is the rationale why I chose this, because the A1C was more than 8.5. Normal drugs, 1 to 1.5 maximal. Okay, another case, 70-year female, type 2 diabetes, 5 years, metformin, A1C 8.1, 156, 248, postmenopausal osteoporosis, she's on bisphosphonates, statins 20, telmisartan 40, which OAs you want to start? I started on DPP4. Once again, I don't want to start in a postmenopausal woman who is 65, how much, 70 years old, given SGLT2 inhibitors. Yes, it's good, I do agree, theoretically all good. But then she'll come next day, she'll go to the gynecologist because she's having genital mycotic infection, not going at all. She doesn't know why it has happened unless you explain this is going to happen. That is number one. The second thing, elderly, partial drop. Thirdly, they may become frail. If the patient is lean built, you lose another 4 or 5 kgs. Now she's not able to walk because she's losing weight. So these things can happen. I know the good things, but then I think we should individualize. So this is another place. What is the advantage? No hypoglycemia. It's good for bone. SGLT2 are bone suspect, whereas DPP4 and the GLP-1 are good for the bones. No risk of UTI, just give it, send her off. Nice guideline says in elderly, whatever you just give this. You don't have to talk to the patient, just give, fill it, forget it. No, it's like that. Just give it, send him off. No risk of UTI, weight neutral. So that's another advantage. Case 3, 76-year-old, newly diagnosed, A1C 7.9, started on metformin. Now the patient has metformin intolerance, diarrhea 20%, 25% having this. BMI 22.4, which OHA you want to use? You could still use an SGLT2 or a DPP4 because now we want to use anti-hyperglycemic agents. We don't want drugs which produce hypoglycemia. I chose this. Why? Weight neutral, no hypoglycemia, no increased risk of falls, no increased risk of UTIs, no partial giddiness with this drug. Case 4, 10 years diabetes. This patient is already on a metformin SGLT2 combination. A1C 8.1 on statin, on blood pressure medicine, family history of CAD present. So yes, now you can add this as a third drug also. So it's not that you have to use it first line. Yes, there is a role for the DPP4. Yeah, it's come down a little bit, do agree. Add it as a third line because no hyperglycemia. It's CV neutral. We have a lot of studies telling that no weight gain, no. And when you combine with an SGLT2, theoretically, the risk of genital mycotic infections also come down. So third drug also, you can use it. That's the role. Diabetes 15 years on basal bolus regimen, SGLT2 on metformin twice daily. Patient was on empagliflozin metformin, A1C 8.2. In spite of all these things, predominantly postprandial hyperglycemia, how will you manage him? Yeah, what you can do, one is add a TZD. We don't want to add that. SUs will produce unpredictable hypoglycemia. You can use it, but the problem with an SU is unpredictable. Today it will work, tomorrow it will not work. So that's the disadvantage of an SU when the patient is already on an insulin. So we are not sure when the patient will get hypos. You can add DPP4, yes. You can add acarbose, yes. Acarbose, the problem is you don't like him, you put him on that. A lot of barbarghermi will be there. Not good to be in a social setting. So these are the problems with acarbose. 3 drugs are required. You have to use 3 times also. Use a DPP4, 1 drug. Why don't you increase the dose of insulin? You can, but what happens when you're starting chasing the insulin, you get a late postprandial hypoglycemia. So that's the problem with the insulin. You don't chase this insulin. You try to adjust it. You tell him, okay, take it now 40 minutes before food or 45 minutes so that you see that the peak of the postprandial comes down. Or you tell him walk 10 minutes after food, or you take some, say, sprouts or something like that, which contains more of proteins so that the excursions come down. These are some of the things, tips you can give him. But in spite of all these things, if the glucose is going up, I wouldn't like to increase the dose, but maybe add a single drug of this medication. Weight neutral, low risk of hypoglycemia, controls PPG with a single dose of, and there is an appropriate increase in glucagon. That's the important thing. So now, when the patient is on a basal bolus regimen, he's having duration of diabetes long, very long. So what happens is he is prone for hypos, and this will stimulate glucose appropriately. So at least theoretically, I would say it reduces brittle diabetes. So appropriate release of glucagon can happen when you give this drug. I think this is the last case. 20 years, CKD, 2.4 creatinine, hypertension, dyslipidemia, recurrent hypos. What will you do? Patient is on pre-mixed insulin, small dose, 8 and 6. So what you have to do, either change them to basal bolus, small dose, or give only the short-acting insulin, which will act like an intermediate-acting insulin. Then also we are not predictable. So what you do is add a DPP-4. Like, of course, you can't use all of them, like a linagliptin without dose modification. These are some of the things. Sitagliptin, you require dose modification up to 25 milligrams. Saxa, not recommended, less than 30. For mild, up to 2.5. Vilda, once a day. Aloe, 6.25. Lina, no dose. So I told the good effects, a little bit about the side effects. Rhinorrhea. Sometimes you find common cold dose there. You give azithromycin, levofloxacin, augmentin, is not going. Stop this for a week. They become better. Skin lesions. Many times patients are already taking this for 2 years and now they come with a skin lesion. Stop this, disappears. It will not go overnight. At least 1 to 2 months are required for this to go. Severe arthritis is not improving. Stop this drug. Angioneurotic edema, rarely, once in 2-3 years, we get one patient. Do not use in patients with pancreatitis, another important thing. Drug interaction, especially with saxagliptin, which can happen because it stimulates the CYP3A4/5 inhibitors. And then lastly, it's only neutral, but not CV benefits. So what is the reason why it was not beneficial? So one they say is there was some sympathetic activation, interaction with the ACI Y1 receptor activation, which produces a pro-thrombotic state. Though theoretically, reduce inflammation, reduce oxidative stress, nature uses BP came down, endothelial progenitus increase, lipids reduce, everything good, but no benefits. And this is one of the reasons why this happened. There are some non-glycemic benefits, useful in psoriasis, bone friendly, useful in inflammatory bowel disease. You have, see, when you give a DPP-4 inhibitors, it also stimulates GLP-2. I mean, in the sense, the GLP-2 is increased, which is present in the gut. The short bowel syndromes and all this is actually useful. And linagliptin alone has been found to be useful in tissue healing when you have infections. So to conclude, DPP-4 inhibitors have been available for a decade and are indicated for patients with type 2 diabetes. With moderate efficacy and a paucity of side effects, these drugs have gained worldwide acceptance, are commonly used as second, third, or even fourth line agents. Results of CV outcome studies have been neutral, except for Saxa, where you shouldn't use it in patients with heart failure. Thank you for patient hearing.
Any doubts from the dignitaries, please? Any questions from the audience?
Not required.
After how many days of starting of DPP-4, we need go for ultrasound?
No, but why do you want to go for ultrasound?
Any of pancreatitis is there, we don't.
No. See, it's, you don't have to do. See, in 2014, the FDA came out. It's not very clear. The cause and effect not proven. So that's the reason now we are, after that thing, we are actually not checking for that. So suppose only thing is, if you're using a GLP-1 agonist, then you have to be a little bit cautious. Look, see whether the patient has gallbladder stone. Pancreatitis is because of that. But then patient will blame you. So that's the reason then you have to be cautious. Otherwise, I don't think we have to do an ultrasound abdomen at all for patients using DPP-4 inhibitors.
Thank you. Thank you.
Okay. Sir, any comments from you?
No comments.
Right. No questions?
Any questions?
First case and the last case. Last case is fine. First case, I was started before because I don't have time to explain all that.
No.
Pass a compliment. Vanpal.
Yes.
Very nice hearing to you, and you have very precisely told what are the indications where we can give. That reminds me, third year lectures from one of the senior professors, most of them are not there. They're, I mean, rest in peace. But they passed on a message, what they call individualize the patient. This is what the message I'm getting it, hearing to Arvind and hearing to you. We had to individualize. There's
Right.
no one single drug. There's no magic pill. There's no combination of these things. It's like, we have 4 things. Like a cook, no good cook. He has salt, he has some pepper, he has 4 things. He makes a nice dish out of it. Similarly, we have 4 or 5 drugs now. We have to mix it in such a way to individualize so that we achieve the glycemic control.
Right.
Thank you, sir.
Thank you, sir.
Any more questions? Thank you, sir.
Thank you.
The next session, there is a small change. The next session will be on HL2 inhibitors by Dr. Krishna G. Sheshadri, consultant endocrinologist from Chennai Diabetes and Endocrinologist Clinic, clinical and research lead, Apollo Sugar. Sir, please, sir, over to you.
Just to give you a disclaimer for my talk, you name the pharma that has given SGLT2 inhibitors, and I have taken speaking honoraria from them. It's a very interesting journey. So you notice that it is a drug talk, but I will try to keep it as balanced as possible. It's actually a very interesting and unanticipated journey in many ways, simply because I was one of the first people in the country to give a talk on SGLT2 inhibitors when dapagliflozin was launched, and it was done in this very city at that time. And seeing how this molecule has evolved over time is actually a very unanticipated journey, right? So I don't want to get into the pathophysiology of everything, but today there are 2 things that have happened in diabetes. One is a focus on obesity that is emerging, and I talked about it this morning. The second is the focus on complications. It's not that these are driven by the availability of the drugs. It's just that our understanding about the disease has evolved over a period of time. For example, in 2003, we never knew about the contribution of the kidney to the glucose in the body, the gluconeogenesis that occurs in the kidney, we didn't know. But now we know a lot more about these things. And at the same time, we've understood, because of statins, that ASCVD becoming a little less prominent. On the other hand, heart failure becoming a more important drug. So clearly, these are things that have occurred as we have evolved in our care of diabetes, from a glucocentricity to a mortality and complication centricity. But thankfully, in the last decade, we've had drugs that are able to prevent or delay these complications. And especially with CKD, I think the one important thing to remember is since 1984, there has never been a single drug available that delayed or prevented complications till the 2010-15s, when the first time we heard about the SGLT2 inhibitors, right? So it's like an apple. And remember, fluorescein is an old story. Fluorescein is isolated from the bark tree, and from this is a selective SGLT2 inhibitors. There are different kinds of SGLT2 inhibitors depending on the selectivity of the SGLT2 transporter. Remember that we don't know what is the clinical benefit to different kinds of SGLT2 inhibitors, although, an SGLT1 thing that people talk about may not be very relevant to our mechanisms because it's mostly in the intestine, right? With SGLT2 inhibitors, especially dapagliflozin, we have extensive phase 3 trials. I'm not going to spend time on looking at each one of these, but we will look at some of the pivotal studies that we have looked at it. This is the declared TIMI 58 trial, and it's very simple. What it looked at is a randomization versus placebo, 4.2 years, a significant number of patients were primary prevention as opposed to the empagliflozin trial. And interestingly, many patients had urine albumin creatinine ratios that were high, but also about 68% were low. What did we see? The renal specific endpoint, which is there was a reduction in 48% in the risk ratio in those who did not have significant albuminuria, 41% reduction in risk in patients with significant albuminuria, and 62% risk reduction in patients who had albuminuria that is greater than 300, which is a macroalbuminuria range. And similarly, you would find a reduction in heart failure. So what the SGLT2 inhibitors have done is that they have positioned themselves as cardiometabolic drugs, and especially renal cardiac, especially with heart failure. Heart failure benefits and the renal benefits go hand in hand and are often independent of any other outcomes. So CKD is very high, and this is a REVEAL CKD trial that showed 92% with type 2 diabetes have undiagnosed stage 3 CKD. So I don't know how many of you use a KDGIO classification. Have you heard of this before, the KDGIO classification? If you have not, I think every time I talk about measuring eGFR and not creatinine. Have a small app that measures eGFR. Now I'm telling you, learn how to use the KDGIO classification. It divides you into albuminuria, non-albuminuria, and the eGFR reduction. So whether the eGFR is less than 90, less than 60, less than 30, or even lower, gives you the G, the GFR. Whether the albuminuria is less than 30, greater than 30, or greater than 300, tells you the A. So in our EMR, which I use, we now started saying A1G2 DKD or A2G3 DKD because it tells me how to position these drugs. So besides measuring the eGFR, one of the simple things that we all need to learn is to know what is the renal dysfunction that the patient has. Because unlike the past, we have enough medications to reverse or halt the progress of renal dysfunction. Right? This is a DAPA CKD trial that did exactly that. And interestingly, what it showed is that between an eGFR of 25 to 75, that's a widespread that no other trial had before. What happened was that there was a benefit, one, in the primary composite outcome. For every 19 patients treated, there was a reduction in the risk. There was a 31% reduction in the mortality and a reduction in both. As I said, heart failure and renal failure go hand in hand, a reduction in both. Right. And it was irrespective of the glycemic status, whether you had diabetes, not diabetes, or impaired fasting glucose. What it did was it reduced heart failure risk progression. This is similar, but somewhat lower. Remember, these are apples and oranges. Was achieved in the EMPA kidney study, and this is just a comparison of it. The EMPA kidney study had a larger number of patients, a higher NNT, right? But remember that there are some differences here: greater than 50%, greater than 40%, a whole bunch of these. I would still believe that some of these are a class effect, but the data seems to be a little more robust with dapagliflozin, right? So it is recommended as a first-line therapy for patients with diabetic kidney disease, independent of the A1C. With heart failure, I want to introduce a new thing to you. If you've not heard of it, I'm sure all of you have heard of HFrEF and HFrEF, right? HFrEF is when the eGFR is, the ejection fraction is less than 30 and lower. HFpEF is a lowering of the ejection fraction, not to the HFrEF level, but having some amount of shortness of breath. I'm going to introduce another term for you. Now that all of you look at ejection fraction in the echocardiogram report, I'm introducing two new things you should do. One, annually in many patients, especially over 10 years of diabetes, start measuring a test called NT-proBNP. NT-proBNP, if you don't have an echo in your clinic or nearby, an NT-proBNP is something that any lab can do. and gives you a great idea of what is the heart failure risk of this patient. If the NT-proBNP is more than 125, then that is a patient that requires an echocardiogram. I'm going to teach you one more thing in the echocardiogram. Look for something called the E prime. If your echocardiographer doesn't do it, ask them to measure it. It's not difficult to do. If the E prime is more than 15, then there is a high likelihood that this patient has HFpEF. So HFrEF, HFpEF. And in primary care practice or general medicine practice, which most of us do, we talked about eGFR measurement, albuminuria measurement. Now I'm telling you, measure NT-proBNP, because today we have the ability to reverse the effects or at least prevent its progression. So in the last 20 years, heart failure has become one of the most important causes of cardiovascular death. Because all of us use statins well, ASCVD has come down, but heart failure is the number one. And if somebody has heart failure, the 5-year mortality is greater than 50%. This is the HAPA-HF study, and it looks at heart failure. And people look at the median NT-proBNP was 1,437. Remember, the average NT-proBNP in a non-diabetic population is less than 125. The average left ventricular ejection fraction was 31%, and 41% had an EGFR less than 60. Remember, heart failure and DKD go hand in hand. What did it show? It prevented CV death. Absolute risk reduction of 4.9%. It prevented worsening of heart failure. And also there was an all-cause mortality reduction of 17%. So in terms of cardiovascular protection, reduction in glycemic control, irrespective of the glycemic control, it works, reduces all-causes mortality, reduces CV death and heart failure, useful in primary prevention, reduces CV death in HFrEF. And of course, most of us know now that SGLT2 inhibitors are safe. They can be used in the elderly. I have noticed some tiredness in a group of patients. Be careful. Just the way I use it in our practice is, I look at another index that we use called frailty index. If somebody is very frail, I still am a little hesitant to use it. But enough comparisons have been done in the elderly, you can use it. Second, it can cause genitourinary infections. And combined with a DPP-4 inhibitor, these genitourinary infections are less. Overall, with Indians who wash their genitals, and if you reinforce it, many of them actually do well without genital infections. Why do you get genital infections? Because glucose is pushed into urine. Remember that there will be glycosuria by the lab sample. We warn the patients because they will need to be alerted of that. The second thing is, when you get a GU infection, you can treat through it, meaning leave the drug on board, use topical antifungal agents. Many patients will get over that phase and continue to use the drug. It's very rare that you have to completely stop the drug. Patients are comfortable, they lose weight and do a whole bunch of other stuff. This is the drug part. Remember that now that choose one drug and stick to it. There's always more data with the promoter molecule, and look for bioequivalence before you substitute a drug. I think that's something that all of us need to do. For example, in statins, compared to the innovator statin versus the generic status, there was a problem with the generic drugs. In India, we have branded generics, so each of them have their own mechanism. Make sure you have a system of comparing these drugs before blindly switching patients. I was talking about it this morning about, for example, thyroxine, where thyroxine generics don't do as well. Clopidogrel especially had a big problem. For example, there was a 2-fold increase in stent thrombosis with generic OADs. So if you have to use a generic, just be careful. Branded generics are also an option. But most importantly, if a patient doesn't have to switch from the innovator, don't do it. Right? So with this, let me stop here. I've used Foxaga and dapagliflozin as an example. Many of the things that I've told you today apply to all the SGLT2 inhibitors. So when should you use an SGLT2 inhibitors? One, at any spectrum of the diabetes care. If you want to reduce the risk of heart failure, want to reduce the risk of renal dysfunction, if you want to prevent further occurrence of cardiovascular events in patients with established ASCVD. There are many people who think that it should be added to Bangalore's or Chennai's water supply. I don't think we are there yet, but there are many advocates of that. But it also tells you how much this class is there. But I've also noticed that there is still quite some hesitancy in using these patients, simply because I think doctors like us who keep on talking about the science and all the confidence intervals and the risk ratios don't make it simple. Simple things is, when should you use it? Any diabetic, you can use it. When can you use it? Right from the beginning up to the end. Even if the eGFR is low, you can use it. So this is one. Third, what is the only thing you should worry about when you use a patient testing? One, if the patient has genitourinary infections, you should worry. Second, if the patient, the eGFR drops greater than 30%, you should worry. You should expect a small drop in the eGFR when you give the drug. It tells you that the drug is working. Similarly, the hemoglobin will rise a little. That tells you the drug is working. These are all good things about the drug. All the special situations is great, but it doesn't take away the fact that it's a good anti-diabetic agent. It also, the way I look at this drug is, it's a good anti-diabetic agent. It also reduces heart failure. It also reduces kidney function. It also prevents a second occurrence of ASCVD in patients who already have ASCVD. If you start looking at it and it has very few side effects, the only major one is genitourinary infections. If you start thinking about it, then you don't have to be afraid of using this drug in practice. People are very comfortable with DPP-4 inhibitors simply because we think that they don't have a lot of side effects. But we are intimidated by SGLT2 inhibitors because we think it's a cardiologist drug or a nephrologist drug or an endocrinologist drug. No, it's a drug for every primary care physician, and we should start getting comfortable using that. With that, I will stop, and it can be used in combination with metformin, with DPP-4, with GLP-1RA, and with insulin. The only place where I would be careful is type 1 diabetes. While there is data, it can also increase euglycemic ketosis. In all other circumstances, I think every primary care physician should really get comfortable with the use of these drugs. Thank you so much.
Thank you, sir, for that wonderful
we
talk
have
and
some time.
take-home points. The floor is open for questions.
So I don't use 5 milligrams of dapagliflozin because it's very interesting, because SGLT2 inhibitors, of all the drugs, the 10 milligrams is actually a submaximal dose with dapagliflozin. I remember the original data, and I was always wondering why they don't have a 15 or a 20 milligram. So 10 milligram works. Second, I don't believe in homeopathic doses. And I don't think that Indians are so different from the rest of the world that they should have a smaller dose. The only exception is pioglitazone. Third, it's very interesting that, and I'm going to use the EMPA study, is that there was a difference between the 25 and the 10. In fact, the 10 did better than the 25. But I don't think there's data to support that the 5 does better than the 10. And in these kind of tablets, please don't break them. And I don't think, we don't know what, these are modern drugs. I don't know about what happens if you break them. So all this jugaad is fine, but I wouldn't do that. No, I'm not. I'm not. I'll be very honest with you. I have no, I believe that Indians are like 99.99% of the rest of the world. And there is no need to do, see, I hope you guys don't, people don't mistake me. If you mistake me, it's fine. I am personally of the opinion that India is not a poverty-stricken fourth world nation. I'm very proud of what India is. This is not the India of our teachers where, the wards would smell of gangrene. This is a proud new India, and I will tell you about our patients. I am very proud of them. They may want free care for some time if they have a problem, but they take pride in saying and paying for their consult. There's not a single patient who has come to me who said, "Doctor, I don't want to pay." An IAS officer will say that, but not regular, hardworking people. Right? Be proud of our patients. They deserve the best in the world. And luckily, and let us also give it to the pharma industry, because they have leveled the playing field for us. No longer can a patient say that, it's affordable or not affordable. Today one dosa is what, 200 rupees or 150 rupees in most places. It's a daylight robbery everywhere else. But what I'm trying to say is the days of extreme poverty in this country are over. And my personal view is the most cost-effective way to practice medicine is to do the most appropriate thing first. Let's do the right thing. If they need only 0.5, then I would rather have them on a DPP-4 inhibitor and something else.
Sir, how long will the weight loss effect continue?
3 months, and then it'll and then your fat cells will ask for a pizza. So it's very interesting to understand what happens to the body when you give an SGLT2 inhibitor. We are the only species that eats and kills for entertainment, right? So from a historical perspective, food and energy were scarce, correct? So we have redundant mechanisms to take energy back. So normally, not even a single milligram of glucose is secreted in the urine, correct? So what happens is when you are in a glucose loss and you're looking at about 50 grams per day, what will happen is at some point of time, the metabolism is reset and you will start eating more with an SGLT2 inhibitor. Therefore, after some time, you will find that the total energy intake actually increases around about the 3rd month. And you will notice that either patients are plateauing or they're actually gaining weight. So the weight loss is not permanent and it's not always going to be there. It's going to be plateauing and actually increase if the patient doesn't watch their diet. So that is what you're seeing at the end of 3 months, saying no further weight loss is because of this. Your body craves for food. Any other? Okay.
Thank you, sir.
Thank you so much. Thanks for inviting me here. Appreciate it.
Next, we have an interesting talk about choosing the right patient for glitazones and AGIs. We have Dr. K.N. Manohar, sir, to deliver the talk. Sir is a consultant physician and diabetologist in Sharada Medical Center and Manipal Hospital and a chairman-elect Kerasis DI. Over to you, sir.
Thank you, everyone. I think my job is very easy. If you have heard the previous 3 speakers and the choice is left after that, then you choose one of these 2 drugs. And I think so, rightly, the last of this topic, also possibly off late, at least we can say, the last of the drugs to be used. So just to begin with pioglitazone, in the last 3 years, how is the usage of pioglitazone in your practice in the last 3 years? Is it same? Is it increased? Or is it reduced? Is it same? Any show of hands? Reduced? Increased? Not so much. So a lot of you for reduced. I don't know whether I have to ask this question. How about the alpha glucosidase inhibitors? It's same or same? Not reduced. Okay, that's interesting. So not sponsored talk, so nothing much from any pharma. So I think Dr. S.R. Arvind was rightly saying, guidelines is a guideline. It's not a law or rule. And guidelines deal with the disease. Doctors deal with the patients who has the disease and have much more other things, socioeconomic constraints and etc. So I think whenever a patient sits in front of us, these are the oral anti-diabetic drug for comparison. Of course, the oral semaglutide is not put up there. And these are the summary of benefits is what we should have it in our mind. And after a discussion with the patient, with respect to the risk, I will show you to the how it is already showed that how the guidelines also has become more patient-centric, and they are looking at hypoglycemia as a concern, or ASCVD is a concern, or a heart failure is a concern, which drug to choose. So I think they have made our life much more simpler. And I think all the benefits Dr. Krishna Sheshadri alluded to with respect to SGLT2 inhibitors. Among all the drugs, group of drugs, this glitazones especially had a torrid type, isn't it? So one of the first of the glitazones, rosiglitazone, got banned. Even pioglitazone took the same path, and in few weeks, pioglitazone was reinstated. So there was a lot of drama about this drug. And of course, we know that insulin resistance among all ethnicities, we have much more insulin resistance, and that is the thin fat Indian concept, what we all know. And what drugs can help it? Metformin, TZDs, of course, lifestyle changes are always there. So we all know PPAR gamma receptors are the seat of action of pioglitazone. They also have some alpha action, gamma G glucose pathway, alpha lipid pathway. So pioglitazone and the newer one, lobiglitazone, and of course the rosiglitazone also had some significant benefits on the lipid pathway. Also improving the HDL was always an important entity. So what we should really know, this is how they act. Inexpensive drug. Nowadays we have a lot of drugs which have become inexpensive or as expensive as sulfonylureas or pioglitazone. Efficacy and durability are unquestionable. I think before the DPP-4 SGLT2 inhibitors large scale trial, the largest durability data was with rosiglitazone. So no dosage adjustment in renal failure, but I don't know how many of us are comfortable using pioglitazone in renal failure, mainly because of the edema. Secondly, most of them will have some amount of LV dysfunction. So that is, even though this is a big factor initially, if you are sure that there is not so much of edema to deal with, and heart failure is definitely not their LV dysfunction, then still it can be a good drug to be used. But I hardly use it, to be very honest. And another important thing is this one, 2 months. For it to take control and give a good glycemic efficacy, pioglitazone requires 4 to 6 weeks at least to show good efficacy, unlike the sulfonylureas and unlike the SGLT2 inhibitors, which can start working much faster. So these are the points which we need to keep in mind when we start writing these drugs. Bladder cancer controversy is done and dusted. Of course, people with history of bladder cancers or strong family history, or people who have hematuria, we should not use it. Another thing is the weight gain. Okay, so weight gain, we spoke in the KRSSD also, KG-A1C paradox is what we say. When you gain weight, it offsets some of the benefits of A1C reduction. But does it apply to pioglitazone? There's no study or data for me to show whether weight gain due to sulfonylureas could be detrimental with respect to mortality. But with respect to pioglitazone, because it causes healthy weight gain, if you look at the abdominal obesity parameter, subcutaneous fat after 16 weeks increases. That's what we see. But the visceral adiposity comes down up to 25%. So we accumulate good fat. So that is one of the pro points towards the use of pioglitazone. And if you look at the metabolic syndrome or insulin resistance syndrome, it has favorable benefits with respect to the metabolic syndrome. So usually we are very scared to use in obese people pioglitazone because we think it may gain weight. People may gain weight further, but they are the group of people who also benefit more with respect to the use of pioglitazone because of all these factors, which I don't want to read it out. Pleiotropic effects, as I said, alpha effect is there. So improvement of the lipid parameters favorably to reduce the ASCVD risk is a parameter what we should know. And some amount of effect on the systolic and diastolic blood pressures are also there. Most important point, what you should note is no other drug has shown to prevent ASCVD as well as pioglitazone. So no antidiabetics showed better ASCVD reduction than pioglitazone. The drug which comes closest is the GLP-1 receptor agonist. So this is the point which is almost always forgotten because we are always discussing SGLT2 inhibitors and more. So this is where it is a very, very useful drug, cheaper, efficacious, and prevents ASCVD in a larger way. And again, this is just a schematic representation of where all it has beneficial effect on coronary artery atherosclerosis, lipid levels I told, improves endothelial function, redistribution of adiposity. It helps us to have a good fat and blood pressure and carotid artery atherosclerosis, especially the stroke benefit with respect to pioglitazone is much more even than what SGLT2 inhibitors give. In fact, the EMPA outcome trial showed maybe a skewed report with respect to the stroke prevention. So that's what I was trying to say. Effect of glucose lowering drugs on the combined endpoint of CV mortality, non-fatal MI, and stroke. If you look at it, the proactive where pioglitazone is used and you compare it with other molecules, including the semaglutide, there is a significant p-value reduction, and glargine or Saxa or lixisenatide or sitagliptin didn't show much of benefit. In fact, the benefit is even better than what empagliflozin has given in reduction of CV mortality, non-fatal MI, and stroke. Safety concerns, edema, a lot of theories to it. Is it because the renal collecting duct is the major site of increased fluid reabsorption and this promotes it? And increased vascular permeability in the adipose tissue. So these are the causes of the edema. Somehow it doesn't go away. For example, you have an edema with amlodipine, you can use ARBs to reduce edema. This edema is very difficult to treat, and it is a bit more when you use insulin alongside. Weight gain, bone fractures, and macular edema is another complications which we should be aware of. Nowadays, the new kid on the block is lobeglitazone. If you want to just know about lobeglitazone in 3 sentences, there is no head-to-head comparison against pioglitazone as monotherapy. Of course, on the background of metformin therapy, it has shown equal efficacious. 0.5 lobe has done as well as pioglitazone 30 milligram. So efficacy is matched, but edema data is skewed again. Few of the trials showed much more edema than pioglitazone, but some of the trials showed slightly lesser edema with respect to lobeglitazone as compared to pioglitazone. So Rosi, Pio, and lobeglitazone are the 3 of them. Pioglitazone is in use. Rosi is out. Lobe, I don't know how much effect or impact it will make it in our prescription or day-to-day practice. So we need to balance the effect, as I said, the favorable and the adverse effect reactions, and then choose the right patient profile. Who is the right patient? Most insulin-resistant patients, as you see, their increased waist circumference, lower HDL, and fatty liver. Don't forget, the one of the drugs which really works well with fatty liver is pioglitazone. Of course, nowadays we are getting data from SGLT2 inhibitors, especially EMPA and DAPA, gaining mileage with respect to NASH. But the drug which really works well with respect to the having fatty liver is pioglitazone. And we all know up to a third of patients with diabetes will have some amount of fatty liver with them. So pioglitazone is the drug which we need to consider. Wrong people, very, very important. As I said, bone mineral density, if you suspect it to be low or if you're measured and it is low, it increases the risk of fracture. So don't use it. Heart failures is a strict no. That's where, even though the renal compromised patients, we can use it. Sometimes we are very difficult or scared to use it because they usually have some amount of cardiac issues along with them. And elderly who have a risk of heart failure and active bladder cancer or history of bladder cancer or a strong family history or someone has an unexplained hematuria, try to avoid pioglitazone in them. So it is definitely an important therapeutic option, and it reduces, as I said again, the drug which reduces the MACE, stroke, and MI risk is pioglitazone. It is even slightly ahead or as good as SGLT2 inhibitors in these aspects. And if someone is on the metabolic syndrome side, which is most of us are, most of our patients are, it is always a good drug to be kept in our armamentarium and not to just brush it under the carpet because of the noise made by the other drugs. And never forget, if someone has a NASH or NAFLD, it is the drug to be considered to use. So first oral agent, yeah, you can use it if metformin is not tolerated or contraindicated. Second oral agent, definitely you look at this subset of patients, which are quite a lot of chunk of patients. If you put these two criteria into the patient sitting in front of us, I think we will have almost most of the patients covered with respect to the utility of pioglitazone and of course triple drug therapy and even insulin. This is another phenomena by experience. When someone is on pioglitazone and you take them off for some reason, their control goes really haywire. So it does something more than any other drug to keep the glycemia under very good control. So sometimes even with insulin, it has done wonders, but the risk of edema is higher, but still it could be used everywhere in the treatment pathway of looking at a patient in front of us. So this is the bottom line. I think I already alluded to that. It is a very good drug for risk reduction and reducing the all-cause mortality. But heart failure risk is definitely there, and that should be borne in our mind. Alpha glucosidase inhibitors, I know Dr. Neethar raised her hands, but I don't think of course, we always said that Indian diet and Indian type of postprandial surge, but then we don't have so much of data as opposed to the newer class of drugs which they have with respect to CV risk reduction or even the renal compromised patients. So that is where, when I think even in my practice, I'm maybe reducing the use of alpha glucosidase inhibitors. It's definitely not like what I was to use a few years before. And we all know, and it has to be given with the first morsel of the meal. That is a bit of a challenge, especially when you are using, you have to sit in front of the plate, have one bite, and then have the drug, because that is when these enzymes get expressed, and that's when alpha glucosidase inhibitors goes and blocks it, and then the absorption of the saccharides come down and the postprandial surge comes down. So that is the first key message, is definitely it has to be given with the meal. After the first bite, it should be given, which is not always easily comprehended. You ask your patients, many of them will be taking half an hour before or after the meal. Actually, the utility of alpha glucosidase inhibitors in that triple drug, what we have written, is zero there. Actually, they will be taking only the effect of glimepiride and metformin, but the alpha glucosidase is a placebo, or still worse, it can be just causing GI side effects. So that is the most important message what I would like to give it. And as I explained, the postprandial surge gets blunted by this use, but we have other drugs also to tackle the postprandial problem, like DPP-4 and insulins, especially the short-acting insulins, and DPP-4 also does well with the postprandial surge in the glucose. And these few, like every drug, I think it all started with the statins. Statins is not just for lowering LDL. It has so many pleiotropic effect. It was a long note when I was writing my MD exams. So after that, I think every drug comes up with their pleiotropic effects. Again, effect on the lipid profile, to an extent, an effect on the blood pressures. But this is not as fascinating as what SGLT2 inhibitors or even pioglitazone showed. So there could be a minor effect, just to mention it, rather than really working on it to say that it is very beneficial or as an add-on drug. So if you look at the reduction in the A1C, I think Dr. S.R. Arvind already told the best effect is 0.4 to 0.5 HbA1c reduction. But we all started looking at Indian diet, Indian carb-rich food, and postprandial as a risk factor for independent risk factor for CVD. And still we say that, okay, comparing to placebo, yes, definitely it does better. But if you put the first slide, what I showed, efficacy of the drug, I don't think alpha glucosidase inhibitors stand so much of a chance unless we really see that it works well with the Indian sort of a diet. And lower risk of hypoglycemia, mechanistically it should be almost zero. But one important point is, if someone, we're using multiple drugs and also alpha glucosidase inhibitors are there, and someone goes into hypoglycemia, a starch or a complex carbohydrate will not improve the glucose. We should either give IV, or you should give simple glucose, Glucon-D or whatever, directly to drink, because by the virtue of its action, it blocks the absorption of the starch or complex carbohydrates. So the risk of hypoglycemia is slightly high. But there is an interesting twist to it also, because it makes the carbohydrate-rich food to stay in the gut for slightly longer time. It has an indirect incretin effect. Incretin effect is mainly because if you give the food carbohydrate challenge with respect to the gut and the IV, there is a difference. Because the carbohydrate stays longer, it has a minor incretin effect like thing, which is important. And because of the same reason, it also reduces the risk of sulfonylurea-induced hypoglycemia also. So these are some two additional points, but they are very, very more of a theoretical, exciting discussion rather than practically how much it's useful, we don't know. So contraindications, gas, I think half of our practice outside, if you're a physician, is related to the gas. So most of the people are always bloated. So we need to make sure that people who already have a lot of acidity, sometimes it may not even worsen it. I've tried in few patients, but then we should be careful. And intestinal obstruction, of course, is a contraindication. And if someone has chronic intestinal disease, colonic ulcers, inflammatory bowel disease, or hypersensitivity, it's definitely contraindicated. So one good thing is, even in impaired glucose tolerance, I think acarbose had shown data that it can prevent the progression of type 2 diabetes into diabetes. So IGT arm, it was used, and the same effect is also seen by metformin, lifestyle intervention, and I think some studies are going on with SGLT2 inhibitors also. It can be used as an adjuvant to diet and insulin in type 1 diabetic. In fact, my professor and mentor, Dr. Prasanna Kumar, I had asked, if one of the meal values are high, postprandial, and you try all your stunts with the diet and exercise and you can't get it, can I just use alpha glucosidase inhibitors there at that meal? So his answer was no. He said, what is the point of cutting only one glycemic excursion? Because this drug, if you want to really use it, it should be given thrice a day, at least twice a day with the principal meal to blunt the postprandial excursion. So blunting only one spike will not translate into a major change in the HbA1c, and also may not give any CV outcome benefit. So why use it is, it was his view on that. And do we have CVO2 data? We have renal safety data. We all say it possibly works better in Indians. Do we have a comprehensive data on that? And as I said, when patient has hypoglycemia, you should treat it with a monosaccharide rather than a disaccharide also. So these are the things which we bear in mind. And again, coming back to the slides, we see we are all becoming patient-centric, which is a great news. If cost is a major issue, we know what to use. ACVD risk is a major issue, or heart failure is a major issue. So keep the patient in mind, have a healthy, open discussion with them, and then choose your drug accordingly. Thank you very much.
Any questions from the audience?
Nor any data on low-glutazone. I see some people coming with low-glutazone. Sorry, I wasn't there.
No problem. I showed a slide. There is 3 points what I made. One is there is no head-to-head comparison as a monotherapy with pioglitazone, but on background of metformin, it was equally efficacious. Edema was controversial. In the main trial, it showed an increased edema as compared to pioglitazone, but in some other follow-up studies, it has showed same or slightly lesser. So I don't think it will make a major impact in our prescription pattern. If someone wants to use a glitazone, I think they still stick to pioglitazone.
Okay. Thank you.
Thank you.
Sir, what is your opinion regarding the AGIs in pregnancy and lactation?
We should not use it. Only drug is insulin and metformin initially. We can use it if someone has PCOD.
Is there any data available
No.
in role of AGIs in pregnancy when the patient is having high PPBS?
Yes, please. Yes, please.
Even I was surprised and taken back. I didn't look at the data, but there was some data presented at the idea. Okay, Dr. Mohan was speaking on AGIs. Somebody from the audience, in some couple of countries, they used voglibose, not voglibose, acarbose. Is that right? Doctor, there is data. In Chennai also they have used. So somebody got up and asked this question and he said, I don't know about this data. That's when I knew that there was some data on this, but generally speaking, no.
Yeah, always I tell this, First, treat the patient medico-legally. Second, you treat the patient medically or technically. Third only comes empathy, sympathy, and etc. So make a documentation of it. I worked with Professor Lily John, who was in CMC Vellore as a HOD for a long time. She used to use a lot of glibenclamide in pregnancy. There was data those days, but still now if you want me you were to write it, you should be very, very, very careful. If given a choice, better don't venture into that.
Also diabetes.
Type
Yeah.
1 diabetes is
Yeah,
again
but-
off label. We should not use it. It's like the SGLT2, at least studies are going on. I don't think there are any studies there, but theoretically it should work.
Use of pioglitazone in MODI. Majority onset diabetes of young. The
No.
second thing is use of pioglitazone in polycystic ovarian disease.
Pioglitazone in polycystic ovarian disease, no real data, but then again, insulin resistance has been the main key component. We can still use it, but it's only if metformin is not available or not is contraindicated. MODI sulfonylureas in one of the types of MODI 4 is useful, but I don't think pioglitazone should be used there.
Sir, PCOS definitely no, because if there is weight gain, yes, for insulin resistant theoretically, but I've never, I don't know, we don't use it.
No, there are two types of PCODs. There is obesity PCOD and
And
also
the thinner one, I
thin,
got it.
PCOD.
I
And we
don't
use it in thin PCOD.
I
It's
don't
been
know.
recommended. Where there is
No
metformin,
idea.
people
I
who
don't-
don't tolerate metformin, they can use pioglitazone.
Definitely no. I've
Not
used
sure.
it.
Yeah, I don't think we should use it. As I said, yeah, I think there are trials which are going on. The same PPAR alpha and gamma I showed you in the beginning of the slide. Saroglitazar is more towards gamma than alpha. So it has a better effect on the lipids and NASH. I think trials are going on with respect to the NASH, but data is not yet out.
Any more questions?
And it also works more on triglycerides as compared to LDL. Yeah.
Awesome. Thank you, sir. Thank you very much for the talk.
Thank you.
So I think we will break for the lunch for a few minutes now. We have a good topic of on a diet for diabetes post lunch. I request all the dignitaries to be gathered back here again at around 2:15, 2:20. Thank you.
Yes, lunch is served downstairs. Grab a quick lunch. It's a working lunch, so you can reassemble back so we can take the topic together. Thank you. Where's Pramila? I should ask her about.
ಮೇಡಮ್ ಅದೇ ಸಾಕಂತೆ ಲಾಸ್ಟ್ ಅಲ್ಲಿ ಹೇಳಿದ್ರು ಅವರು ಅದೇ ಬೇಡ ಅದೇ ಇರ್ಲಿ ಹೇಳಿದ್ದಾರೆ ಸರ್.
ಓಕೆ ಅಂದ್ರೆ ಓಕೆ.
ಈಗ ಒಂದ್ಸತಿ ಕೇಳ್ಬಿಡಿ ಆಮೇಲೆ.
ಒಂದು ಹಳೆ ಫೋಟೋ ಇದೆ ಅಂತ ಅಂದ್ರು ಅದಕ್ಕೋಸ್ಕರ.
ಓಪನ್ ಮಾಡಿ ಕ್ಲೀನಲ್ಲಿ ಎತ್ಕೊಂಡು ತಿನ್ಕೋರು.
Good afternoon, everybody. Hope you had lunch, but we're going to start shortly. Yeah, we try. Come. Another 5 minutes we can give, 3 to 4 minutes, and then we can start. 20. Good afternoon, everybody. Welcome to the post-lunch session of ADO 2022. Now, we have an interesting topic now to discuss. May I now call upon Dr. Vijay Kumar, who's a consultant diabetologist and physician at JP Specialty Clinic, Tumkur, to introduce the speaker and the topic and take the session forward. Thank you.
Thank you, sir. So post-lunch session, we have an interesting topic. To begin, I would like to invite Dr. Neeta Deshpande, who is a diabetologist and bariatric physician from Belgaum, Diabetes Center, Children's Diabetes Center, Weight Watch Obesity Center, professor and HOD, Dental College, and associate professor of medicine in USMKLE International Medical Program, Belgaum. Over to you, ma'am.
Thank you very much, Chairperson. At the outset, I would like to thank the Primer team and the ADORE committee for inviting me to Bangalore to give this lecture in this lovely city of Bangalore. So the topic that I have been given is slightly different from what I have been speaking all these months and years, and that is diet for diabetes control, just diabetes control versus diet for diabetes remission. As you all know, we've all been talking so much now about remission, the direct study, the counterpoint study, and all of those things. So we wonder, and so many guidelines also coming in. And then we wonder whether everyone should be doing this, whether diabetes remission happens in everybody, and how is it different from the regular diabetes diet, so to speak, that we've been giving all these years. So I do not have any disclosures for this lecture. Let me dive in straight and first come to the first part of it. And the first part of it is diet for diabetes control. That is just glycemic control. This is the traditional way where for years together, from time immemorial, we have been doing this. And we've been doing a pretty good job of it as well, where we use this as an adjunct and diabetes diet is given. So let's just tease it out a little, understand the nuances some more, so that then you will know the difference between this diet and the remission diet. So the basic goal of diet for diabetes control is this, that you balance the diet in such a way that the medicines and lifestyle, all of them put together, give you a good glycemic control. As such, this diet is not really expected to do much more, though it does, because any amount of control is going to bring a lot of good things. But how good, the extent of it, we don't know. Or rather, it is a little less than the drastic diets that happen in remission. So the basic goal is very simple. You give a balanced diet, you balance it with the medicines, you balance it with the lifestyle, and that is the goal for a diabetes glycemic control. So I've purposely put the 2019, which is much the same as 20, 21, 22, and I'm then going to contrast this with what the 2023 guidelines are going to say. So here, if you can just see, basically the medical nutrition therapy for diabetes patients, it talks about a healthful eating pattern. It talks about nutrient dense foods. It talks about portion sizes. And basically the goal is to achieve and maintain the body weight. And those are the goals. It's individualized. There is no reduction drastically of anything. Neither the calories, nor the carbs, nor the proteins, nor anything. So everything is in moderation because it is meant to sync with the pharmacotherapy. And that's why the diet is like that. And individual needs, cultural needs, psychosocial needs are also looked at. And you're supposed to make the patient feel good with this kind of a diet. So let me tell you that, because I'm going to contrast it with the remission diet. So you're going to make the patient feel good. Okay, you want to have a little bit of this. Okay, then you walk a little more. So you just, do all the balancing act, and that is your usual diabetic diet. Our nutritionists are doing a good job of it. We are doing a good job of it. And this is what we've been doing all these years. So the principles of such a diet are very, very simple. Basically, it is portion control. So you teach your patient that don't eat too much at one time. If you're hungry, eat a little later. And basically you teach them how to do portion control. So this is one of the basic principles of a regular diet for a garden variety patient for diabetes control. Then the second thing that we also do is we look at glycemic index. So we tell the patients, eat a little less rice or reduce your carbohydrates because they have got a high glycemic index. If you have to eat carbohydrates, then you have complex foods. So this is how we tell them that you reduce. So glycemic index is looked at, and that is how we try to balance the patient's diet to match with the pharmacotherapy. Supposing somebody is on insulin, then we tell them that if you eat a very high carb diet, you're going to need far more insulin, and therefore what you need to do is reduce your foods that have got a high glycemic index. That's the second thing we do. And the third thing we also look at is the glycemic load. So a regular diabetic diet, without so much as making calculations per se, basically follows these three tenets. That is, you look at the portion control, that is, you reduce the calories. You look at the glycemic index, so you reduce the carbs mostly. And you also look at the glycemic load, which is again a function of the portion size per se. So this is basically, and everybody is quite aware of this. Doctors are aware of this, nutritionists are aware of this, they are taught in this same fashion, and this is traditionally what is done. And out of such a diet, what are the typical results that are expected? So this is a very practical talk that I'm giving to you because everyone is talking about diabetes remission. But if you do a simple diabetes or glycemic controlled diet, typically what are the results that you expect? You expect a weight loss in the range of something close to 5%, maybe 7% in some. Then you get better glycemic control with the aid of appropriate medication. You may tweak the medication a little. The patient is more obese, you may give an SGLT2 inhibitor or a weight neutral drug or increase metformin, reduce sulfonylurea, and so on and so forth. You will adjust the medication to suit that particular diet. And by giving this kind of a diet, if the patient adheres to it, you do expect small de-escalations of pharmacotherapy. Patient doing very well, you reduce the medication a little bit. So this is happening at this level of a regular diabetic diet. However, what we find with this kind of diet is that you do not have much de-escalation of antihypertensive therapy. You do not have much of an effect on fatty liver. You do not have much of an effect on musculoskeletal problems such as osteoarthritis, back pain, etc. That's not going to happen with around a 3 to 5% weight loss. You may get a good glycemic control because, as I said, when you set out to give a diabetes diet, you are going only with that in mind, that you want to give a good glycemic control with the help of medication. So these are the results that you will expect. Now, let's flip over and go to the opposite side. Let's go to diet for diabetes remission, which is something you all have been talking about. The basic goal here itself is completely different. If you remember the goal that I talked to you about in a diabetic diet, then it is just good control with medication and lifestyle. But here it is to attempt to reverse the diabetes state and stop medications entirely. So the basic goal here is quite different. So these were the changes that were made to the ADA standards of care in 2023. You can see very well here that there is something added on intermittent fasting. I won't go into that, but emphasis was placed on supporting larger weight losses. This has come for the first time, 15%. No standard of care so far, neither the ADA nor any other in their standards of care talked about a 15% weight loss. So that is what has come from remission trials. And then a recommendation was added to reinforce that both small and larger weight losses should be considered as treatment goals on a case-by-case basis, which means to say you need to individualize, but you can aspire for larger weight losses in the appropriate cases of up to 15% also. And they have also written, with evidence of course, that larger, that is 10% or more weight loss may have disease modifying effects, which means remission, basically including remission, and may improve long-term cardiovascular outcomes. So you see here the jump from the previous, what I showed you of 2019 or 20, of what the recommendations of medical nutrition therapy were, to this, where they're telling you, you can in the appropriate cases have 10% weight loss, 15% weight loss, and get effects beyond just glycemic control. So this is the basic difference between diets for diabetes control and diets meant for remission. Because diets meant for remission do far more than just doing remission. They do much more. So what are the principles? Our principles are basically based on the twin cycle hypothesis of Roy Taylor, which you all know how diabetes is caused. This explains the pathophysiology of type 2 diabetes, where it says for years together, if you have a positive calorie balance, you have fatty liver, fat deposited in the liver, which interferes with insulin sensitivity, and your fasting sugar starts to go up. If positive calorie balance continues, the fat spills over and takes over the pancreas as well, you have pancreatic fat increasing, which interferes with insulin secretion. So you have postprandial rise, and that's how you have diabetes. So what did everything start with? It started with positive calorie balance. So the principle for diet for remission stems from the fact that you need to convert positive calorie balance into negative calorie balance. And how do you do that? You do that with severe caloric restriction. They do not, the principles do not really look much at the macronutrient, though there are some studies now which tell you that when you do a negative calorie balance, it helps if carbohydrates are reduced. But basically, the principle here is quite different. The principle here is that you just drastically reduce the calories and try to reverse this twin cycle that you are seeing over here. Now, what do these diets look like visually? How do they look? So this is how a diabetic diet, a simple diabetic diet looks. So you have everything. So you have a roti there, and then you have veggies, you have sprouts, and you have so many other things. And typically they say 1400, 1600 based on the BMI. So this is how it looks, and this is the calculation. All the nutrients are there. And this is a traditional diabetic diet. Our plate looks something like this, supposed to at least. And this is a diet that we are all used to prescribing. Our nutritionists are also used to prescribing this. But this is what a reversal diet might look like. You see that tall milkshake over there? So that is the meal basically. So that is the meal. And what you see on the right side, those plates, they're actually small portions of veggies or something similar to that. And that is given along with this milkshake. And this is done 3 times a day. So this is called a remission diet. So visually, they look very different. And that makes you understand that to prescribe a diet, which you see on the right-hand side, is going to be not easy, because for years, it has been ingrained in us that what you need is this, a balanced diet. So this is also a balanced diet, not that it is imbalanced, but it is very, very low in calorie, 600 to 800 calories. So obviously, you're not going to get all that calcium and sodium and everything. So you will have to supplement that. So it's a different ball game altogether. So you need to supplement it. You need to keep watching the patient. It has to be done under supervision. So if you see the contrast, a diabetic diet believes, a simple diabetic diet believes that once diabetes is diagnosed, beta cells cannot recover, so medicines are required. So it is only an adjunct. That means you do a lifestyle modification or a diet modification as an adjunct to pharmacotherapy because your beta cells are not recovering. Then if you look at the right side, they are the results of the famous counterpoint study, which was done with just a few number of patients for 8 weeks, about 11 patients for 8 weeks. And they were given a 600 calorie diet. And then they measured before and after what has happened to the insulin secretion, the first phase of insulin secretion, and the pancreatic triglyceride content. And the results are there for you to see. It's an 8-week period of a hypocaloric diet. And you can see that the first phase of insulin has recovered. So beta cells have recovered. So you see a maximal insulin response, which is increasing, which means beta cells have recovered. Pancreatic triglyceride content has gone down, and that is why the insulin secretion has gone up, because you've removed the fat from the liver. Basically, that is what has happened. So this is the difference between the conceptualization of a regular diabetes diet versus a remission diet. Again, the same thing. A diabetes diet believes that diabetes is a lifelong disease. It cannot be managed without medication. But you can see the results of the direct trial. The same counterpoint study principles were applied to a much larger population across the United Kingdom. And what they found was that at the end of 1 year, 46% of patients went into remission. And 85% of those who lost more than 15 kgs went into remission, which means a very low calorie diet of 600 to 800 kilocalories could actually put you into remission Then there was 2-year data, and now there's more data coming in. And now there is also data for people who are normal BMI also attempting the same thing and reversing their diabetes. So there are certain indications, caveats, determinants of who will remit, who will not remit, etc. But this is what you will find. The concept itself is different for diabetic diet versus remission diet. These are the practical aspects now. Let me just enumerate those for you. Only highly motivated patients can try remission diets. Why did I put those visuals? Because those visuals will make you understand that you need to be motivated to do it. It has to be done under very close supervision with supplements and frequent follow-up. Because it's a restrictive diet, you need supplements. And you need close supervision for de-escalation of therapy, which has to be done at regular intervals. Choose your patients wisely because remission is not for all. The basic remission diet is not a permanent diet. Now, this is something that I must tell everyone. Though I showed you 2 visuals, the visual that you saw of the diabetic diet is for life. It doesn't change. But the remission diet does change. The remission diet, which I showed you with the meal replacement and vegetables, is for 4 to 6 months. And then a person is gradually weaned off that diet onto a maintenance diet, which may or may not look exactly like the diabetes diet, which you give to start with. It will not look exactly like that. It will be different. So I hope I made myself clear that the remission diet that I showed you is not permanent. It is for 4 to 6 months. And then there is a weaning off of that. So while remission may not be a goal in all the patients, reduction of medication, better metabolic parameters such as lipids, blood pressure control, NAFLD, etc., and improved quality of life definitely are. So every patient who goes on a remission diet may not remit entirely, but will definitely have benefits with respect to his other metabolic parameters, which in itself is big. So it can be tried. So let me make my conclusions here. The traditional diabetic diet is still the most widely prescribed because of ease, because of people knowing it. There is science to it. It has been proven and there's evidence. It can be dispensed even by general practitioners, dietitians, other trained personnel. Even those people who are not nutritionists can dispense this kind of a diet. The diet is meant to be an adjunct to pharmacotherapy while causing modest weight loss and helping weight maintenance. Diabetes remission has been proven to be effective in many groups of patients, especially if the duration of diabetes is less, if they are not on insulin, if they are obese. So these are the kind of patients who will benefit more. As of now, remission needs to be supervised by experienced healthcare professionals and nutritionists. So everyone can't attempt to do it because there are a lot of nuances to it. People should get trained and then attempt it. For remission, patient selection is very important. For a regular diabetes diet, well, it's for everybody. So what's the future? The future, we talk about adherence. How much of adherence can you expect? As it is, diet is a situation where people don't adhere. Lifestyle, adherence is poor in general. So if you had to tease out these 2 diets, the adherence issues have to be looked into. Acceptance. How many patients, even for 4 to 6 months, will agree to go on this kind of a diet? Of course, Roy Taylor showed in backup data afterwards that people who were given the option, statistically, a majority of them accepted it because they thought that the results will be very good, and rightly so. So if we do not offer it to our patients, we cannot assume and think for the patient, oh, they're not going to accept it. You give the option. If they don't, they don't. Then the durability, as I said, we still are in a fledgling state as far as the long-term data is concerned, but we do have a little more than 2 years data that is published and it looks promising. The direct trial, 46% remission came down to 36% of patients undergoing remission. So thank you all very much for a patient listening, and thanks for the opportunity.
Thank you, ma'am. The floor is open for discussion. If there are any questions, we'll be happy to take.
Thank you for this wonderful talk, Melinda. We see a lot of technology coming into play into our mission. I know it helps in certain ways, but since it's driven by not by doctors and probably technocrats and market, there are a lot of patients who, because of the advertisement, get into these. And what do you have any experiences in these
Right.
type of
So that's, yeah.
use technology-driven remission?
Right. So that's a very good question. When you say technology-driven remission, technology is used for keeping up with the patient, dispensing advice. But a lot of the technology-driven platforms also have doctors on board, and they are trying to do it as evidence-based as possible. So that is there. So a lot of the work, which is not exactly doctor-based, is being outsourced to a second level, third level of people who are nutritionists, dietitians, or assistant doctors, and then it is escalated up to senior consultants if it is required. So technology does have a place in today's world, which is rife with hectic schedules of people who do not have time to come every week for a follow-up or something like that. So online and technology driven happens in different ways. For example, a lot of my patients who are on remission do a hybrid model. They visit the hospital sometimes, and the rest of their things are done online. So so the day they go on a diet, they have to tell us the weight on their digital weighing machine, and we see it on ours, so that then we can compare it and have it like that. So yes, it has a place, but if it is entirely driven by technocrats and with no medical people, I think that's not a very good idea.
Yeah, I mean, a quick question, because you studied in Mumbai, you keep going to Mumbai. When I visit Mumbai and Delhi and places like this, when I ask a lady, are you a dietitian? Immediately she corrects me and says, I'm a nutritionist. I have not been able to figure out the difference
Actually,
between
even
a
I haven't.
dietitian and
Yeah.
nutritionist, because in South India, we still call them as dietitians, educators. But I thought you may know the difference.
No,
between
I honestly don't know the difference. I think it's in the degrees, some of them. So I think if they have the RD, registered dietitian, then they're dietitian, and those who do something else are nutritionists, is what I think. Yeah. This was out of syllabus for me, but that's okay.
Ma'am, these remission diets, though they are monitored and all personalized, everything, but still they're continuing for years, ma'am. Is that safe to do? You said 4 to 6 months. is
Yes,
the
4 to
remission
6 months, and then you wean them off. You need to wean them off because you can't be on these kind of unnatural liquid diets. I call them unnatural because it's different from what we are used to. But they're typically you're supposed to wean them off. But if you have large BMIs, very large BMIs, you may want to continue it a few more months because you need more weight loss. But having said that, they have to be closely monitored for everything. See, there can be hair loss, there can be vitamin deficiencies, then there can be so many other, they can become anemic. So all this has to be monitored. And typically, even in the maintenance period, sometimes we ask them to take one meal replacement a day and then 2 meals. So various combinations are made, and that's the process of weaning off. So the safety of these kind of diets on long-term basis is not known. It's not been studied, not been reported more than these many months. But then I have had patients who have been on this kind of a diet for even a year, because their body mass index to start with was 45 or 42. And then they're still losing weight on that. They need to lose weight. But we are very, very careful. We keep checking all their parameters very frequently, making sure that everything is okay.
On remission diet, will the weight loss keep going on, or does it plateau somewhere, ma'am?
It depends. It can plateau also. So higher the BMI, lesser is the plateau because they keep on losing. But if they are BMIs of 27, 26 who want to go for a remission, then they plateau faster. But it's very individual.
Thank you, ma'am.
Generally, what happens, ma'am, adherence is one of the main thing in all these things. If at all the patient doesn't adhere much to that and probably just goes back to his normal diet, is there any variation which can happen? Because what we have seen is patients do come back after doing all those diet with a very high sugar values and they're totally, totally off that actually. Just want to know, have you really faced that kind of a thing or?
They relapse.
They relapse, right?
Yes. Relapse is known. My patients also have relapsed in spite of counseling them right in the beginning that if you do not come for follow-up, you will relapse. We tell them on day one. We tell them you will relapse. They ask us the question, what about after your diet? I said, there is no after your diet. You have to keep coming because they're diabetes individuals in any case. And then we keep on looking at their weights. If they start to increase drastically, we pull them back with rescue diets again and so on. But if they're lost to follow up, they gain back everything.
Ma'am, how about the herbal life? People are using herbal life because
Okay.
I've seen patients coming out of the insulin also, reducing the doses of tab OHS also.
Yeah. See, basically, you can affect low calorie by any means. Okay, it can be by any means. You can do very low calorie by a forced bariatric surgery, or you can do it even with these milkshakes, and Herbalife is of that. But the caveat is here that there have been several reports in the last 2 years itself of hepatotoxicity with Herbalife. So the content is very important. Now, the content that is there in the medical meal replacements that we use, it's just food. There are no additives, no medicines. It's just food with added vitamins, minerals, etc. But when you talk about Herbalife, you think that herbal is always not harmful, but that's not so. It has, there have been hepatotoxic, it has been reported in the BMJ couple of years ago. And again, this year, there have been some 2 or 3 deaths because of hepatotoxicity attributable to Herbalife. So while I'm not an Ayurvedic expert, this is what I have read.
Sorry, out of syllabus, because 2020 Diabetes India meeting, I know Sanjay had gone up by 20 kgs, had long sessions with you, and then we saw him losing 20 kgs in 6 to 8 months, and then again he regained.
They
the
don't
weight.
talk to us again. They don't talk to us often enough. Lost to follow up, then you regain everything.
Then because he said, okay, I mean, weight loss gives
Again, I'm going to talk to Neet.
weight loss gave him a lot of happiness, but the diet that you need to follow day in and day out doesn't give you happiness.
Yeah, so you need
go
to find a
back-
new happiness in life other than food. It's as simple as that.
That's right, yes.
Yeah. Your definition of happiness, if it changes, you've nailed it.
I have a question here. I think of late, this diabetic remission has been making a lot of rounds. It's become viral, in fact, the social media. So I just want to get back to our physiology of diabetes. It reminds me of something like autoimmune disease. When you're talking of remission, there's going to be relapse, there's going to be exacerbation. Invariably, in the initial part of the diabetes, there is a honeymoon phase. All of us, we know. Later on, when it's not properly, people think that during that phase, they've gone into natural remission. Later on, they come back with rebound, hyperglycemia with all the complications that is associated. But I want to have a clear idea before we leave this hall. What is the scientific basis of this so-called diet remission in diabetes?
Yes, sir. As you very rightly said, sir, for any diet or any disease, it's just like usual life. After honeymoon, some people still stay in love and their marriage continues very well. And after the honeymoon, sometimes the couple starts fighting and then they may separate. So it's very similar to that. It's what you do afterwards that's what is going to decide whether you stay in remission or you don't stay in remission. At the beginning of my lecture, I provided the scientific basis of remission. So I showed the twin cycle hypothesis, for which the Banting Award was given to Roy Taylor for computing it, some early 2000s. And there it has been very clearly shown with very elegant experiments about what happens to first phase insulin secretion, maximal insulin secretion, pancreatic fat content, hepatic fat content, and that is how the basis of remission came about. And I'll refer you to the counterpoint study. which took all these things in, it was a proof of concept study, and he proved that remission can happen with this kind of an approach because of what is happening in the liver and the pancreas. Of course, as I said, relapse happens even in regular diabetes patients. Patients come to us, they take insulin. After 6 months, they just disappear, come after 6 months with how much? 400 sugar. We stopped our insulin or we stopped our diet. This is true of any chronic disease. People get fatigued and they stop their treatment. So that percentage is there in every, whatever, whether it's remission or otherwise, that is, you're going to see that anyway.
I think I would like to say that diet alone is not the only thing, as we've been talking about various things. So many drugs, including insulin from last evening. There are 4 pillars of control of diabetes to make it euglycemia. One is the primary thing, I believe, it is attitude. Because a lot of stress hormone, the moment I get diabetes, all the 5 antagonists will start working and my sugar will not be controlled. So the attitude, always I'll tell my patients, have a good attitude. You will positive attitude. Second thing, diet. Third thing is exercise. Fourth, of course, the drugs. So combination of this is what going to give a euglycemia than just venturing upon a diet.
Right.
Okay. Thank you very much, ma'am, for such a wonderful talk on niche subject. So I thank you very much. We'll move on to the next topic. Thank you.
We now move on to the next session on severe risk reduction strategies in diabetes. To chair the session, I would like to invite Dr. K.N. Manohar, consultant physician and diabetologist at Manipal Hospital, Chairman-elect KRSSDI, and Dr. Suman R., Director of Madhumeha Diabetes Center, Jayanagar, past Chairman of KRSSDI 21-22. Over to you, sir.
Thank you. Thank you so much. So just moving on to the next session, that is severe risk reduction strategies in type 2 diabetes, practical tips. To start off, we have with us Dr. Pramila Karla. Dr. Pramila Karla is MDDM, and she's a professor and consultant endocrinologist at Ramaya Medical College. She's going to talk about the importance of dysglycemia management for severe risk reduction in diabetes. Over to you, ma'am.
Yeah. So good afternoon, everyone. And we had a nice discussion on diabetes remission and diet. And now we are going to talk about one other aspect of diabetes management, that is the role of control of dyslipidemia for the severe risk reduction in patients with diabetes. This is my financial disclosure for this talk. So just to start off with a case, we all see so many diabetes patients in our setup every day. And what we see is some of the patients who come with a new diagnosis of diabetes with a problem initially only, like they may come with a cardiovascular problem, they may come with renal failure, and there may be a group of patients who may just come with the diagnosis of hyperglycemia, but may not have any other comorbidities at that point of time. Or they may have some like hypertension. And then we may have another set of patients who come already with a cardiovascular disease, and then they come to us for the management of diabetes and dyslipidemia. So that's what we label it as primary prevention, or we label it as secondary prevention. Now, just to start off with a case like this, where a 42-year-old person who is a known case of diabetes for past 2 years is on metformin and dapagliflozin. And this patient has now come to us with a proper control of diabetes, as it looks like from the HbA1c, which is 6.4. But the patient is a hypertensive. Patient has dyslipidemia. So what we are going to discuss in this type of a case scenario, where you have a patient who has a LDL of 139, is not on any statin. And this is a common thing which we see in our OPD setups, because whenever the patient like this walks into the OPD and you tell them that you need to be on a statin, then the theory starts that why I need to be on a statin. As per this, I am a little bit in the moderate risk category. I am not in the high risk. So how do I need statin? So let's discuss that. How do we assess? Because first we need to know whether my patient is a high risk or not. So first thing, we all have to understand that diabetes, hypertension, these are all parts of the metabolic syndrome, and it's a continuum. It's not just one day. It's not that today It's not that the patient has diabetes today and we have to decide today. It's all going to continue. So what's there today will progress, and these patients may develop problems and cardiovascular disease and other features of the metabolic syndrome over a period of time. So when we assess the cardiovascular risk in these patients, we have different risk calculators. One of the common, which is advised by AHA, is the ASCVD risk calculator. This assesses the 10-year risk of ASCVD, but are we just going to get a proper idea? It does include diabetes as a risk factor, but the main thing is does not include the duration of diabetes. Like, so you have a patient who is 2 years having diabetes. There's another patient who is having diabetes for 10 years. You may not have a different risk categorization for both. You may label the 2 years similar as to a 10-year, though your 10-year diabetes duration patient may have a higher risk, may not have. But this calculator takes into account the age of the patient, the gender, the race, the blood pressure, the lipid values, the history of diabetes is there, but not the duration, the smoking history, and antihypertensive treatment, statin treatment, and aspirin treatment is included. And they say that less than 5% is a low risk. So if you try to calculate in our tertiary care centers, the risk for most of our patients, you will see that most of them come under the category of at least moderate to high risk. Very few of them come in the category of low risk. We know there are other guidelines also. We also have from the ESC way back in 2016 itself, they had categorization of a 10-year CV risk. They use different types of calculators again. But we know that when we talk about the risk, we know that it's not just one calculator which is going to tell us the risk. Sometimes these calculators may not include one of the parameters. They may not be validated with more population from our ethnicity. So all that makes a difference. So we know that we have a risk categorization. We have a 10-year risk categorization. We say a low risk, a moderate risk, a high risk patient, a very high risk, or an extreme risk patient. Patient may have a risk categorization as per their risk scoring and how many other risk factors they have, like if they are smokers, they have peripheral vascular disease, they already have microalbuminuria. So all these come under the high risk categorization. They already have diabetic kidney disease. We have another good calculator, which is the UKPDS risk engine. That's another good way of doing, because this calculator actually has duration of diabetes in it. So this is one of the good calculators which we can use in our OPD setups on our phones to at least get an idea about the risk. Because though we know that by seeing our patients with our experience, we know, yeah, this patient could be high risk, but just by experience, we can't calculate a risk. We have to have a risk categorization because we might need to give a high intensity statin to a particular patient rather than a moderate intensity. And we may end up giving a moderate intensity thinking that the risk is borderline. So that's why this is another one of the good calculators which has included Indian ethnic or Asian ethnic population into the calculation or validation of the calculator, and it does take into account the duration of diabetes as well. Like somebody in the audience was definitely talking about the 4 pillars of diabetes management, and these are definitely the 4 pillars of diabetes management. There's no controversy on that. And we know that not only the glycemic management, but dyslipidemia management is a major pillar among the 4 for diabetes control or reduction in the diabetes complications. We know that our population is a little bit at a higher CV risk. We cannot say little bit, it's quite at a high risk for CVD. If we see, we can get CVD a decade earlier, and lots of younger population, less than 40 years, may get cardiac events early. We do see in our setups, a lot of younger population around the age of 35, 40 with diabetes coming to us with multiple problems and with cardiovascular disease or very high risk categorization. Already they have blocks, they require treatment, they require antiplatelets. And we know that the mortality obviously will be higher at a younger age. So when we talk about dyslipidemia management, no talk for diabetes or metabolic syndrome or hypertension management is complete without lifestyle. So we already had an elaborate discussion about what diet we should give for diabetic patients, what diet we should give for remission. We all had a very nice discussion with Dr. Neeta, and she was nicely elucidating how nicely we can give the diet pattern to the patient. So there is no controversy. We have to talk about lifestyle modification even when we are targeting dyslipidemia. And it pretty much remains the same because we are not targeting just the glucose. We are targeting all these things when we're giving those diets. We know that we have to counsel our patients to take more fiber in the diet, reduce the saturated fats as well as the trans fats, because a lot of our Indian preparations do have trans fats, and this we need to counsel to our patients. And when we talk about lipid lowering, we know that when we try to reduce the risk of cardiovascular events, we know that if you see the data or if you see the studies which have been done, they have clearly shown that if we reduce the lipids to the requisite level or to the level required, we can actually reduce the risk of cardiovascular events even to the tune of 70%. We cannot make it zero, obviously. We know that there are studies, I'll come to the data, how much exact reduction we see. But up to the extent of 70% risk reduction, we can see. But we need to take into account the other things also, and we need to see what level of LDL we need to achieve. That's also the most important factor. So this was one of the study where they have tried to see the intensive LDL lowering for the cholesterol, LDL cholesterol lowering. And this was a meta-analysis where they were trying to see from different trials. And what they found out that the statin therapy, where they followed up these patients for a mean period of around 4.3 years, they demonstrated a 9% proportional reduction in all-cause mortality and 13% reduction in vascular mortality for each 1 millimole per liter reduction in the LDL cholesterol. So what we're trying to communicate is target the LDL first. We know that we have lots of discussion on triglycerides, we have discussion on HDL increase. There's no controversy. We're not saying that those are not the factors, but the first factor which has shown a definitive evidence in most of the studies is the LDL. So target the LDL first. And that's done by the statin. You can clearly see here, whatever you see, fatal MI, non-fatal MI, the post-CABG mortality, PTCA, ischemic stroke, all these things have clearly shown in this that it favors the use of statin. So we have to use statins to reduce the LDL, to reduce the cardiovascular mortality, to reduce the overall mortality with regards to the ischemic stroke and also the cerebrovascular events as well. And we know that dyslipidemia is one of the strongest contributor to the CV risk. There's no controversy. We have the Interheart study data where it was found to be the strongest contributor for the myocardial infarction in Indian patients. And so what we have understood till now that identify your LDL as the primary target therapy, lower LDL with definitely pharmacotherapy and lifestyle modification, 50% or more lowering of the LDL, and we can identify specific values. We are not saying that don't identify a 100 target of LDL or a 70 milligrams per DL or a 55 milligrams per DL target for secondary prevention. The lower, the better, we say, but at least a 50% lowering, because the patient will ask you, my LDL was 110. Why are you starting me on statin? As per my report, I'm looking to be normal. But this is how we have to explain. And we have intelligent patients who can understand. Obviously, there are patients who may not understand this data, but we need to know in our mind. First, we have to be clear. We have to be convinced, yes, my patient needs statin. And we know that whenever we talk about these guidelines, they all say that for primary prevention, statins are the thing which we have to use. If you see the 2021 ESC guidelines on cardiovascular disease prevention with regards to diabetes, they have clearly said the same thing. Then patients with type 2 at very high risk, like who have established ASCVD or who already have severe target organ damage, and intensive lipid lowering by lowering more than equal to 50% the LDL, and the LDL of less than 55 is what we should target for. And patients who are more than 40 years at high risk, lipid lowering treatment with a LDL goal of at least more than 50% reduction and a LDL of less than 70 at least is recommended. And the statin therapy must be considered even in people who are less than 40 with type 1 or type 2 who have evidence of target organ damage, because we do have younger patients, as I told you, who come with already a target organ damage, unfortunately, by the age of 30, 35, where you need to intervene at that time. So it's not that just universally above 40 only we are going to give statins. We have to give statins in a group of patients who are less than 40, but who fall into this category, whether they have type 1 or type 2, if they have evidence of target organ damage or a LDL more than 100, as long as if they are not planning for pregnancy, because we know statins now are in the category B. If the LDL goal is not reached, then the second step of ezetimibe comes in. So if we try for LDL reduction of more than 50%, as I showed you in the meta-analysis and the different studies, they have clearly shown that at least a LDL reduction of more than 50%, if we try, we need a lower number to treat to achieve that. And it could be based on the net benefit. We have to see the number needed to treat. So if you see LDL for 20% reduction from baseline, you can see the number needed to treat here is 63. But if you see LDL reduction for 50% reduction from the baseline, the number needed to treat is only 26. So what we are trying to say is target the LDL. We have to target a 50% at least reduction. We might have to target lower of below 55 for very high risk group, below 70 for high risk, And the moderate risk group, we target at least less than 100 or a 50% reduction. And we know that if we are targeting this 50% reduction, we reduce the cardiovascular events significantly. If you see here with the number needed to treat, but we saw that data, so it's here 20% and here it is 50%. What we can see, 63 number needed to treat, and here it is 26. Now, there are lots of studies on personalized management. So now we were discussing about diet, we were discussing about so many aspects of diabetes management. And diabetes being a chronic disease, we need to have personalized management. So we can't just have a blanket statement for everybody. As I showed you the calculators, and I clearly showed you that many of these calculators, even the ASCVD calculator, does not take into account the duration of diabetes. It does takes into account diabetes, yes or no. So your calculation might show a 2-year duration diabetic patients to be having an equivalent risk to a 10 years old diabetes duration, but your statin therapy may differ. You might like to go for a high intensity statin, even if your 10-year risk old diabetic duration patient shows the similar risk as the 2 years old duration diabetic patient. But your statin therapy may be much higher, or you might like to go for high intensity for other reasons which you think are pertinent to that patient. And this is what we talk about personalized management. So now we also talk about even for not only for diet, not only for the anti-diabetic drugs, but also for the lipid management. We just have to basically understand the high intensity and the moderate intensity. There is nothing called as low intensity, but in our country, because of our patients' body weight and tolerance and many factors, we start off with a lesser level or the lesser dose of the statin. And then if we don't get the requisite amount of the LDL reduction, we do go on with the escalation of therapy. But what has been recommended as per ADA 2023 is if we have a high intensity, which is mostly for secondary prevention, and the high and the very high risk group, it's atorvastatin 40 to 80 and rosuvastatin 20 to 40. And at moderate intensity comes with atorvastatin 10 to 20 or rosuvastatin 5 to 10 mg. Now, when we are talking about rosuvastatin a little bit, we know that if we see the data of the Jupiter trial, there they had around 17,000 patients, and we all are aware that it was to see whether the long-term treatment with rosuvastatin decreased the rate of the first major cardiovascular, even compared with placebo. And the secondary endpoints were definitely the total mortality and the non-cardiovascular mortality as well, and the development of diabetes as well. The median follow-up was 1.9. And they did see a good reduction of LDL, you can see to the tune of 50%. HDL increase was seen. Triglycerides did reduce. This was another added benefit. As we were talking about, target the LDL first, reduce the LDL first with the statins, mostly for primary prevention, it works. Secondary prevention, we have to go for even additive therapies, which we're going to talk about soon. And hsCRP reduction was also seen to the tune of 37%, because we know that diabetes itself is an inflammatory disease, and the development of complications and even the beta cell loss is also related to inflammation. And that also is one of the factors which was studied in this trial. And when we talk about the risk reduction of the CV events, if you see 44%, number needed to treat is 25, MI stroke, CV death, 47% reduction, revascularization and unstable angina, 47%, fatal or non-fatal stroke, 48%, fatal or non-fatal MI, 54%, and CV events in CKD, 45%, and all-cause mortality in CKD, 44%. Now, if you see this Uranus trial data, it was found to be more effective in reducing the LDL-HDL ratio and non-HDL versus atorvastatin at 16 weeks data. Here again, they took adult patients who were diabetic at more than the age of 18 years, and the LDL mean was more than 127 milligrams per DL. This was one of the nice meta-analysis, which was a meta-analysis of 50 randomized controlled trials, where they were trying to see the LDL lowering efficacy of the 7 statins in patients with dyslipidemia, cardiovascular disease, and diabetic patients they have taken in this. They have taken all those studies. So they found and they concluded that in terms of the LDL lowering, rosuvastatin was better when they did the surface under cumulative ranking, which we do if we have more than 3 things to compare. So they tried to compare, and what they found out that the value of this sucra ranges from like up to 100% it can go. So this was 93.1, and they found rosuvastatin, after that atorvastatin, and then they had pitvastatin, simvastatin, and other statins as well. Now, if you see the ADA 2023 guidelines, they are very clear. They're pretty much the same, but there is a little bit of a difference. This was already there for patients with diabetes who are between 40 to 75 without atherosclerotic cardiovascular disease. We have to use moderate intensity, not low intensity. And between 20 to 39, if they have additional atherosclerotic cardiovascular risk factors, then you can initiate statin therapy. And higher risk who have multiple atherosclerotic cardiovascular disease risk factors, we have no controversy. Up to the age of 75, high intensity. This was already there last year also. Something new is they have added is in adults with more than 75 already on statin therapy, they say they continue the statin. Like previously, we were a little bit in a dilemma that whether to stop, continue. We were stopping for some, but now they say continue. It's a grade B evidence. And if with adults who are more than 75, it may be reasonable to initiate moderate intensity statin after discussion of the potential benefits and risks. Till now, it was our mindset that above 75, we were not bothering much, but now we have understood and we have evidence for that because we know our diabetes patients are living longer. Now the life expectancy has increased. Patients are coming to us who are very healthy, they're working, and we don't want them to get into complications, and they should be offered moderate intensity statin. But yes, we have to do again the personalized management. But this is what has been written in the ADA 2023 as of now. So as I was talking about, this is a risk continuum. So it doesn't end. It's not that today it is not there and it will not be there tomorrow, or today it is not there at all. After 5 years only it will come. It's not like that. It's a continuum. It starts. It's like it starts and it continues. It starts from the childhood. It continues. The atherosclerosis doesn't happen on day one. It continues. So we have to calculate the risk as per this. And none of the risk calculators actually takes into consideration everything. I showed you the UKPDS, which is one of the good calculators where we can have this type of risk assessment. So just 2 lines about the secondary prevention. So when the secondary prevention we are talking about, the target of LDL is definitely less than 50% reduction from baseline and the LDL cholesterol goal of less than 55. And we can add ezetimibe or PCSK9 inhibitors, which can be used over and above the statin if the patient is on a maximally tolerated dose of statin, because some patients may not tolerate the higher dose. We can add these drugs. Ezetimibe, we have evidence for secondary prevention where it reduced the MIs by 24. And in that around, in the Improve It trial, if you see around 27% of the patients had diabetes. And we also know that triglycerides, now we also talk about the reduction of triglycerides. We know that who already are in the higher risk group, patients who already have atherosclerotic cardiovascular disease, the Reduce It trial did show that there was a benefit and it can be considered to reduce the cardiovascular risk. But we don't use fibrates to reduce the cardiovascular risk. Fibrates are only indicated if the patient has a triglyceride more than 500 to 1000, where you are thinking the risk of pancreatitis is high. That's the point of time when we add fibrates. We also have to understand that when the patient comes with high glucose values at the outset, they may have very high triglycerides, but when we control the glucose values, the triglycerides do come back to normal. And statin niacin combination is not recommended. So the take home is we have to have, similarly, like we talk about the individualized management for glycemic control, now we talk about dyslipidemia individualized management. We do have the risk calculators like the ASCVD, which I showed, the risk calculator, and the UKPDS, which I showed you. We have the ESC guidelines as well. We have the ADA 2023 guidelines as well. But we also need to understand that now we also need to target our patients who are more than the age of 75, because they are also to be targeted with the risk categorization and may need moderate intensity statins. Secondary prevention is only additive therapies after statins have been used only for the secondary prevention. And we need to again individualize and see whether this patient needs it or not. We have evidence with rosuvastatin as well as with atorvastatin, as I showed you the data, but the meta-analysis did show that it had a better reduction of the LDL. That was a meta-analysis of around 50 randomized controlled trials. Thank you.
Thank you so much, ma'am. We can have the discussion later, ma'am, after the 3 talks. Now I just invite Dr. Vagesh Iyer, sir, who is going to talk about inflammation and the role of HYQs in practice. Dr. Vagesh Iyer needs no introduction. Dr. Vagesh Iyer is a DM endocrinologist, professor and head of the departments of endocrinology, St. John's Medical Hospital. Over to you, sir.
Yeah, thank you, Dr. Suman. At the outset, thank you, Dr. Sanjay Reddy, Dr. Arvind, Dr. Bhavana, for inviting me regularly. This is my 10th attendance to ADOR. Fine. I think next 15 or 20 minutes, I will explain the link between inflammation and the diabetes, then what is the role of the medication we have got for this inflammation, that is hydroxychloroquine in type 2 diabetes. So this is an overview of my talk from epidemiology to the summary. We know that worldwide the prevalence of diabetes is increasing and we are in the peak of the prevalence, with only China being ahead of us. And we are expected to see 700 million diabetics worldwide by 2045. And all these numbers are conservative, means you're going to hit this number in 2045, because all the previous estimates have been broken, and we had much more than what it was predicted. So same thing in India, it is around 77 millions we have type 2 diabetic patients. We are expected to grow to 134 millions. If you remember, by 2030, we were expected to reach 79 million. So in 2022 only, we have reached 22 million. So we are expected to reach or cross 134 million diabetics unless there is a major change in our lifestyle. So we know that inflammation is a very important contributor for many diseases, including pre-diabetes, diabetes, atherosclerosis, atherosclerosis-related macrovascular diseases, and also metabolic syndrome. So what this chronic inflammation does, there will be release of inflammatory markers like TNF-alpha, interleukin, TGF beta, PKC, and all these things activate endosomal NADPH oxidase. They generate a reactive oxygen species. These are quite toxic to the cell, and also NF-kappa B. This is the one which is going to cause more damage and one of the pathological importance in diabetes and also its complication. That's why we are getting a lot of medications which are directed towards NF-kappa B. This produces an inflammation, and the inflammation is a leading cause for a diabetes, atherosclerosis, and atherosclerotic vascular diseases and metabolic syndrome. So this is nitty-gritties of a inflammation, how it contributes to the insulin resistance and also beta cell dysfunction. So I think we have got two types of immunity. One is innate, another is acquired. There is some amount of a discrepancy in this immunity, and this leads to the development of a insulin resistance, and this insulin resistance leads to the type 2 diabetes. It's a beginner, but same these disturbances in the inflammation, they cause beta cell dysfunction because of the ER stress, reactive oxygen species, mitochondrial dysfunction. All these things reduce the beta cell function, reduced insulin secretion, insulin insufficiency. Both together, insulin resistance and insulin insufficiency leads to the hyperglycemia, that is type 2 diabetes. So if it just attributes inflammation to the pathogenesis of type 2 diabetes, it would have been all right, but it does even add to the complications. Most important being the micro and the macrovascular complication. We know that microvascular complication are a diabetes specific anyway. When the hyperglycemia happens, this complication going to set in, but macrovascular complications are directed even from the adiposity, which is forerunner of most of our diseases, including type 2 diabetes. This adipocyte release the cytokines and inflammatory markers. These pro-inflammatory things do damage the vessel and results in the atherosclerosis and the macrovascular disease. Then the question comes, yes, we know that inflammation is an important. Do we have any agent which addresses the inflammation and brings down the hyperglycemia? One such molecule which witnessed nearly a decade back, that was a hydroxychloroquine in type 2 diabetes. So how it does? I think most of the agents which are acting on diabetes are acting on several pathogenic aspects to address from octet to even 14 pathophysiological things. But this has got one unique way wherein we know that whenever insulin gets acted, subsequently it gets metabolized. Any molecule has to end its action. That metabolism gets reduced or degradation becomes reduced with the use of hydroxychloroquine. How this happens? Insulin comes and docks to the receptor in the cell, and there will be internalization. Subsequently, it gets degraded and insulin action comes to the end. But what hydroxychloroquine does is it retards the degradation of the insulin. Hence, more insulin is available for a cellular metabolism. Yes, it's there, sir. No, it's not. Yeah, fine. Okay, that's that point. Yes. Yeah. So more and more insulin is available for internal action, and more insulin is available. Hence, hyperglycemia comes down to the extent that it reduces HbA1c close to the other standard drugs other than our basic drugs to tune of 1%. So what about the anti-inflammatory action? I need not tell on this. Most of us are using in rheumatoid arthritis this hydroxychloroquine, and also I think last decade when we had an episode of post-viral arthritis, I think maximum number of patients were treated with hydroxychloroquine. That also has got a anti-inflammatory action. But what has been very clearly shown is you have got a marker of inflammation, that is a highly specific CRP. At the baseline, you can see it is on the higher side, and patients with type 2 diabetes who are got a higher HbA1c, the CRP comes down, and you can see even the HbA1c comes down. So whenever there is a reduction in the inflammation, there is reduction in the hyperglycemia, and this reduction is to the tune of 0.8 to 1.3%. Hence, it addresses the inflammation comes down, and the hyperglycemia comes down. Then comes the insulin sensitivity. I think this is just a surrogate marker of improvement in the HbA1c. This is whenever there is an improvement in the hyperglycemia, beta cell function improves, insulin sensitivity also improves. This has been shown in animal studies and even shown in the human studies. So we know that inflammation has got two aspects. One, it affects the insulin resistance. It affects even the beta cell function. When it comes down, your insulin resistance is going to come down. Even the beta cell function is going to improve. Hence, there will be increase in the beta cell function and reduction in the HbA1c. Then comes whenever there is improvement in the hyperglycemia, reduction in the inflammation, there is preservation of the beta cell. And once beta cell is preserved, the progressive decrease in the beta cell comes down, and you will be preserving the beta cell mass for a better use of a future diabetes management and also for the complications. So what has been clearly seen is there is lowering of the inflammatory markers in the pancreas, that is TNF alpha, TGF beta, interleukin 1s. So now we have got agents which are addressing these inflammatory markers. Probably in the next decade or so, we may get agents in type 2 diabetes only to address these inflammatory markers, but this agent is doing right from past 50 years. So this is just a slide which has shown that with use of a hydroxychloroquine, you can see that there is some improvement in the beta cells, fine, and reduction in the alpha cells. So the ratio is towards beta cell, hence the functioning improves, hyperglycemia comes down. This is all about the bench. Then comes to a bedside. So what are the clinical evidences we have got to address this? I think this is first Indian phase 3 clinical trial wherein patients who are not controlled on the two drugs. So most of the time you can see that place for this agent as a third add-on drugs. That's what been studied. So on two drugs, somebody is not controlled with A1C more than 7, that's 7.5 to 13 they have been taken. And they have found that for a one group, as a third add-on, they added a pioglitazone, and for the other group, they added a hydroxychloroquine. Then you can see the HbA1c reduction almost close to the pioglitazone. I think all of you are using pioglitazone. How many of you are using pioglitazone here? Okay, including me and Pramila is not using. Fine, that's right. Fine. So you can see that HbA1c reduction is almost close to the 1%, as similar to the pioglitazone, which has been internationally proven. So this is one more study, which is efficacy and the safety of hydroxychloroquine as an add-on therapy in uncontrolled type 2 diabetes who are using two oral antidiabetics. That's all. The place for this is a third add-on drug. You use as a third add-on drug, you'll get a very, very good response. Similar thing, but here the study was much different, where they did a dose hike. They gave for a one group 200, for the other group 300, for the other group 400. Close to the patients 400 were studied for a 12 weeks. This was mainly for a glycemic benefit, not for any of the other thing. For a glycemic benefit they saw, and also at the week 18 they saw even the other change from the baseline even for the HbA1c. So what you can see is there is response to the 200 also, 300 also, even 400 also. So you can see the HbA1c reduction is there with 200, little more with 300, much more with the 400. So when the maximum reduction is seen with the 400, why can't we use a 400? Or you should stick only to 200 or a 300. So what decides next is a side effect profile. So most of the time our use gets dictated by the what is the benefit, what is the side effect. If you look into the side effect, hardly you see much side effect with a 200 or a 300 and some side effect that is less than 10 to 15%, mainly a GI disturbances, that's nausea and vomiting. I think it's almost much less than the metformin, what it causes. Hypoglycemic events is little numerically more because of the higher doses, and also pigmentation is more with the 400. Otherwise, with the 200 and the 300, absolutely the side effect profile is almost similar to the placebo. This is one more trial wherein again persons on OHS, it has been very well studied. What happens to the person if he is taking insulin, if you use this agent as a third OHA on an existing insulin therapy. So again here for a one group, 200 was given. Patients who are on the standard therapy of metformin, glimepiride and the insulin. One group received hydroxychloroquine 200, the other received the 400, and glycemic evaluation done at the end of 24 weeks, that is 6 months. So here again the benefit what you see is with the 200, you see some amount of a reduction in the fasting plasma glucose, much more reduction with the 400. So also with the postprandial, both with the 200, it is reduced, with the 400, much more reduced. And after 6 months, this gets sustained close to 0.8% with 200 and almost 1.3% with the 400 milligram, which is significant compared to the baseline. Any reduction of a HbA1c more than 0.5 is good enough to prescribe a drug. That's what international standards say. I think it has reduced much more than what has been expected. So we know that once the glycemia comes down, hypoglycemia is the one of the expected thing. And when person is on the insulin, the best way to reduce the hypoglycemia is to by reducing the insulin doses. Same thing was seen with the 200 and the 400. You can see close to 4 units insulin dose was reduced with the 200 and close to 10 units was reduced with the 400 milligram. So glycemia improves, requirement of the insulin comes down, and also maximum with the 400, less with the 200. Then comes the inflammatory markers. Same, higher the dose you use, higher the reduction of a inflammatory marker, that's a CRP. With the 200, it is less, but with the 400, it's a much more. Yeah. Then comes the CV safety. Now we want to have a drug which is safe to reduce the glucose without affecting our heart. If it benefits the heart, it's good enough. I think this is one drug where when we started using this drug, already it had a CV safety. Which are the other drugs which had a CV safety in a diabetes before we started using? This is one. In fact, they need not, we had some evidence of a CV safety because they were used in the long term with in a rheumatoid arthritis. Is there any other drug which had a CV safety before we started using? Otherwise, most of the thing we have started using after 5 years, CV safety data has come in. Any postgraduates? Insulin didn't require, Degludec we did later only, CV safety, it was not there. Metformin came later. Pioglitazone came late, didn't come on late, came other way around. The other drug which has been used is an bromocriptine. Immediate release bromocriptine had a CV safety, then only we started using because it was in use from right from 1975. So this is one of the two drugs which CV safety came much before we started using it. So this is a study from the Journal of American Heart Association. It's again a retrospective rheumatoid arthritis cohort because from 1957 this drug has been used in a rheumatoid arthritis and they found that it's quite CV safe. We don't want any benefit. If it doesn't harm, it's more than enough. So this is quite CV safe from the Journal of American Heart Association. I think this has been further studied in an oxy pilot trial using because it does reduce the interleukin 6. Once the inflammatory markers comes down, you expect some amount of a cardiovascular benefit. What this oxy trial showed is Hydroxychloroquine lowers interleukin 6 levels more than the placebo, suggesting it might be beneficial in reducing cardiovascular inflammation. That's why 300 milligram per day for somebody is weighing less than 60 kgs and can be safely administered even after MI. So that post MI you want to give any OHA, this can be given. This is been done by the Oxy trial conclusion. Then comes the retinal safety. Retinal safety is a major issue when we use a hydroxychloroquine in a rheumatoid arthritis patient. But I don't think it's a major issue when we use in patients with type 2 diabetes, because otherwise also our patient go for a regular annual retinal evaluation. So this is not a major issue for our patient. Anyway, they go for a retinal evaluation. However, it has been shown that in the dosages, when they use lesser dosages, that is less than what we use for a rheumatoid arthritis, there is no significant retinal problem when we use HCQS, and most of our patients going for an annual checkup, retinal checkup, and at the earliest we can pick up and we can discontinue if something happens. That has not been shown in any of the trials. So we know that so much benefits are there. This drug being used for rheumatoid arthritis right from 1957. Is it been recommended? If we don't find the recommendation of this drug in the ADA or a EASD classification, but we find in our own recommendation, that's a RSSDI. So in RSSDI, it does show recommend this drug as a third add-on patients who are not controlled on the conventional sulfonylurea and metformin or any other agent. Third add-on we can use, and we can, even the trials have shown, it can be added to the patients who is taking a 2 OHAs plus insulin as a third OHA. To summarize, as an add-on therapy of this hydroxychloroquine reduces HbA1c anywhere between 0.9 to 1.3%. It's quite retinal safe if you are using less than 5 milligram per kg per day, and most of the time our diabetic patients will be using, we are doing an annual retinal checkup. So hence this may not be a major issue in our patient. It's quite CV safe because it's the safety came much before we started using it, and 200 milligram is quite suitable based on all the trials which have come in the patients who are weighing less than 60 kg. I think that's quite less to see, except 1 or 2 I can spot. And it is 300 is suitable for somebody is more than 60 kgs. So this drug would have been used for many people who are seeing now obese or were very young. I think this is Dr. Same. I'm seeing two of my friends with more hair than what they have got now, with the lesser weight also. Thank you for your patient hearing. This is nearly 17 years back, 2005.
Thank you, sir. It was an excellent talk and you just kept us occupied. Thank you so much. I think we'll take the questions in the end. Moving on, we have Dr. Sanjay Reddy, sir, who is going to talk about the fixed dose combination. Earlier in the day, we were listening about either sulfonylureas or DPP-4. Now, sir is going to talk about the combination of DAPA with sitagliptin. Over to you, sir.
Thank you. Thank you, Suman, and thanks, Dr. Arvind, and to pushing me to do this talk. We had a lot of molecules being discussed from yesterday: SGLT2 inhibitors, sulfonylureas, DPP-4 inhibitors, HYQ, insulin. I think everything is discussed. What I'm here trying to say is, I would look at, and Dr. Vijay Kumar is telling, one diet alone, exercise alone, drugs alone. I think it's a combination of everything which works, and we all know in management of diabetes. And we can say that the same combinations of drugs which are there, are they beneficial? Should we combine them? And there's no doubt about it, because now what we did 10 years ago, people are saying, now let's start combination therapy. You can use combination therapy. All the guidelines have started talking about it the last 3 years. Now, is there a rationale of combining SGLT2 inhibitors and DPP-4? The spotlight is on dapagliflozin and sitagliptin. We know already existing, approved, well-approved combinations like empagliflozin and linagliptin, and dapagliflozin and saxagliptin, because they're manufactured by the same company. Now we have two different molecules manufactured by two different companies. Do we combine in our country? Yes, and it's specific to our country, so we stick to it. We do use them. We have every combination available: DAPA, SITA, DAPA, vildagliptin, which is not there anywhere else. So what I'm going to talk about is what is the data and what goals of diabetes care are. We've been listening. Do we prevent complication, optimize quality of life? I think, a very important statement, and what ADA and ESG and everybody from glycemic management, we moved on to weight management, cardiovascular risk factor management, cardio-renal protection. This all came in, and how the guidelines changed over the years, taking comorbidities into consideration and understanding the pathophysiology over the years has been enormous. So what happened is now the focus is cardio-renal protection, weight management. Do we have drugs? Can we combine them? Are they going to be effective? So one of the most important thing is the cardio-renal snapshot of metabolic interaction. We have heart failure as one of the, we listened to yesterday, Dr. Keshav and Dr. Prakash talking and taking us through the benefits of SGLT2 inhibitors and management of different drugs used in the management of heart failure and how common it is in diabetes patients. And these are the reasons that we have cardiac congestion, decreased cardiac output. There's a huge neurohormonal and inflammatory response. We saw Dr. Vagesh talking about the benefits of HYQ and inflammation. There's another pathway. Probably tomorrow we'll have a drug, which a combination of drugs. Now we have already 3 drugs, metformin, sulfonylureas, pioglitazone was there. Then you have metformin, all sorts of combination. Then when do you use them? Do we use them in the beginning? We'll take you to the end, different scenarios where we can use them. Diabetes, hyperglycemia, insulin resistance, oxidative stress. We've seen and heard all of this causing renal damage, chronic kidney disease. Can we use drugs which can address these complications early on is what we need to look at. 65% of deaths are due to CV disease. Coronary artery disease increases 2 to 4-fold in the diabetic patient. Heart failure up to 5-fold. Actually, it's one of the earliest. Stroke 2 to 4-fold. And these can start even with impaired glucose tolerance. And then I liked the talk yesterday, if anybody would have listened to John Buse telling us why not use SGLT2 inhibitors even before metformin when a patient has diabetes or even pre-diabetes. That's the benefit of these drugs, and that's what we're saying. So heart failure is one of the manifestations, first manifestations of type 2 diabetes related CV disease more often than was MI or stroke. So heart failure is more common. But one thing, remember, before heart failure, please examine somebody's foot. And if you find peripheral artery disease, make sure you're sure that this patient has CV disease. And this is what the data is showing, that heart failure is more common. Now, I was listening to Ganapati and he was telling me, oh, we see garden variety because he wanted to defend and talk about DPP-4 inhibitors. Only 20% of my patients are cardiovascular risk. I just was looking at data published on complications of patients with type 2 diabetes, newly diagnosed type 2 diabetes, listening to Dr. Pramila and what we were in a gray area, whether to start statins with somebody with 18 and 39. Now, it's clear guidelines. Even after 75, the benefit of statins. Our understanding is increasing over this. The CV mortality in type 2 diabetes. I think I've not learned so much of heart failure the last 1 year, what I've learned, not even in medical school, entire of my career. My knowledge on heart failure and diabetes is so much. Why is this? We're seeing so many patients. And is this because these molecules are doing benefit? So heart failure development any year since type 2 diabetes diagnosis was associated with the highest 5-year absolute and relative risk of diabetes. 40% of diabetics will develop diabetic kidney disease. And we do all see, and this cardio-renal compendium is here to stay. So these are the mechanisms of this. I'm not going into the details of these. So what are the update on guidelines? 2022. See, if you look at 2022 guidelines, minimize hypoglycemia, weight gain, there was place for DPP-4 inhibitors, there was a place for SGLT2 inhibitors, there's place for sulfonylureas, and now how they changed, didn't change much. What they did was in 2023, I know Dr. Arvind showed this slide very much. They took the DPP-4 inhibitors and told all the last decade, I was talking only about DPP-4 inhibitors. It was only this cardio safe, you can use them. They're very nice drugs. But believe me, they do work very well in Indian subset of populations. So I've said country specific here. Individual diabetes is not only diabetes, I think every risk management of a patient is going to be patient specific, disease specific, country specific, probably to your clinic specific, or acceptability of the patient, accountability and affordability of this patient. So these drugs and the way you're going to be treated for chronic disease is if you can do these three. Now, this is 2023 guidelines. Look at it, SGLT2 inhibitors, everywhere. So all the patients could fit into getting SGLT2 inhibitors if the EGFR is holding up. DPP4 inhibitors still work in our population. I'm not sure why the ADA done one. I know the GLP-1s are much better, but yes, DPP4 has to stay. So this is the EASD and the ADA combined guidelines telling us how to use. And early combination therapy too. So this talk about this combination therapies. So combining SGLT2 inhibitors and DPP4, what do we have? Now, so if you look at the pathophysiology of diabetes, if you use both of these molecules, I think you cover not everything, and the majority of the pathophysiological mechanisms can be addressed. So complementary glucose lowering activities of DPP4 and SGLT2 in type 2 diabetes, you have the kidneys where you have glycosuria, glucotoxicity is reduced, weight, systolic blood pressure is reduced, hyperglycemia. Now you have data of using SGLT2 inhibitors and reduce in uric acid levels to on the pancreas, beta cell sensitivity, glucagon, increased glucagon. Look at this. There is DPP4's decreased glucagon here, the increase. This also is neutralized to some effect. And then you have weight neutrality of DPP4 and definitely reduce hyperglycemia. When you combine this and the combination therapy, what do we see? SGLT2 and DPP4 change in A1C from baseline versus if you compare two drugs, definitely two drugs are going to be powerful. They have some effect. So they favor, it favors SGLT or combination of SGLT2 inhibitors and sulfonylureas than only DPP4 inhibitors. So this is SGLT and DPP4 change in A1C from baseline according to baseline A1C versus DAP versus DP4. Again, it's a combination which is better. So similarly, change in A1C from baseline. These are all a compendium of trials trying to tell you that a combination of SGLT2 and DPP4 is better than using only a DPP4 or an SGLT2. So this will be known. So what happens in change in body weight? If you look at the change in body weight when you use SGLT2 and DPP4 inhibitors, whether you're sequentially using them or using them combination in the initial stage is better. Look at this. If you use it in the beginning, there is significant, sequentially, if you add it, there's not, the difference is minor, but you have some additional benefit. Relative risk of hypoglycemia is also better when you're using them at the start go than adding sequentially. DPP4, relative risk of urinary tract infection. This is interesting. If you use them as a combination, there is slight benefit even in the relative risk of developing urinary tract infection, or rather than adding them sequentially. Genital infection, this is what the data is showing, that using them in the beginning is better. So this is the paper which shows that DPP4 inhibitors moderate the risk of genitourinary tract infections associated with sodium glucose co-transport inhibitors. So it favors that if you use them in combination before, the genital urinary infections are lesser compared than using them one after the other. So in type 2 diabetes, so if you look at the adjusted mean change of baseline in A1C over time of the entire patient population. I know we have the DAPA-CITA metformin combination also coming in. So this is so where do we place them in decision making? Where do you want to give them? You can start them in the beginning, as you tell a patient walking into the clinic, even before metformin, I would sometime. If the patient is already having a cardiovascular disease, diagnosed newly with type 2 diabetes, A1C of 8.5, yes, I would use it even before metformin sometime, but I don't know, that's a personal statement. But after metformin, you can use them in treatment-naive patient, treatment-naive with metformin, metformin not tolerated. Yes, this is one. So based on glycemic factors, uncontrolled on metformin plus second line, you use the metformin sulfonylurea. Do you want to add on this as the other drug? Or in patients with on insulin, you want to add SGLT2 and a DPP4 inhibitor if he's already on sulfonylurea and metformin. So appropriate use of SGLT2 and DPP4 based on heart failure recommendation. Now you look at sitagliptin data, it's cardiovascular safe, doesn't have any indicators towards heart failure. So if you want to use these patients and you want to accept a better glycemic outcome, SGLT2 and DPP4, you know they are all generics, the cost of them is very less. Same thing similarly in patients with renal dysfunction, or if you have falling GFR, you want to use both of them. I think they are safe, and the benefits, the cardiorenal benefits, you're known to, you know the cardiorenal benefits. Yes, sulfonylureas are potent drugs. There is a chance if you get causing hypoglycemia, but if you use SGLT2 and DPP4, and then later think if the patient doesn't achieve a glycemic goals, you can add on. They can be used in the armamentarium of any type 2 diabetes. Combination therapy, friends, is going to stay, and we've been using it for such a long time. This is the data of combining a DPP4 and SGLT2 inhibitors. It's going to have all the cardiorenal benefits, better glycemic control, lesser genitourinary infection if you use them combination early rather than using them sequentially. Thank you very much.
Thank you, sir. If you can stay back for the questions, I think, ma'am, if you can just come on the dais. Wagesh, sir, if you can on the dais. Now it's open for the discussion.
Here I come.
Let me start off, ma'am, actually, so that let the ball growing. Generally, it has been said off in the earlier talks by the cardiologist that if you're a diabetic, start on a statin. What is your take?
No, it's not like that. As I showed you, we have various ways to decide. Above the age of 40, no controversy. We have to give to all type 2 diabetes moderate intensity statin. We're not negating that fact. Between the age of less than 40, there the controversy is between that 20 to 39 age bracket, where we can calculate the risk scoring. We can see if the patient has risk factors. So there are so many risk factors. If patient already has target organ damage, like I showed you the data, or patient has already like evidence of microvascular complication, they have family history of premature heart disease. So these are all the indications, and they're all any of the 2 risk factors, if they are positive, then it demands that we put the patient on a moderate intensity statin. But it's below 40 is not for all, but above 40 for all, moderate intensity, but high intensity for high risk. That's how I put it. But still we cannot say below 40 for all word we cannot.
Once started, we cannot stop. Is there any stoppage?
Yeah, there is data, because if you stop the statin, there is data to show that there can be increased incidence of the plaque destabilization, and there were increased incidence of cardiovascular events in patients who intermittently stop their statins or just stop their statin. Though there is data with alternate day therapy of statin, that data is available. There are studies with that where people have tried, instead of giving this just for compliance reasons. We also did one study on alternate day statins, but that's not advocated. As per now, it is daily statin dose, whatever moderate intensity is required for the patient. Stoppage is not recommended because it can actually precipitate an event. That study is available.
Not recommended.
Yes,
anymore.
only for hypertriglyceridemia it is recommended, where you're treating hypertriglyceridemia for the treatment for prevention of pancreatitis. There you give fenofibrates.
So in combination with high LDL and high triglycerides, still a
Icosapent,
combination.
omega-3 fatty acids, icosapent, I have shown that data, that for the if you're giving it for cardiovascular risk reduction for secondary prevention. For primary prevention, we are not reaching that level. Okay. If the patient has a triglycerides more than 500 and the blood glucose values are under control and you don't get any secondary cause. Just to add here, it is very important that when you see a patient with hypertriglyceridemia, always rule out secondary causes first. Sometimes you will see one commonest, I told, uncontrolled glucose value, insulin resistance. These are the commonest. Then the second is uncontrolled hypothyroidism. A lot of hypothyroid patients will present like that. So all these, the secondary causes have to be ruled out. And once you have ruled out and you think lifestyle modification, diet, everything has been tried, the triglycerides, if it is beyond 500, we treat for the prevention of the risk of pancreatitis. There we have to give fenofibrates. But when we are talking about secondary prevention, then we have data now I showed you from the omega-3 fatty acids where they have shown the risk reduction even with the level of 139 to 499. Also, they have said that if the patient has a higher risk and has multiple risk factors, still then you can treat the hypertriglyceridemia. But fenofibrates have not shown reduction in mortality. In whatever trials they have given fenofibrates for the reduction of cardiovascular mortality, the data is not positive.
So neither the omega-3, right? Ma'am?
But they have shown in that there is a which study I showed you where there were around 27% patients were diabetics. They have shown a reduction.
Reduction in mortality. Okay, and how about pre-diabetic?
This is over and above the statins. We should never use it. Oh, like this is all things are over and above the statins.
So statins will still continue when the patient's triglyceride levels come
Statins have to continue. Statins are the initial therapy. They have to continue even if you are treating. See, there are two things. If you are treating a type 2 diabetes who has dyslipidemia, you are treating with statins first. Triglycerides are the secondary target in secondary prevention, where you are targeting in cases as per case to case basis between the levels below 500 also for the cardiovascular risk. But if a patient has beyond 500, you are treating for prevention of hypertriglyceridemia, for the prevention of pancreatitis. That's one thing. That is fenofibrates. When you are talking about overall use, if you have treated a patient with statin and you have added triglycerides, triglyceride reduction also, omega-3 and all that, and you are trying to bring it down, you continue with the statin. The statins will continue. Statins are not going to be stopped.
But we can stop fenofibrates if the triglycerides come back.
Yeah, but many of these patients who have familial hypertriglyceridemia, and if they continue to be having the higher triglycerides, you might need to continue the fenofibrates. But there are a group of patients where we do, we have some patients who came with very high triglyceride, we treated them, and then we put them on fenofibrates, and now they're younger patients, they're doing better. We did reduce and we have stopped in few of them, but statins are not to be stopped if you are giving it for the reason of the cardiovascular risk reduction. No, statins are not to be stopped. Pre-diabetics, we have the risk calculation. We have to see if there is then it comes, we have the guidelines for pre-diabetes separately. We have the guidelines for the normal population separately. So we calculate the risk scoring and decide whether they need statin. The cutoffs for them are higher, not the same as type 2 diabetes.
There's a question about bempedoic acid.
Yeah,
I think initially when we did the phase 3 trials,
Yeah.
it was all for statin intolerant patients,
Correct.
but now it's also released. Well, it did well in statin intolerance, but it is not a big problem as we think it is in India. Hardly we could get
Correct.
patients
True,
for this
true.
particular trial.
True.
Now, where do you use bempedoic acid? Because the marketing strategies are totally different, and most of the physicians may not know, and they tend to believe that it's as good as statins.
No,
Now, where does it stay?
Yeah, absolutely. I didn't discuss about it because I thought it is a big topic in itself. So voluntarily, I actually didn't put it because as of now, we are not putting it. It's not there in the guidelines. We have data with bempedoic acid. It does help to reduce the LDL levels. Definitely, we know that. But the reduction in the mortality, we don't have at the moment. So why we are still sticking on to statins and not talking about and only saying that we'll use bempedoic acid in patients who are intolerant to statins or whom we cannot escalate or we don't get the requisite amount of the LDL drop, we can definitely put it at that point of time. So I may say that like maybe over a period of time where we say that we haven't achieved that LDL target of maybe less than 55, where we are thinking about other options like PCSK9 and other things, maybe bempedoic acid will also come into that picture. But as of now, we have no reduction data, mortality reduction. So we cannot put it at par with statin. It's definitely not at par with statin. It is after that, maybe it may come over there, but we need to have data.
Yeah, this is a clinical case, an actual case that came to Daikon Hospital. 35-year-old lady, type 2, wants to conceive very badly, familial hypertriglyceridemia. When she's on treatment, it's in the region of 400, 500. She stops the fibrates, 1,600, 1,700. She wants to conceive. And some gynecologists said, well, we can give her omega-3 fatty acids. We'll allow her to conceive. Most others said, no, it's not worth taking a chances because pancreatitis chances increase with pregnancy. What would you have done? What would have been your advice to this patient? Conceive or don't bother about the child?
No. I think lifestyle modification and omega-3 is what we can do. Phenofibrates, we can't say that we can give it. There is some data with this basically like people have tried curcumin, that is haldi, people have tried. There are studies in pregnancy because I had a similar patient and there are studies in
And that too, this
pregnancy.
patient already has one child, 3-year-old, and now mother-in-law wants a son. And then the
Then,
mother-in-law is forcing, the husband is not keen, the mother-in-law is forcing. Now, this is the
Then we
problem.
counsel the mother-in-law, that's better.
Dr. Sajay sir, generally it was told that, in your talk that when you're using a combination of a DPP or SGLT2, the chances of UTI is less. Is there any particular rationale or knowledge?
There's a rationale. They say that it works on the immune system. DPP4 does have something to do with this. Exact mechanism I forgot. It works. Inhibits the fungicide bacteria. It works on, because when you looked at DPP4 earlier, there were reports of how it works on the immunity levels. Probably those one of the explanation for that is fungus.
It acts on the
Bacteria. Proposed.
No, that's been shown.
Yeah.
I think that's the only advantage of adding. Otherwise, placebo also shows same benefit.
Sir, how about, sir, Vagesh sir, how about your HCQs? Even though HCQs is there since a long time, the usage is really less. I don't know why. What is it?
No, because it's the third add-on. Now we have got a big, I think, market for the third add-on drugs. Fine, that's why third. If it's come as a second add-on, the studies would have done then. But we are using in a selective patients. Somebody with diabetes, viral, post-viral arthritis and all, they respond very well to the HCQS with good control of the things. I think we need, every medication has a role, but it needs to be used in selected patients.
Thank you so much. I think we'll.
Very well on this. There we are using with HPQ in patients who have joint pains and diabetes both, and we require like 0.6% reduction. There they do very well. Yes, especially like we have to examine the fundus before we go ahead with it. That's the most important.
Thank you so much for all the three speakers.
Just a question.
Yeah, I'm sorry. Go ahead.
Vagesh sir, DPP4 inhibitors. There's so many out there in GP practice. You see sitagliptin, tenligliptin, vildagliptin, and you're told that some have toxicity. See, and you're told that tenligliptin is relatively safe in liver and kidney. I mean, do we just keep shuffling with them, or do we select one and go with one? What's your suggestion? How do we?
I think, no, the reason being, efficacy wise, all are same. Only thing, one needs to be given OD, other needs to be given a BDN. So for efficacy, tenligliptin needs to be given BD, but you can give sitagliptin and modified vildagliptin can be given OD, even linagliptin can be given OD. That's one advantage. That's it. Second thing is your side effect profile. Saxa, I don't want to give somebody is in the failure. In fact, I don't want to give any dip for somebody is in the heart failure. Okay. Fine. If a renal issue is there, lina and tenli goes up. If a cardiac issue is there, I may not use the tenli and the saxa. So the only thing is so many gliptins are there. Another 25 will come in next 10 years. You have got lots of choices. Fine.
Okay, sir. Thank you.
If there are no questions, we're going to hand off. I think we are starting an interesting session. I just hand over to Bhavna.
Thank you. Let's take a small break for coffee and tea now, and followed by this, we'll be starting with the sorting hat event. We're just waiting for Dr. Chitra to join us. Dr. Vasan is unable to make it for other personal reasons now. So we're going to next move on to the sorting hat. And while we wait for everyone to come in, we'll have coffee and tea. We'll start at 4:15, yes.
Yes, absolutely.
Welcome, Mina. Ena run ಮಾಡಪ್ಪ ಲೈಟ್. ಹಿಂಗಿರ್ಲಿ ಹಿಂಗೆ. ಚೇರ್ಪರ್ಸನ್ ಅಂತ. ಹೊಡೆದ ಫುಲ್ ಹೌದಾ? ಟೀಚರ್ಸ್ ಕೇಳಿದ್ರು ಜಡ್ಜಸ್ ವರ್ಕ್ಶೀಟ್
ಅನ್ಕೊಡ್ತೀನೋ ಅವ್ರ ಫಸ್ಟ್ ಮಾರ್ಕ್ಸ್ ಕೊಡ್ತಾರೆ. ಇವಾಗ ಇಲ್ಲಿ ಲ್ಯಾಪ್ಟಾಪ್ ಏನು ಯೂಸ್ ಆಗಲ್ಲ ಅಲ್ವಾ? Right? 4 teams help 5 teams. You 5 teams ಇಲ್ಲ teams ಬಂದಿರಲ್ಲ ಅಲ್ಲ ಅವರು ಅಲ್ವಾ ಮಾಡ್ತಾರೆ ಅಲ್ಲ teams ಬಂದಿರಾ You just send it to Rachana.
But the second time, the other person has to speak.
You need to talk about.
Yeah, it's on.
You can talk about this whole thing.
Hello, everyone. Good evening and welcome to the Sorting Hat. We're just going to start in time, and Dr. Chitra has walked in to get this event kicked off. Before I hand over to her, I would like to first call all the 5 teams up, and I'll ask you to introduce yourselves. We're going to do that while Dr. Chitra got here. So each of you, 5 teams. We initially planned an actual sorting because we had 4 teams confirmed. Then we got a last minute 5th team coming in. So we said, okay, we'll stick to your colleges and teams. Teams, one by one, can you guys come up here? You can all come up here, tell us your names, where you're from, and then I'll call Dr. Chitra on and we get started. Or you can, yeah, pass on the mics.
Good evening, everyone, and welcome to this event. I'm Dr. Pooja from Diacon, a second-year resident.
I'm Dr. Kirtana from Diacon. I'm doing my first year fellowship in diabetology at Diacon too.
Good evening, everyone. I'm Dr. Bharati, final year resident from Ramaya Medical College. Good evening, everyone. I'm Dr. Rachna. I am from Ramaya Medical College. I'm in the first year resident.
Very good evening to all. Myself, Dr. Nikita, final year senior resident in the Department of Endocrinology, Ramaya Medical College.
Good evening. I'm Dr. Altha from MS Ramaya.
Good evening. I'm Dr. Veena from Diacon.
Good evening. I am Dr. Shavanti from Diacon Hospital.
Good evening, everyone. I'm Dr. Aishwarya from St. John's.
Good evening, everyone. I'm Dr. Pankti from St. John's.
All right, so thank you all for the introductions. As requested by many of you, the judges have agreed for 2 things. One, once you guys pick a topic, the team can decide who wants to speak that topic. And for the next round, we would request the other team member to speak. The second, after you speak a topic, there's a timer here. So please keep an eye out on that. It gives you 1 minute to kind of formulate your thoughts. And then you get 3 minutes to speak. So keep an eye on the timer. No, 1 minute.
1 minute, 1 minute.
1 minute.
Yeah, so I now call on stage Dr. Chitra. Dr. Chitra is here running. So I now invite Dr. Chitra, Professor of Endocrinology from MS Ramaya, to kick off the sorting hat event. And we're going to actually make her wear this hat now.
Sure.
And she has the magic wand.
Sure, Bhavna. Thank you.
All yours.
I have a feeling this is secretly Dr. Arvind's plan to just get me to look ridiculous on stage with the hat, but I'm going to play along. Okay, so the rules of the game before we start, there are going to be 5 teams, 2 per teams. We've met all of them. Round 1, one speaker from the team comes. You can choose who will come up and speak amongst you. The second round, the other person has to come, right? At the end of 2 rounds, the judges will then have some time to deliberate. 2 teams will be eliminated, but the other 3 teams will move on to round 3. And then they'll decide the final round of people, okay? So we'll go like this. Is that okay? A, B, C, D, E. Is that okay for all? Okay, great. So now for the sorting song. The sorting hat decides your fate. Pick a topic and let's orate. 3 minutes you get, so keep your time. Choose your words to truly shine. Where science, knowledge, and truth is told, honor, glory, and riches behold, truly riches behold. Let us begin your claim to fame. State your name and play the game. All right, so may I request the first team, Team A, both of you can maybe step forward, pick a topic, and then claim your 1 minute to formulate your thoughts. The judges have been kind enough. Team A is all ready and wants to go straight with no time for formulation. Great.
I understand.
Come on stage.
Metformin in lactating mothers.
So you will be also given points and taken away points depending on if you exceed your time as well. So keep your eye on the timer. The timer is here.
Yes. Metformin, as we know, has been the safest drug in pregnancy and lactation, which has been practiced over decades. And today, debating or like commenting about metformin use in lactation, enough data we have to prove that there's a very minimal amount of metformin levels in the breast milk at any point of time when a lactating mother is on a maximum dose of 1,500 milligram a day. It was about found to be about 0.2 to 0.5% in breast milk. And also the fact that there was no relevance or to timing of metformin and timing of breastfeeding, because at any point of time, the serum or when the infant's blood was tested for the metformin level, it was the same or the other way also. And when it comes to the adverse effects, we have again enough data to be proven that there is no adverse effects being found in infants who have been fed by a mother who is on a metformin. And as Chitra ma'am emphasized yesterday on the importance of continuing euglycemic state in the postpartum period, which is being neglected, especially in our country. As soon as the baby is born, the mother neglects about her personal health and says, okay, this was GDM, it was bound to go back to normal and I'll be in a euglycemic stage. No, please monitor. We have to recommend them to monitor their blood sugars and to tell them even before the delivery and emphasize the importance of continuing being in a euglycemic state and how important it is for her and the baby's future health, which is also been shown in few data. A euglycemic mother will help the baby grow up to have a lesser risk of metabolic syndrome. And last point I would like to emphasize is there are enough studies today to say metformin to be used as a galactogog in high-risk mothers who have a incidence of lactation failure. This is in relation to the insulin resistance that has been proven in pre-diabetic and GDM or type 2 diabetes. Thank you.
Well done.
Yes. Yes.
So you will check the time from there, right? So that they can keep an eye when they are on stage. Okay, so team B, let's go. So also know that there's a minute for you to formulate your thoughts, yeah?
Number five. Who is going to speak?
So give them some few seconds. Yeah.
Let's start. Topic is C-peptide and GAD antibody. C-peptide coming, what is C-peptide is nothing but it's a connecting peptide. It connects the A and beta chain, alpha and beta chains of proinsulin that is made in endoplasmic reticulum. So why this measurement of C-peptide is important is because why can't we directly measure insulin? This is basically done to, you want to assess the insulin reserve in a patient. You want to know whether they're insulin deficient or insulin resistant. So we are doing the C-peptide. Why not insulin is the question is because insulin has a shorter half-life of just 2 to 3 minutes, whereas C-peptide has a longer half-life of 20 to 30 minutes. And there is variable extraction of insulin from the liver. So that is why we're using C-peptide. The serum levels of C-peptide also can be used as well as the urine levels can be used. Serum C-peptide, always remember it is collected in a gel tube and it is always should be in a pre-chilled tube and in a cold chain it should be maintained. There are certain, it is measured in like nanomoles per liter and there are different cutoffs for fasting as well as stimulated. So for absolute insulin deficiency, it is like less than 0.08. And for type 2, it is more than 0.08. The stimulated is less than 0.2 and more than 0. For type 2, it is more than 0.2. So the C-peptide is used for differentiating type 1 and type insulin deficient and resistant, also in factitious hyperinsulinemia and other hyperinsulinemic syndromes. Coming to GAD65, it is nothing but it is a precursor for GABA, which is a neurotransmitter. This is found in the pancreatic islet cells, that is GAD65 isoform. It is antigenic. It is there. It's also found in 4 to 8% of the normal population as well. It has a very good sensitive and specificity for the diagnosis of type 1, also for predicting the risk of type 1, developing type 1 diabetes. So the thing is GAD65 is also found in a type of diabetes called LADA. It's also found in non-diabetic conditions like Stiffman syndrome. Now the therapeutic implication is that GAD65 and vaccine also has been developed, which is not proven of much efficacy in preventing diabetes, but the trials are still undergoing. Also in a study in rat, it was shown that GAD65, when it was given to mice, it was able to induce a little bit of self-tolerance and help to prevent the type 1 diabetes. So the same concept you can move forward and use in the prevention trials also of type 1 diabetes. The other thing about GAD65 is that there are two isoforms are there which are found from two different chromosomes, GAD55 and GAD67. But even though GAD67 is more found in the pancreatic islet cells, GAD65 is shown to be more antigenic. So that is why we're measuring GAD65 antibodies. Other kind of antibodies are islet cell antibody, IA2, zinc transporter 8. But as I said, the sensitivity is around 85% and specificity is more around 96%. So this is about C-peptide and GAD antibodies.
Can we have a representative from team 3 to come in? Please use the mic.
Glucometers for SME. Topic number 4. Topic number 4.
1 minute timer on my.
Connected glucose.
Three-minute timer set, buddy. Wait. There.
So my topic is connected glucometers for self-monitoring of blood glucose. So we'll start with self-monitoring of blood glucose. It is nothing but patients check their own blood glucose levels at home. They keep a record of the blood glucose levels and then bring it back to the healthcare center. So as we know, there are many types of glucometers. The evolution has been from the past many years. So basically, previously there were standalone glucometers where when the person checks his blood glucose levels, automatically the reading shows up in the glucometer. Whereas connected glucometers are the recent type of glucometers. So few differentiating features from the standalone glucometers are they are very smaller in size. They do not have a display. We have to connect it to a smartphone through, so we have to download an app first in our smartphone, the app which is suitable for that type of connected glucometer. And once we download the app, when we connect that to the smartphone, we have to insert the strip and check our blood glucose levels, and automatically the reading comes in the phone, but not on the glucometer as it does not have a display. So what are the advantages of connected glucometers? It also stores the blood glucose readings, what were checked in the past few days, and it also gives us a pattern of the blood glucose readings which were checked in the past few days. So the advantages is that we have a record of readings, and but few disadvantages are there where patients who are illiterate and who do not know how to use the technology, it is difficult for them to use this type of glucometers. But advantages are it is easier to know, easier to know whoever knows about it, and also we have a pattern so that we can make some changes in the treatment pattern for the patient. So there was in India 2 types of connected glucometers are there. One is DITO and one is Glucomi. There is also a program of diabetes education which was inculcated into this connected glucometer system, which was done in the United States of America, which is called the Living Diabetes Program. In this Living Diabetes Program, once the patients check their blood glucose levels with the help of this, all this data is transferred into the Living iCloud, and from there the diabetes educator is able to receive this information, and they will educate the patient about how to do the changes in their treatment. And one more advantage of this is that whenever the blood glucose levels are going less than 50, it gives us an alarm to the patient. And also when the blood glucose levels are going more than 250 also, it gives an alarm. Thank you.
Well done. Can we have team D coming up? Please use the mic to announce the number of your topic. 1 minute. We are anxious to know the topic.
Ma'am, topic number, should I say, no?
Yeah.
Topic number 24.
You could also read the topic.
So non-alcoholic fatty liver disease.
Sure. Please come.
My topic is non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease can be divided into non-alcoholic fatty liver and non-alcoholic steatohepatitis. Non-alcoholic fatty liver is the deposition of fat in the liver without any inflammation, while non-alcoholic steatohepatitis is the deposition of fat in the liver with inflammation. This non-alcoholic fatty liver disease will develop into NASH on certain conditions. And this non-alcoholic steatohepatitis may develop into cirrhosis and end-stage renal failure. There are certain symptoms like fatigue, weakness, tiredness, right abdominal pain, etc. You can be seen in non-alcoholic fatty liver disease. How do you diagnose? The diagnosis is through blood test, viral markers, through MRI, CT, X-ray, etc. What are the things that you can do to prevent non-alcoholic fatty liver disease and NASH? The things that you can do is reduce the consumption of alcohol, reduce weight loss. That is the weight. Mostly the deposition of fat is the main cause. So the reduction of visceral fat through weight loss is can be a good thing for non-alcoholic fatty liver disease. So weight loss and also providing hepatitis B and C vaccination, reduction in the consumption of alcohol can all be a good prevention and good treatment for NAFLD and NASH.
Any other medications?
Linagliptin, as OHA's linagliptin can be used for the reduction of NAFLD. And the main complication is cirrhosis and end-stage failure. Thank you.
Thank you. Can we have a member from Team E to step forward? Please use the mic to announce the number and the name of your topic.
Our topic is topic 23, thriftage hypothesis. Good afternoon. So my topic is thriftage hypothesis. Thriftage hypothesis is currently mainly in the type 2 diabetes and the obesity epidemic what we are seeing. It is an evolutionary hypothesis. So in the past, when there was a scarcity of the food during the famine, there was a scarcity of food and the mother who were pregnant at that point of time, the babies had a malnutrition. So there were some components, some genes which used to store the fat, which was important for the intrauterine development of the baby. But after coming out, when the extrauterine environment, when there is a full of a nutrition, and in the present time when there is a overnutrition, these genes are still storing the fat deposition, because they are used to that thing, that fat should be stored, and when there is a scarcity of the food, that fat should be used for the survival. In the present time, when there is over malnutrition, these genes are specifically causing the epidemics of the type 2 diabetes, hypertension, even the obesity. Some of the genes which has been studied, the one of the gene is PPR gamma, which can be work as a thrifty gene. Another hypothesis is also for the osteoporosis and hypertension. Because of the malnutrition during the intrauterine life, there is a less number of the renal glomerulonephri, which can lead to adult onset of hypertension. Associated with malnutrition, decreased number of the beta cell in the intrauterine life, which will lead to adult onset insulin deficiency. Associated with this, the leptin level will be less at the time of the delivery. When patient catch up the growth during the extrauterine environment because of the overnutrition, the fat deposition will increase, but the lean mass will not increase. This fat deposition will further lead to the leptin resistance, which leads to hyperphagia and obesity. So these are the hypotheses for the recent onset of the obesities and type 2 diabetes. So thrifty hypothesis has been used now to prevent, to research for the drugs which can act against this type of genes. So PPR gamma agonist is a one part of a thrifty gene associated disorder which can be prevented by the genes, but other genes are still in the research.
Thank you so much. Thank you. So that brings us to the end of round 1. So before we begin round 2, do the judges have any tips or clues they want to share with the participants? Dr. Vagish.
Discourage them. What you come with, just you present. But only thing I think when you present, you define the subject first, then go into the details.
Dr. Sanjay.
Observations. Whenever you're presenting, like Vagesh said, what is it? What is the clinical significance? What is the research in it? What is the future? If you divide it into 4 parts of your thought of a few seconds on each of that, then the clarity of thought will flow. This is my take on if you're doing a extempore like this. So you need to have introduction, clinical significance, probably if it's there, anything research, future, something like that. Depending on the topic, you can choose it into different compartments and your flow will be very good.
Thank you, sir. Dr. Pramila.
I think when you start off, it's always good to start off with the topic, as everybody said, but you all know about the topic. So it's not that you don't know, you all have been seeing it in your clinical practice. Even if you don't remember anything, because we may not know everything about every topic. It's not possible for everybody to know everything. So even if you don't know, you must have somehow put that topic into your clinical practice. So even if you talk like that, that also works. So try to put that thing into your clinical perspective and see how you have been using this thing into your clinical practice. And then if you talk like that, then also it works. So if you don't know the depth of it, if you don't know the genetics of it, doesn't make a difference. But if you know where it applies, it does make a difference. I think it's how you can do an extempore better.
Dr. Suman.
Well, we have a scoring of a body language also. So I would either feel that, make it more dramatic. People should really look at you so that looks more right.
Be so confident, keep the mic closer to and speak loud so people think you know everything. No, you're bullshitting. It doesn't matter. But be confident about it. Even if you're telling something inadvertently wrong, but be bold and make that statement right.
Okay, so thank you for all of that. So is it okay if we start round 2 with team E? Can we do that? Are you okay? Yeah, great. You can go. You have to brainstorm with her. Yeah. Yeah.
Topic number
Cluster classification. 14.
14. 14.
Please use the mic.
Cluster classification of diabetes.
Good evening, everyone. My topic is cluster classification of diabetes. This, based on the epidemiological studies, studies of diabetic patients, population could be divided into 5 different clusters. So first included severe autoimmune diabetes, SIAD, and second cluster was severe insulin deficient diabetes. Then the third cluster 3 included patients with severe insulin resistance diabetes. Cluster 4 was mild obesity related diabetes, and cluster 5 was mild age related diabetes. So the ones with insulin deficient and autoimmune diabetes were found to have very high risk of retinopathy. And the ones with insulin resistant syndromes were found to have more of nephropathy progression in the population. In the Indian studies, 4 different clusters were noted. One with similar severe insulin deficient diabetes. Next was insulin and insulin resistant IROD, called insulin resistant obesity with obesity diabetes, and mild age related and mild obesity related diabetes. So the patients with mild age related diabetes had better glycemic control of older population, more than 60 years, and they had lesser progression and lesser complications. And yeah, this was the clusters. This is just an epidemiological classification into, and which provides an insight into different categories of people and the risk of different population in risk of progression and complications in each of the population. And
Thank you, Teamy. We have team D.
Topic number 12, type 1 diabetes and associated disorders. Good evening, everyone. My topic is type 1 diabetes and associated disorders. What do you mean by type 1 diabetes? Type 1 diabetes occurs due to autoimmune conditions due to less C-peptide level and GAD positive. The diseases associated with type 1 diabetes are autoimmune conditions like thyroid disorders, vitiligo, frozen shoulder, rheumatoid arthritis, Turner syndrome, and in type 1 diabetes, the C-peptide level is low.
Thyroid condition is, you can tell us how common it is.
Thyroid conditions are more common associated with type 1 diabetes.
So is
And,
hypocommon or hypercommon?
hypothyroidism is most common in type 1 diabetes.
Any other autoimmune conditions in the GI tract which are also commonly associated with type 1? Which can cause
gastric
Do you want to close? Perfect. Thank you so much. Can we have team C to step up? Bolo yaar.
Hypoglycemic unawareness, sorry, topic 21.
21.
This is not syncing with this. This is what my cycle. 21. Topic number is not syncing. It's okay.
Come. On Madi. Timer on Madi, please.
So my topic is hypoglycemia unawareness. Hypoglycemia unawareness is basically defined as the occurrence of neuroglycopenic symptoms immediately before the adrenergic symptoms, which are the protective mechanisms that tells a patient that the patient is undergoing a hypoglycemic event, occurs before that. So directly without the adrenergic or the protective symptoms that help us, like sweating, shivering, tachycardia, and feeling of hunger and perspiration. All these symptoms are usually protective of hypoglycemia and tell the patient to go and do something to help the patient do something about the hypoglycemia. However, if these symptoms don't occur initially, and then it is immediately followed by the neuroglycopenic symptoms, which include seizures, coma, obtundation, confusion, all these symptoms, then the patient goes in for hypoglycemia. So what happens is one episode of hypoglycemia can trigger, can lower the threshold of when the next, can increase the risk of hypoglycemia as a second event. So the methods by which we can reduce the recurrent hypoglycemia, it occurs more commonly in type 1 diabetes individuals, but it also occurs to a certain extent in type 2 diabetes individuals. So what can we do to reduce the hypoglycemia and unawareness? Mainly, it is more frequent, probably for more frequent monitoring of blood glucose helps. The other method is for the patient to wear a CGM device and record the glucose more easily. Some of the CGM devices have an alert that algorithm which tells the patient that the event of hypoglycemia is going to occur beforehand, like half an hour or 1 hour prior to that. The other ways in practice in which we can reduce hypoglycemic awareness is one, to stop medicines that cause severe hypoglycemia, that is sulfonylureas and mainly sulfonylureas and reduce the dose of insulin. The other way is that we can change the insulin also to to analog insulins, which have a more which matches the endogenous insulin secretion more accurately. Or third way is by changing the long-acting forms of insulin from NPH to either detemir or glargine, or better yet, we can even change it to peakless insulins like degludec. Other than that, we can more frequently monitor blood sugars, and so these are mainly the ways we can reduce hypoglycemia and awareness.
Yes. Dr. Altaf, you're the only boy, so there might be some special points. I was just looking
Insulin
at all the
discovery.
photographs on the wall and about how there are no women.
Insulin discovery 6.
Okay.
The opponent is very happy reading the topic.
Timer on Muddy. 3-minute timer on Muddy.
Insulin discovery. So prior to discovery of insulin, diagnosis of type 1 was considered to be a death sentence. So the discovery of insulin is very interesting that it is clashes of politics, egos among the great scholars. So Langerhans was the first scientist who discovered that there is something being released from the pancreas, which is causing the reduction in blood glucose. Followed by that, Lenoid, Dr. Lenoid was a person who he ligated a pancreatic duct of a dog and then observed that the entire pancreas is atrophied, but not the islet cells. It was given, and he told about this in a talk, which inspired Banting to take up this topic. Banting was a young orthopedic surgeon. And while he approached the McLeod saying that, so I want to do this further. I want to do research on this insulin. I want to isolate that extract material. But McLeod was initially not interested, though as he was going out for a vacation to Scotland, he handed over his laboratory to Banting. Banting hired another student, that is Best, who was a medical student who was 21 years old. And later, both of them, through an innovative technique, ligated the pancreatic duct and isolated that pancreatic extract, and they have given to a dog, that is Marjorie. Marjorie was a dog which was pancreatectomized long back. When after giving that pancreatic extract, the dog has become better. It could walk, it could stand like that. So they thought that it could help, but that blood reduction in blood glucose was only short-lived. So they thought that larger extracts were required. So as to get larger extracts, Banting and Best went around the streets, stealing the dogs, stealing the cow's embryos so that they'll get large amount of insulin extract. Later, by the time McLeod returned, McLeod hired one more biochemist, that is Dr. Collip. Dr. Collip is a biochemist. Later, Banting and Best used their pancreatic extract in a small boy, that is Leonard Thompson, who was 14 years old, suffering from DKA, whose blood glucose levels were around 420. In the first shot, when they have given, they observed that there are multiple insulin abscess at the insulin sites. So it was Dr. Collip, who was a biochemist, who used alcohol to purify the pancreatic extract. And when they gave it to the Leonard Thompson, it improved, and he has survived for almost 14 or 15 years. And one more doctor has received this, that is Gilchrist. And in 1923, Banting and McLeod were announced for the Nobel Prize. Later, Banting was furious that McLeod did not contribute much. Later, Banting shared it with Best, and McLeod shared it with Best. That's how the insulin discovery had happened. And after that, there is so many insulins which have come, like oral, rectal.
Thank you for sharing that, Dr. Bharti. Can we have team A to step up? Please announce the topic number and name into the mic, please.
Topic 10, AGIs in pregnancy. Good evening, everyone. I'm here to talk about the use of AGIs, that is alpha glucose inhibitors in pregnancy. So alpha glucose inhibitors, these are drugs which inhibit the alpha glucosidase enzyme, which is involved in the absorption of glucose during digestion. What happens is these drugs such as acarbose, voglibose, and migditol, they inhibit the site where glucose is supposed to sit and, that delays the absorption of glucose. So the cleaving of polysaccharides and oligosaccharides is slowed down, and so this mainly helps in reduction of postprandial blood glucose. And so why these drugs were considered in pregnancy? Because they are absorbed very less into the mother's blood circulation, and therefore there is less chances of the fetus being affected by these drugs, and there is no proven teratogenicity, and it can be considered as a candidate to reduce postprandial blood glucose and achieve better glycemic control in pregnant women. But the studies are still underway. There has only been one study which was conducted in India, here in Chennai. It was done on pregnant women of gestational age between 16 and 32 weeks. And the results were that there was no teratogenicity observed in the fetuses, and there was very less absorption of the drug. There was very less placental crossing of the drug, and there were no observed side effects. It helps reduce the adverse effects of hyperglycemia in the pregnant women, such as macrosomia in the baby, intrauterine deaths, and other congenital anomalies that can happen when there is hyperglycemia. And that was acarbose. Only acarbose was studied. The other two agents haven't been studied. And thank you.
All right, thank you. So we'll give the judges about 2 minutes because we have a super fast and supercharged team of judges. They'll tell us who the 3 rounds, through 3 teams who will progress into the next round will be soon. And then in the next round, we again go through the same process of picking up a topic and doing an extempore for the same time of 3 minutes. So It's like you're using me as a filler, sir. It's like beach mein is like Nach Basanti, like that. So I would like to tell all the participants that there's a huge cash prize for all 3 places. And there's also a sorting hat trophy, which everybody gets. There's definitely a certificate of participation.
Teams, thank you for everybody for participating. All of you are winners. A big round of applause to all of them. It's not easy to come and do an extempore. I know it's difficult, though the topics will be given. Doing an extempore is always a difficult task. Thank you all for participating. Now, the teams which go to the second round are Team 2, Team 3, and Team 5. So that's it. Team 2, I think you know your names. That's Bharati and Rachana. Team 3 is Altaf and Nikita, Aishwarya and Pankiti. Yes.
Okay, if you're all set, can we begin the next round? Okay, so shall we start from Team B then? Should we make it interesting and give them 30 minutes for formulating thoughts? Sorry, 30 seconds instead of one. Sir. So, ma'am. Yeah. There are 2 rounds. Yeah. This will be faster because there are only 6, but I'm thinking, should we reduce the time for formulation to 30 seconds? Ma'am. Please tell us the topic. Okay. Discuss. Okay. Do I need to tell you about the judges? The judges are like, they can talk for like hours on the topic.
Weight loss and diabetes. So why is weight loss important in diabetes? Why is there so much hype around weight loss and diabetes? One thing is that recently it has been found to directly correlate with the remission. The more the amount of weight loss, the more the remission. That has been clearly told by the direct trial, which was done recently. Another reason why we should know is since we know weight loss decreases all the complications of diabetes. That is, one is glycemia, the requirement of hypertensive medications, the dyslipidemia, cardiometabolic risk, all are reduced by decrease in the weight loss. So coming to how much of weight loss should a person have? Ideally, it is recommended that around 5% of the body weight should be lost through either diet, exercise, or pharmacotherapy. That is, we can divide this weight loss into many categories, like one is just behavioral diet therapy, one is pharmacotherapy and metabolic therapy. So the diet, usually it is advised for people with BMI more than 25 or in Asians more than 23. Actually, diet is advised as a basic for all the people who are overweight or obese. That is, what kind of diet we recommend is a Mediterranean diet. What is the Mediterranean diet is more of pulses, legumes, more of olive oil, fish, and less of refined and processed foods. So also very low calorie diet can be followed. That is around 800 to 1000 calories. That is only done in a hospital setting with proper monitoring. Coming to pharmacotherapy, it can be like drugs like phentermine, topiramate, bupropion, and naltrexone. The most commonly we used in India is Orlistat. And another drugs which are proving efficacy is the GLP-GIP agonist, that is tirzepatide, which has been recently proven in trials for weight loss. And also the metabolic surgery, when it is recommended, is that when the BMI is more than 30 or 27.5 in Asians. Why we're talking about weight loss is because of one of the major trial, that is look ahead trial, which was done, that compared two groups. One was intensive lifestyle management and the other was the normal routine standard of care. What they wanted to study was the cardiovascular outcome. Was it different or not in both the groups? They did not find any difference in this primary outcome. Although what they found that many of the BP lowering drugs, the antihypertensives, antidyslipidemics, and the amount of drugs needed to control the glucose level was much less in the intensive group than the other group. So this was a very big trial which recruited almost 5,000 people. It was almost the longest and the largest RCT which was conducted in overweight and obese people for type 2 diabetes management. And it was shown in the direct trial that more than 15% of weight loss helped in diabetes remission. That is, more than around 85% of the people had diabetes remission when the weight loss was more than 15%. Also in bariatric surgery, around 30 to 65% of weight loss can be there with procedures like Roux-en-Y gastric surgery. And other things in metabolic surgery are sleeve gastrectomy, intragastric balloons like Reshape, Orbera, and many other new devices have been coming up for the weight loss. So the more the weight loss, the better is what is going on in most of the trials. Thank you.
Thank you, Dr. Rachna. Can we have team C? Your team C only. Please tell us the topic.
Topic number 17, use of artificial intelligence in diabetes management. So my topic is artificial intelligence in diabetes management. Let's start with what is artificial intelligence. Artificial intelligence is nothing but a science where they use computer systems to create, where they use the computer systems to create an algorithm or something which analyzes it like how humans analyze. There are two types of artificial intelligence. One is strong artificial intelligence and one is weak artificial intelligence. Strong artificial intelligence is similar to human brain, where it analyzes the data consciously. Example is Doraemon cartoon. Whereas weak artificial intelligence is specialized only in one subtype and it cannot make conscious judgments by itself. Example is Siri, what we use in our iPhone. So coming to the artificial intelligence in diabetes management, so it can be divided into 4 subtypes. One is especially for screening. So in rural areas where there are shortage of ophthalmologists, and also it is difficult for one doctor to see most of the patients, there have few devices have come where the machine screens the patients and tells whether the patient has retinopathy or no retinopathy. So so that device is called IDX device, which was manufactured and it was released in 2018. Then the second aspect in diabetes management with artificial intelligence is support, clinical diagnosis and support. So patients can use, with the help of the SMBG data and the CGM data, the data is collected and sent to the cloud. And with the help of the artificial intelligence, it helps the data comes back and where the patient is educated like how to manage his blood glucose levels. So there was a study where patients were divided into 2 subgroups, and one subgroup were guided with the help of healthcare professionals, and the other subgroup, artificial intelligence was used to guide the treatment. It was a non-inferiority study which showed that the data from the artificial intelligence was non-inferior to the healthcare professionals. And the third subgroup for where we can use the artificial intelligence in diabetes management is to risk stratification of the patients. So with the help of artificial intelligence, we can screen the patients who are at risk for certain conditions. And the other aspect is it also helps us to create algorithms and to guide the patient. One example is Guardian Pro, which was developed by Medtronic. So as we all know, we have also used artificial intelligence for the artificial pancreas study, where in type 1 diabetic patients, the data was collected initially about their blood glucose values with the help of a trial. And after that, this data was used to create an algorithm for the patient management.
Next round.
Good.
Please, team E.
Topic complete.
11.
Topic number 11.
Alcohol and diabetes. Yes, sir, topic. Sir, your talk work, artificial intelligence. What are you telling about? You're talking about it, right? The same thing, Siri.
Good evening. Now the topic is alcohol and diabetes. The permissible alcohol intake is 2 standard drinks for male per day and 1 standard drink per day for female. Okay. 2 standard drinks for male and 1 standard drink per day for females. Alcohol is beneficial when consumed in moderation of this limit. Yes. Alcohol is beneficial if consumed within this limit. Excess consumption causes deleterious effects. So coming to alcohol and diabetes, when consumed in a fed state, that is post meal, there can be hyperglycemia by alcohol. Alcohol inhibits gluconeogenesis and inhibits when given a choice to the liver, instead of metabolism of glucose, it prefers to dispose of the toxins first. So alcohol is preferentially metabolized and the utilization of glucose is affected, causing hyperglycemia. Also, during the consumption of alcohol, the person may binge eat without his knowledge, and that can also contribute to the hyperglycemia. When consumed in a fasting state, similar principle applies, and there will be a quick metabolism of the alcohol and inhibition of gluconeogenesis and glycogenolysis happens, predisposing the person to go in for hypoglycemia. After this, coming to the complications, on an acute basis, alcohol predisposes the diabetic individual to go in for ketoacidosis and hypertriglyceridemia, causing pancreatitis. Pancreatitis is a acute complication. Among the chronic complication, it increases the risk of retinopathy and neuropathy. Already predisposed by diabetic, alcohol adds fuel to the fire by chances of neuropathy and retinopathy. Another section which is important is drug interactions. Earlier, chlorpropamide, which was used for diabetic, would interact with the alcohol consumption, causing disulfiram-like reaction. And even metformin and glitazones, they are known to cause hepatitis with elevation of transaminases as an adverse effect. Alcohol aggravates this hepatotoxic effect of these drugs. It's beneficial when consumed in moderation, deleterious when consumed above the permitted limits.
Sure. Thank you. Thank you. So for the next round, shall we start with the same so that we'll give this time, we'll give you some time to recuperate. We'll start from that order because they've been relaxing.
Time in range and clinical relevance. So all these years we are relying mainly on HbA1c. Why can't HbA1c be continued for managing diabetes? Why can't it be gold standardized? Thing is, HbA1c can be like varied because of CKD, anemia, various hemoglobinopathies, or if the patient is under strict control the last 1 month, the HbA1c may come down. So time in range is increasingly trending because of availability of CGM. So what exactly is time in range? Time in range is the amount of time of percentage a patient glycemic glucose is under the normal limits. So there are various studies saying that the time in range is a better marker. So with every 10% increase in time in range, there is reduction in HbA1c by 0.5%. And not only that, what are the normative data for time in range? The normal individuals, that is type 2 individuals without any complications, the time in range should be between 70 to 80, being greater than 70%. And time in range for frail, for population who are having recurrent hypoglycemic episodes, it should be 70 to 180, greater than 50%. And for pregnant women, it should be around 63 to 140, greater than 85%. Not only that, HbA1c doesn't give us glycemic variability and glycemic trends, which directly correlates with the complications. Whereas time in range gives us a real-time data where we can see the clear-cut glycemic variability and glycemic trends. So for population whose time in range is greater than 70%, the HbA1c cut was around less than 7.5%. And there are there are multiple studies showing that time in range correlated with the complications. Few among them are, for population in a study, it has shown that populations whose time in range is greater than 80%, the diabetic retinopathy severity has decreased, and even the progression from NPDR to PDR has also decreased. In a population, they have correlated between the diabetic peripheral neuropathy and time in range, and time in range inversely it was inversely correlated with that of diabetic peripheral neuropathy. So that is, the greater the time in range, the lesser is the diabetic peripheral neuropathy. And in one more thing, in one more study, they have seen they have correlated the time in range and carotid media thickness. For every 10% increase in time in range, the carotid media thickness significantly decreased. And time in range also correlated with cardiovascular mortality and morbidity. So what are the fallacies of time in range? So CGMs are not yet completely validated. For suppose a patient is having hypoglycemia below a certain range, we have to cross check with SMBG. That is one. And the other is they are costly and not easily available in each and every center.
see.
Topic number 2, individualizing targets in comorbidities. So the topic is individualizing targets in comorbidities. So up until 2010, the way to treat type 2 diabetes mellitus was that it used to be a one size fits all sort of treatment where the same targets were given to almost all the patients. So the main watershed study that came up in 2008 is the ACCORD study. So that is the action against comorbidities in diabetes management. So what they found in that study was the investigators went into the study saying that a lower target HbA1c of 6 or below in the intensive group will yield better mortality outcomes later on. But as opposed to the other group, or the control group, which was given the standard treatment. So in the ACCORD study, with this idea, they went forward and did the study. However, what ended up happening was that these 10,000 patients were divided into two groups in this randomized control trial. They noticed that the trial had to be cut short by 17 months exactly because there was the increased death due to cardiovascular mortality was very high in the intensely treated group. So what we have to take away from the study basically is that it proved that this was the first study that proved that the HbA1c value should be catered to the patient, looking at the patient as a whole and looking into the comorbidities of the patient also. With the ACCORD study, hence we came to know that not every patient is the same, and that with every different comorbidity, you should individually see each patient as a whole and then plan the treatment or target the HbA1c or the sugar values. So, for example, the various situations in which this occurs is usually when conditions like CKD, where KDIGO as well as ADA criteria from 2023 states that the HbA1c should be somewhere between, can be as low as 6.5, but can go up to 8% also, depending on the patient's, the amount of comorbidities the patient has. Secondly, in old and frail elderly individuals, depending on their state of cognition, if they are otherwise normal type 2 diabetes mellitus patients with normal cognition, you can keep a good HbA1c target of less than 7.5. Whereas if their cognitive status is quite poor, or if they are bedridden, then the targets can be set at higher, respectively for around 7 to 7 below 8% HbA1c. And in bedridden patients, the best policy is to avoid hyperglycemia and not look at the HbA1c. In hospitalized patients can have targets, whether they are if they are very critically ill, the range is between 140 and 180 milligrams per deciliter. And inside the wards also, mostly we keep an upper level of less than 180. So other than that, yeah. So this is how you individualize targets in diabetes management.
The last team coming for the last round.
Role of EGFR management in diabetes. Number 3. So my topic is role of EGFR in diabetes management. So mainly the role of EGFR in diabetes management is when we are prescribing OHS to the patient. So usually what the first line OHS we are using is metformin. So metformin can be prescribed safely to the patient when EGFR is more than 45. When the patient has EGFR between 30 to 45, you should decrease the dose of the metformin up to 1 gram per day. And when patient is EGFR is less than 30, we should not add metformin freshly to the patient. If patient is taking some 500 milligram, we can still continue if there is no high risk of lactic acidosis. So some renal safe drugs are SGLT2 inhibitors, DPP4 inhibitors. So SGLT2 inhibitors, mainly empagliflozin, dapagliflozin. So dapagliflozin DAPA-CKD trial has shown it can be safely given even up to the EGFR of 20%. And even the empagliflozin can be given up to the EGFR of 20%. And they both have renoprotective action by reducing the microalbuminurias and even the cardioprotective action. So another group of drug DPP4, in which linagliptin drug, it doesn't require any modification according to the EGFR. Sexagliptin can be given a full dose up to, when the EGFR is more than 50. And when it is less than 50, it can given 2.5 milligram. But it should be avoided, that should be avoided because there is a high chances of patient going into fluid overload and cardiac failure. When we are prescribing sexagliptin, it increases the chances of heart failure. Sitagliptin can be given up to 50 EGFR full dose, and less than 50 EGFR, it can be given 50 OD. And another group of drug, insulin doesn't require any dose change according to the EGFR. And GLP-1 antagonists like liraglutide and dulaglutide, it doesn't require any modification according to the EGFR. And coming to the CKD patient whose EGFR are less than 60. So how will we manage the comorbidities with the CKDs? So first thing, for the prevention of the CKD and the progression of CKD, we should always use ACE and ERB when the patient has microalbuminuria. And when the patient has microalbuminuria of 30 milligram per 24 hours, even after the ACE and ARB, we should always prescribe the patient with the SGLT2 inhibitors. Even now, some newer drugs are coming on, that is non-steroidal mineralocorticoid antagonists like the Finrinon, which can be prescribed to the patient when patient is already on ACE, ARB and still microalbuminuria is not controlled. So that will further give protection to the microalbuminuria, and the cardiovascular protection is also there. And according to the EGFR, there is further comorbidities can also be associated. Like when patient is less than 30 EGFR microalbuminuria, that you can predict this patient has high chances of going into CV mortality, cardiovascular mortality. So all this protection has to be given when patient has lost EGFR is less than 60 and patient is in CKD group. According to the that even diet should be prescribed. Like patient already in CKD should have a protein content of around 0.8 to 1 gram per day. And according to that, electrolyte should also be measured. Thank you.
Okay, so while the judges take a minute or two to decide the winners and the order, congratulations to everybody who participated. This was not easy at all, we know. And thanks for being absolute champs and showing up and then giving it your best shot. Truly appreciate it. And we're hoping that we'll have more teams joining in the upcoming years. Is there anything else you would have liked to be different? Would the participants want to share their experience? Yeah. So we're waiting for the winners tally to happen. I think it's important to appreciate that everybody participated. So may I now invite Dr. Arvind and Dr. Bhavna to come up on stage to appreciate the effort that went into participation. So can we have team A to join us on stage? A big round of applause, please. And we have team B. Team C. Sure. Team D. Team E. और मुक्स पे टिका रहा है और जजेस मुक्स पे टिका रहा है सब done yeah we give the judges awards with this right after yes okay great thank you so much I'm going to ask Dr. Arvind and Bhavna to stay on stage. Judging this was not easy, I know. Thank you for showing up on a Sunday afternoon. May I invite Dr. Suman to come up on stage. Dr. Sanjay is already on stage. Dr. Pramila, please. And Dr. Vagish.
I also want to acknowledge Dr. Chitra here and thank you for being a good sport and wearing the hat for us. Apparently, it's not enough. Tree branch.
Should we invite the judges to do the honor?
Yes.
Yes. Dr. Sanjay, please.
Yeah. Yes. Good evening, everybody. I thank you. Everybody is a winner. Those who participated, a big round of applause to all of them. It's not easy. I know the difficulties of trying to do an extempore. I've been in this situation many times. This in competitions and debate extempore. Thank you very much once again. Now the judges, Dr. Suman, Dr. Vagish, and Dr. Pramila, Dr. Chitra for moderating, and the concept by Dr. Bhavna, Dr. Arvind, and a big round of applause. I think we all make it a little interesting. Probably it may get better with time. So the winners are the one who are in the third place, Aishwarya and Paniti. Please come. Right. Yes, and this is a cash prize to both of them. Thank you very much. The second place goes to Nikita and Altaf. Nikita, please come on stage. The winners of this first sorting out hat competition and this extempore is Rachana and Bharti. Over to both of you, please. Sure. I don't we get you something with. Thank you. Big round of applause, gentlemen, for all of them. Thank you. Thank you, everybody, for staying back. And
Right. Come on. All the participants on stage, please come. Dr. Chitra.
We had the boxes also for this one. Is it here? Right here? Get it out so that.
What is it in the box?
Yes, we're thrilled. No, sir, no. ಅವ್ರಿಗೆ ಲೈಟಿಂಗ್ ಸರಿ ಆಗ್ತಾ ಇಲ್ಲ, ಅವ್ರಿಗೆ ಐ ಸಿಗ್ನಲ್ ಕೊಡ್ತಾ ಇದ್ದಾರೆ, ಅವ್ರು ಕ್ಯಾಚ್ ಮಾಡ್ತಾ ಇಲ್ಲ.
Don't worry. Just finish the photo. Done. Guys.
Thank you.
Can give to them. It's okay. Thank you very much. I think that concludes the 10th edition of Adore, and we had something new. And thank you so very much for all the postgraduates who took part. And I hope you all had some fun reading it. The whole idea was to just read up and be familiar with the things, and extempore is always difficult. We are so used to looking at the slides and speaking, but I think you all did a splendid job. I mean, there were 25, 26 topics given, and then I'm sure every month we can have this kind of a competition going on. So everybody is ready before the examination. Thank you very much. Have a safe day. Have a great evening, and see you all again next year, or maybe more often in months to come or days to come. See you all. Bye-bye.
Bye-bye. One more.